Καλημέρα σας.
Good morning. Please be seated in order to begin. Commissioner, dear speakers, dear friends, welcome to the first conference of the first day of the 10th annual conference of ELLOK, named People at the Center, Bridging Pathways of Care. This is a very particular timing because this year ELLOK is celebrating its 10th year of dynamic presence and representation of oncologic patients, cancer patients. We will focus today on strategic cancer planning. We will talk about HTA, we will talk about the National Cancer Plan and the integrated comprehensive pathways. With the participation of the Greek society, the scientific community, the European Union, we embark on a constructive dialogue in order to build a people-centered healthcare system. The 10th annual conference of ELLOK is under the auspices of the Ministry of Health. Also under the auspices of Union for International Cancer Control, European Cancer Organization, OCAN International, Association of European Cancer Leagues. It is also under the auspices of the Medical Oncologists of Greece, the Hellenic Society of Medical Oncologists, the Hellenic Hematology Society, the Hellenic Urinology Society, the Hellenic Nuclear Medicine and Medical Imaging Society, the National Association of Hellenic Nurses, and the Health Visitors Association. Also, the Association of Pharmaceutical Companies of Greece, the Pan-Hellenic Pharma Industries Association, the Hellenic Association of CROs, the Hellenic Documentation Center. The official media partner is the Athens Macedonian News Agency, and our sponsors are Armatura, AstraZeneca, Brains, CMT Προοπτική, Gilead, MSD, and Servier. The gold sponsors are AbbVie, Bayer, Bristol Myers Squibb, Coronis, Elpen, Genesis Pharma, GSK, Integris Pharma, Johnson & Johnson, Merck, Papapostolou Varia, Swix Biopharma, Pharmacet Lilly, and Win Medica. Silver sponsors are Affidea, Anaviosis, Boehringer and Ingelheim, GE Healthcare, Ginkor, Gnomon Informatics, HIPAA, Ipsen, Nova ICT, Novartis, Pfizer, Roche, and Takeda. Communication partners are Vuli TV, All About Health, Capital.gr, Daily Pharma News, Health Daily, Healthmark, Health Pharma, Health Update, Health Web, Iatronet, Medley, Health Next Generation, OnMed, Plan B, Daily Health, virus.com.gr. Our audiovisual partner is Connect Hellas. We also would like to help the volunteers from Alma Zois. Now I would like to give the floor to the president of the Hellenic Cancer Federation, ELLOK, Mr. Giorgos Kapetanakis, for his opening remarks. Commissioner, dear friends, ladies and gentlemen, welcome to the 10th annual conference of the Hellenic Cancer Federation. This year, we don't simply meet to have our 10th annual conference, but we want to look back, to take a look at the future and prepare for it. 10 years of ELLOK, 10 years of collective voices, 10 years of maturing, 10 years during which patients stopped being passive recipients, but they started participating in their healthcare plan. During these 10 years, we've tried to put the patients around the same table as the healthcare sector and the Hellenic state to co-shape the national healthcare plans, to highlight the experiences of patients and make it part of the oncological care. We also want to focus on the gaps that exist, which we are trying to fill in, because if we want to be honest, and we have to be honest, challenges for patients are still structural. There are still inequalities when it comes to access. Geography, income, information, and red tape continue being risk factors. Continuity of care after the end of treatment is, to a large extent, missing, and the burden is put on the patient and the families. But at the same time, our country is in the midst of a huge transformation of cancer care. There are important initiatives on the part of the state. The scientific progress, data, digitization of healthcare services, and new technologies create new opportunities. And we have to tap on these opportunities, because unless we do that, we will stop asking whether there is innovation, but we will be asking who has access to this innovation. Because without coordination, without interoperability, technology will further deepen inequalities instead of eliminating them. So the OCAN initiative is a historic opportunity for Europe, an opportunity to invest in prevention, early diagnosis and data, to align national policies with European quality and accountability standards. But today, in an environment of increasing uncertainty, both in Europe and all over the world, it remains to be seen what will stand in time. Patients don't need plans that change when the political leadership changes. And this is why ELLOK's role is crucial, because we are the national hub for cancer and we can act in many ways. We can be the bridge between the European strategy and its national implementation. We can act as a mechanism that transfers patient experience in policy making, and we can act as guarantors that people will be actually at the center, because the success of a healthcare system is measured by whether there is equal access, whether they are not lost within the system, and whether they are not alone after treatment. And we will discuss all these topics in today's conference. We are not going only to focus on what we've built in the past 10 years, but what we need to build for the next 10 years. So, welcome to our 10th annual conference. Thank you for your presence, and thank you for your support in our work all these years. Thank you very much. Now I would like to give the floor to Ms. Stella Kyriakidou, former Commissioner for Health and Food Safety in the European Union. Ladies and gentlemen,
it's a great pleasure to be here with you today. If you'll allow me, I will give my very short introductory remarks in Greek, since I am here, and I'm sure that you can follow with your interpretation. Αγαπητοί
Dear friends and colleagues, ladies and gentlemen, for me it's a big honor and I feel emotional being here today in the annual conference of the Hellenic Cancer Federation, the 10th annual conference. And first of all, I would like to congratulate the Federation, the President, and all the members of the board for their ongoing work, for your ongoing presence next to patients and their families, and for the decisive part you've played in shaping a more human and more just cancer policy in Greece. The title of the conference, People at the Center, Bridging Pathways of Care, is very relevant in these difficult times we've been living today, where everything is under doubt and where resilience in building policies becomes ever more important. The World Cancer Day on the 4th of February is a day of memory, of awareness raising, and of actions. This day reminds us that behind each diagnosis there is a human being, there is a family, there is a life, a story. And this means that we have to treat cancer not only as a medical challenge, but as a social and political priority. As former Commissioner of Health and Food Safety in the European Union, and as a person with a personal experience, I know very well what it means to be on the patient side, to live in uncertainty, in fear, and to have the need for hope, dignity, and support. And this experience has shaped the way in which I perceive healthcare policy. Because when we talk about cancer, policy and politics cannot be distant. They have to have a face and a heart, clear targets and specific policies and actions in place. During my mandate, I had the chance to travel throughout all member states of the EU and far beyond. In all my visits, I made sure to visit cancer hospitals and care centers. I talked to patients, families, healthcare professionals. I listened to many stories of deep inequality, stories of strength. I saw firsthand how different the chances of a person can be depending on where they live. And this enhanced my conviction that healthcare is a right, not a luxury. And this is precisely why, in the context of the European Cancer Plan, we established for the first time the Registry of Inequalities in Cancer. This tool records the differences and inequalities in prevention, diagnosis, treatment, and survival, because only when we are aware of inequalities and we can measure them, we can truly address them. This is a plan which has a budget of 4 billion euros. It has clear targets, a clear timeline, and it is built based on European strategies. Because even though health is a competence and responsibility of member states, the pandemic showed us how much we can achieve when we join forces. Ladies and gentlemen, cancer does not test only our body, but our soul as well. Anxiety, depression, mental fatigue, fear have an impact on patients and families alike at all stages of the disease. This is why, in the plan that is already being implemented, we stress the need to integrate mental and social care in cancer care, and this should not be a luxury. And this care should be holistic and human-centered. In the same spirit, palliative care is a fundamental right as well. Palliative care is not only about the end of life. It concerns all stages of the disease in order to alleviate people from pain, from agony, from symptoms. Dignity, care, and respect know no time limits, and they have to be ensured for everybody. The next day is equally important. Those that have cancer experience know that survival is not the end of the way. Reintegration in the workplace, in the social and economic life, without discrimination and without any stigma, is a key element of a modern healthcare policy and strategy for cancer. The right to oblivion and the support during recovery is an act of respect. This is why we are all here today. It's hugely important to continue having cancer care and cancer policy as a top priority. The European Cancer Plan has already led to changes in many member states, but there is still a lot of room for improvement in order to achieve our objectives all together, because in this fight there is no one to spare. The progress we've made should not be taken for granted. We have to continue the same efforts, and this is a matter of responsibility, of equality, of humanity. I know that this path is not easy, that the fight against cancer is not only a fight for more years of living, but years with quality of life, with equality and hope. And we have to continue this fight together. I wish all the best for the works of this conference. I'm very happy that I'm here yet another year. Thank you. We would like to thank Ms. Kyriakidou for her presence here today and for her opening remarks. And now I would like to give the floor to Mr. Joao Breda, Head WHO Athens Quality of Care and Patient Safety Office and Special Representative for Greece.
Kalimera, that's, I promise, the only and last word I can say in Greek. But it's improving, I promise. Thank you very much. I would like to express our gratitude to the organizers, particularly to ELLOK, but also, if you allow me, a word of appreciation for those who represent patients and people living with conditions related with cancer. Also, I see in the room many of my dear friends that work in the area of prevention, treatment of cancer, clinicians, and that's very important. And of course, it's very important to have policymakers in this room, to have a constructive discussion to see how we can move forward with this ambitious, let's say, agenda that we have for cancer. And it's very encouraging to hear. I try to understand your words in Greek as much as I could, and it's really very important to acknowledge that there is great motivation and interest from across the board, from current and past policymakers, to work together in addressing this challenge of cancer. So I think we're at a comfortable and good, let's say, point, but much more needs to be done. We all acknowledge that we are not there yet, and that many things could be improved when it comes to cancer, from prevention to, I would say, long-term and palliative care. But thank you very much, and congratulate all the organizations that are here in this room, because it's really important that we work together to advance policies in this field. And also, I think it's really a great milestone that this organization is basically representing the voice of patients and advocating for cancer action from prevention to long-term care from a systems perspective. We see a lot of actions, many times in isolation, and we advocate that many times we need more collaboration, better coordination, and action, like as if we are in a very good orchestra. Not always the orchestra plays very well, even if you have great musicians in the room. So I think that we need to acknowledge and we need to recognize that we all together, maybe collaborating more, we can do more for patients and to really address the issues of cancer. I also believe, we believe in WHO, that the way we deal with cancer from prevention to long-term care is really an ultimate test, is the test to see how people-centered and really equity-focused our health system is. We can see the gaps. We can identify the challenges. We can also celebrate success. But really, particularly in rich countries, in EU countries and Greece, whether you like it or not, you accept it or not, you have to agree with me that we live in a privileged place compared to many other places of the world. And obviously, you need to have a cancer system that excels. And there are many things to ensure that the system really excels, because we are in a privileged situation in not just in the context of the WHO European region, because we have 53 countries that include all the EU 27, plus a few others, and all the Eastern European region countries that in many cases have systems which are not as developed as the one you have more in let's say, in the EU countries. So we have to acknowledge that we have to do more, and we have to be more ambitious. And I think this is very important for Greece. Why is it so important for Greece? Because in spite of all progress, cancer remains very high in your country, in my country as well, if I may say, because it's the country where I'm placed, and I'm very proud of having a duty station here in Athens, where, with the support of the Greek government since 2021, basically almost 5 years, we have established a unique initiative, which is the Athens Quality of Care and Patient Safety Office, which is the only, globally, the European region is the only that features an office fully dedicated to quality of care and patient safety, and it's based in Greece and with the support of Greece. So I would like to thank all the Greeks and the Greek people for this collaboration. I myself, I met already 4 ministers of health, and you can see that, I mean, this is a collaboration that cuts across and has been ongoing since 2013 very intensively, and has accelerated very significantly in the last 4 years. And when it comes, of course, to quality of care and patient safety, non-communicable diseases, chronic non-communicable conditions, and obviously cancer, one of the most important, where sometimes quality could and should be dramatically improved. So Greece has more than 60,000 new diagnoses of cancer, as you know. The incidence is slightly below the EU average, but for example, the mortality decline is slower than most EU countries, and the mortality rate is also slightly above the EU average. So, I mean, there is progress, but the data for Greece, it's not something we should be tremendously proud of. There is a lot of opportunity for improvement when it comes to cancer in Greece. There's serious inequalities. Men, in many cases, are worse than women. They have worse outcomes for several reasons. We wouldn't need to go in details here, and you will discuss it during the conference. There are also, in WHO, we are very keen about addressing risk factors, alcohol, but especially tobacco, and of course, unhealthy diets. Obesity is very serious in Greece. You are the second country after Cyprus with the prevalence of childhood obesity, and also in adults the prevalence is very high. Obesity has been identified by WHO, IARC, and others related with 8 cancers at least, and therefore if you don't address the elephant in the room, tobacco, right? This is very serious. Greece is the country in the EU where vaping has increased the most. The first one is Serbia, not yet at least part of the European Union, and Greece in the EU is the country where vaping has increased more. I would urge all of us to think about why. Why is Greece leading the increase in young people in vaping? We cannot accept that this is something we need to conform with and we need to live with, right? So, 25% daily smokers. It's going down slightly, but vaping is increasing. And vaping is not being used, novel products are not being used by smokers who want to quit smoking. I'm sorry. You all know it's not the case. Vaping and new novel tobacco products are being used by young people, your adolescents, 13 to 15-year-old, at the front door of your schools, your secondary schools. I see it every day. It's not acceptable. And we know the reasons, and those need to be addressed. Also, obesity, of course, very serious issue and very tremendously related with cancer and all of that. One of the things I would like to also highlight is the strong social gradient. So cancer is also an issue with the equity and inequalities in terms of access, in terms of quality of care and all of that. So we really need also to take that into account. In Greece, particularly with your geographic challenges, which are unique, the beauty of your country also comes with some challenges which are, of course, related with that geography that no other country in the EU has, and that makes it, of course, more difficult. So sometimes I become very upset when people point that Greece is sometimes at the top of the negative, let's say, data, but people need to understand why as well. And as we understand that there is a lot of things that we can improve, the challenges are also very big. I would also like to highlight the challenges with access and quality of care, the shortages in the workforce and burnout of the workforce, waiting times, and even service distribution. I talked about that. And of course, the also out-of-pocket element, which is important in Greece and we need to address. So it's really, let's say, a system issue, and we would like to address it from that perspective, and I commend the organization for doing that. Therefore, we in WHO, we focus on resilience, quality, patient safety, and equity, and we really would like to strengthen the idea that we need to focus on the entire cancer pathway from prevention to survivorship. And here, there are many innovations that we need to adopt, of course, from medicines, but also from behaviors. Physical activity has a tremendously positive impact in cancer survivorship. And we are not using those things enough. We have to use it more. And I would like to really propose that we have discussions on that as well. Here in Greece, WHO has two. So we work with on quality of care directly and more or less intensive way with 24 countries with the help of Greece. And also we have a collaboration that is directly with the Ministry of Health and with Greece. Basically, two projects, one of them which is called Health IQ, which is looking into quality of data, is developing an information system that is now unique and will be launched soon in March. For the first time, it will place Greece really at the forefront of having indicators coming from a series of sources and really put all together from a quality perspective that we believe can really inform policy development. So the Health IQ is a milestone, and having this information system that will include a lot of data on cancer for the first time, I think is commendable, and we are grateful to work with the Ministry of Health on that standardization, patient-focused indicators, all of that will be there. We've been also working with the Ministry of Health and with the health regions on improving primary health care. And we also have to understand that PHC plays a very strong role when it comes to cancer. This is true. This is not a specialist field only. We need the specialists, but everything starts even before primary health care when we really implement public health measures, but then PHC plays a very, very strong role, and I think there's a lot of room for improvement there. So here we're also working with the Ministry of Health, and I would really like to underline these two messages, that we need, what gets measured gets done. This was a former WHO Director General, let's say that she used very much, and I really like. We believe that health IQ is going to have that contribution here in Greece, and also we believe that strong primary care also saves lives from cancer, and we really need to play that card as well. We fully align with as I finish, with the objectives of this Congress, the National Cancer Plan, the National Registry, the digital transformation, your focus on inequalities, the innovation aspects you are going to discuss, the linkages with the work being done at the European level and the work in other countries, and the European Cancer Mission. So all of that is very important, and I really think that, as I close, just to say that perhaps it's time to focus a bit more on prevention and address those issues which are really important, a bit more focus on the equity elements, and really on higher quality data. So I think that together we can do more, and this is why WHO is here. We will always be here with you, and we hope that we can advance cancer, addressing cancer from prevention to treatment. Thank you very much.
Thank you very much, Mr. Breda. Θα ήθελα τώρα να προσκαλέσω...
Now I would like to invite Mr. Konstantinos Toutozas, a professor of cardiology, responsible for the office dedicated to structural cardiopathies and cardio-oncology at the first University Cardiology Clinic of the Hippocratean Hospital, and president of the Hellenic Cardiology Society, to take the floor. President, organizing committee, I suppose you must be wondering what a cardiologist is doing at a conference organized by the Hellenic Cancer Federation. Thank you very much for the invitation, by the way. It's a great honor. Hellenic Cardiology Society, for all of you who don't know, is among the oldest medical societies in our country, and numbers more than 4,200 members, and it is perhaps the biggest scientific medical association in our country. What is it that connects us to cancer? First and foremost, bad statistics. We have CVDs, cardiovascular diseases, that constitute the number one cause of death in our country, Europe, and the world over, generally speaking. And number two, cancer in our country and in other countries. So this is bad statistics. The second element that unites cancer, or rather links cancer to the heart, apart from the psychological parameters that the Commissioner mentioned, regards the management of cross-reaction between treatment and effects, whether we're talking about chemotherapy, radiology therapy, and the effects related to cardiological functions. We know that the progress made in cancer management, and we have survivors, many of them either at an early stage or very late stage, after 20 years, for example, manifest cardiological problems that we are called upon to tackle. And in fact, the behavior of certain patients is anecdotal, or it sounds like a joke. When you ask them if they've been through a disease in their lives, some of them have forgotten about cancer altogether because they underwent radiation 20 years ago. However, this is a reality that shows the progress made in the management of cancer, but on the other hand, it reflects the late onset cardiology problems. That's why we have cardio oncology departments in Greece and the world over. There is a new specialization. I started this office in the year 2012 in our hospital. We started the first such dedicated clinic, the first in Greece and one of the first in Europe, and now we have a blooming discipline regarding conferences, funding, research and interest all over the world. There are dedicated journals under the umbrella of the European and the American cardiology associations, focusing precisely on the field of cardio-oncology. The third element is the pathophysiological route that bridges these two entities. We have common risk factors: obesity, it has been mentioned, smoking, conventional smoking of new kinds, such as vaping and similar modes of smoking. Unfortunately, in our country, there's been an increase. We heard about it before with the new smoking products. We have an increase. And the problem is that, first and foremost, vaping concerns very young people, and we have to manage this social and economic problem. Finally, I'd like to say that this common problem that we have now for these patients suffering from both cancer and cardiological problems is exacerbated because the population is increasing. We follow your organizational structure on a European level. On the 16th of January, we announced the first EU plan for the prevention of cardiovascular diseases in the European Union until the year 2040. The target is to lower rates, mortality from CVDs to lower than 4 to 5%, including diseases related to cancer. And within this framework, we're open to every collaboration, research, clinical trial. Already, we launched a big clinical trial, multi-center, that will be published shortly, manifesting that the amount of clotting thrombosis is 8% and arterial problems reaching 5%. So 1 out of 9 patients with cancer will face a problem of thrombosis of some sort. So we have major problems that we need to examine in common. We're open to collaboration, and we hope that you'll have a very conducive and prolific conference. And looking at the agenda, I'm sure this is guaranteed. Thank you very much. We would like to profusely thank Mr. Toutoukas, and now I would like to call to the floor Mr. Giorgos Patoulis, who is the president of the Athens Medical Association. Dear members of the audience, ladies and gentlemen, President Mr. Kapetanakis, first of all, I'd like to thank you for the invitation and say that according to the World Health Organization, and as Mr. Toutoukas said before me, following cardiological causes of death, one of the most frequent causes of death is cancer-related death, and every year about 20 million people manifest cancers of different kind. It is certain that today is a special day in the sense that it will be bridging the academic community with patient associations and all state policymakers so that we can advance our efforts following common steps. The Medical Association of Athens is actually oriented towards the intention to prevent, by means of screening and lifestyle modifications, the appearance of disease for the people of tomorrow. and reduce the numbers of people that will have cancer. And science has equipped us with the necessary tools. We can eradicate bad habits like smoking, which was mentioned, alcohol consumption. But apart from that, I believe that screening that can be performed targeting gender and age groups vulnerable to specific forms of cancer constitute the best approach, because prevention is indeed far better than treatment. In this sense, the programs which have been included under the umbrella of the Προλαμβάνω program here in Greece, which means prevent, have been a coordinated effort to that end. And this can truly make a difference in the safety of today's citizens, tomorrow patients, and to truly lead to prevention of disease. Obviously, science has reached very high levels, surgically speaking, through the use of robotics and chemotherapy modalities and medicinal products, radiation treatment. However, prevention and screening are key to reducing the likelihood of losing lives because of cancer. And for this purpose, dear President, we'd like to congratulate you on this initiative as well. On the 4th of February, the last day of the conference, we'll be remembering the World Day of Cancer, and this will be a reminder for all of us of the fact that we need to join forces. That's why I believe that the title of the Congress is indeed very, very apt. People at the center, building bridges of care. Academic communities, communities of experts, associations of patients, citizens, all of us need to join forces so that we can create in Greece, in the land of Hippocrates and the land of health, the best possible conditions for every person alive, ensuring that they can deal with cancer in an equitable way. Thank you very much. I wish you all the best for your conference. We'd like to also profusely thank Mr. Patoulis. We'll have a slight change. We'll need to postpone the key lecture for a little bit later. I'd like to invite Mr. Yorgos Mariatidis, Head of Sector EU for Health Grants and Cancer, to undertake the moderation of this panel discussion. Thank you for the microphone. Good morning to one and all. I'm very glad to be in Greece today in order to talk about beating cancer. I'll make the introduction in Greek. When we have some foreign guests, you will allow me to address them speaking in English. We have a very nice panel organized with the other George, Yorgos Kapetanakis, who is the president of ELLOK, the Hellenic Cancer Federation. And let us start with a short video, Matti Apro's video. Okay, let's invite everyone here. Let's invite Mr. Mark van der Bulke. Mark, are you here? Mr. Nikolai Koncharenko, Mr. Nikos Arkadopoulos, Mr. Olympios Papadimitriou, Mr. Kyriakos Souliotis, and Mrs. Anastasia Gotzi. Please join us. Let me say a few things about the framework of this session and what it is that we'd like to achieve, and we can start with the video of the only guest who has not been able to join us due to something unexpected that cropped up. Okay, so let us start. Invited to the 10th conference organized by ELLOK, we thought about building a bridge, as the title of the meeting is, to build a bridge between the National Cancer Plan and the European Cancer Plan. Mr. Kapetanakis and myself and everyone here knows Mr. Kapetanakis has dedicated many years of his life trying to make sure that ELLOK can reach the state that it has today, to be the National Cancer Hub for Greece. The National Cancer Hub is an idea that is part of the European Beating Cancer Plan, and we heard Mrs. Kyriaki, the former commissioner who was behind this political effort. The effort is related to important European funds. Yes, precisely. Well said, but let me make an introduction for you, dear George, so that people get to know you. Mr. Yorgos Mariatidis is head of sector EU for health grants on cancer, NCDs, mental health and rare diseases, and health workforce. I believe that you are based in Strasbourg, and you have a wealth of experience from the past, because you also served the national health system here in Greece, isn't it? Yes, precisely. So we have something linking the past, the present and the future. The title is convoluted, it's rather long. It means that in the end, we sign agreements for financing national action plans in order to beat cancer. Now, I'll ask our technicians, before we embark on the conversation, to upload the video of Mati Apro, who has not been able to join us today. He's the president of Sharing Progress in Cancer Care, SPCC, and board member of Union for International Cancer Control, UIC. And Orcan International, in fact.
Ministers, professors, honorable guests, and above all, those of you representing patients in the audience, apologies for not being with you to celebrate 10 years of the Hellenic Cancer Federation. The reason is very simple. One of my very dear friends just lost his mother. I have to be with him and his family in these very sad days. ELLOK has done a fantastic work in the last 10 years. It is impressive, it is recognized, certainly in Greece, but all over the world, and I'm certain that many representatives of outside of Greece will be there saying what example ELLOK has given to them and to the rest of the world. The times that we are facing are difficult. They are difficult certainly in Greece, they are difficult in Europe, as will be discussed a little bit later during this conference, and they are very different worldwide. We have to bridge the gap between the various systems that help patients, and this is one of the themes of Orcan. This is a great theme that is the center of the work of ELLOK. So I wish you a 2.5 days of intense collaboration so that we all together can face these difficult times, find the solutions that are adapted, and continue to help patients in Greece, in Europe, and worldwide. Good work. Apologies again.
We would like to profusely thank Mati Apro, who cannot hear a round of applause, of course. So the bridge today is a link between the European plan and the financing that it represents. This slide is merely a background reminding us that up until now, almost €500 million has come from the public health program of the European Commission, and we are not talking about the funds channeled to research from Horizon Europe. So we have very strong funding for trans-European networks and collaborations that give member states the tools and good practices required, validated solutions in all sectors in order to beat cancer in all its dimensions, starting from primary care and going up to survivorship, as we said before. We have the luck to have people who have survived for 10, 15, more than 15 years, having been through this ordeal. When we were kids, when people heard the word cancer, they saw a tombstone. They thought that this was the end of their lives. So great progress has been made on a European level, on a societal level, financial level. And Mr. Kapetanakis, perhaps, will be able to say a few words regarding the Greek framework, the political framework, because the bridge regards the link between what Europe gives member states and what member states themselves can do. Because as Mrs. Kyriakidis said, the cancer policy is a national policy. And of course, there is a role for the European Union, but it is the member states themselves that will change things. Indeed. Let's welcome Mr. Souliotis. All of us are here. We've known one another for a long time. Indeed, Mr. Mariatidis talked about what has been happening precisely and how much the European Commission has tried to help establish a new framework, generate new national strategies by providing central guidelines. Where do we stand here in Greece? What is the state of affairs in cancer? We are not starting from scratch. This is not point zero. We're not there. Many steps have been taken. We have screening programs. We have programs that ran the previous years, and they introduced prevention for people. We didn't used to have them in the past. We have new frameworks regarding access to innovation with the very well-known obstacles that we know, and of course the big contribution of the pharma industry, the new framework for authorization and reimbursement of biomarkers that passed recently as a law and will start working hopefully soon. We have the digitalization of health services. Only last year did we acquire a new malignancies registry on a pilot application, and within the year there will be a general application. Digitalization of 12 CCCs and creation of oncological patients' files, electronic files, and there is legislation and framework enacted for palliative care. However, the implementation has not started at full speed. Initiatives have been taken, things have started, but these things are perhaps not interconnected as they should. Perhaps there is not enough interoperability, and we don't have the maximum effect yet. So this is more or less the state of play. And through the instructions of the European Commission, it is a great honor to have Mrs. Kyriakidis here with us today, former commissioner. She's the person who inspired many of us and all the member states of Europe, I would say, to turn the eye to cancer, and through these programs to manage and create the requirements for the development of national strategies. Why are we talking about prerequisites? Because these programs lead to pilot application, and there will need to identify challenges so that pilot applications can scale up and have a horizontal effect on the system. Dear George,
we will have two rounds. We will have two rounds of questions, and the first question is addressed to all panelists. Based on your experience, whether national experience or EU experience, which are the challenges, the barriers in shaping a national plan, a national strategy, whether a plan or a strategy? I know these are two different things, but they're both political vehicles in order to make a change. So now I would like to give the floor to Mark van de Bulke.
Embedded in the National Cancer Institute the National Public Health Institute of Belgium. He participates in many joint actions, and he's in touch with other member states. So let's take Belgium as an example, and your experience in the National Cancer Plan, challenges, limitations, barriers.
Yeah, thank you very much. I would like to thank the organizers to give us once again the opportunity to explain a little bit how we try to approach in Belgium the introduction of national cancer plans, national strategies, because we had both already. We had a national cancer plan, I think, from 2008 till 2015, and then we considered that all the measures that we had proposed and all the activities that we had to propose in the plan were implemented. And then there came a gap where we identified some gaps in what we did. One of them was personalized medicine, one of them was survivorship, and we made a strategy focusing really on these gaps. Now, and I think it comes after COVID, COVID's changed a lot of things also, raised a number of things that we saw that we were missing. We came up with a new strategy in the first 2 years of our Minister Frank van den Broek's term, because there was not enough time, but now we're working on a new plan. So we're going to address, again, a plan format. Accessibility is going to be important. Quality of life is going to be important. Data is going to be, innovation is going to be attention for children and adolescents and young adolescents for cancer, and then rare cancer. So there's a number of spear tracks that we're going to look at. And very important is has been the interaction over these 4 or 5 years with the EBCP plan. Really, that has fostered in Belgium the installation of what we call the mirror group, the EBCP mirror group, 400 institutions, so organizations that are dealing with cancer are represented in the mirror group, and they are now going to help us. They first of all helped us to identify what should be covered in the plan, so we're working on that now. We're going to write it. And then the difficult exercise will, of course, be to find budget. We never forget that you need budgets to do something. But then the stakeholders, the people that worked with us during the EBCP period, are now going to be the ambassadors to implement, because it's them who have to implement. So there's a really very interactive exchange of what you want, what you need, what Europe can do, what Europe cannot do. So this will continue. We will continue with the mirror group. We will continue to give information to the Commission. We're constantly working together with the Commission. And I think the next big thing in Belgium now is going to be the CCCs, because the comprehensive cancer centers, the network, we really believed in that. I think several of you were in Paris. I think everybody saw this is going to be a real instrument for bringing, let's say, better cancer care all over Europe. So that's more or less where we are in Belgium.
Very well, thank you, Mark. And now I want to pass the floor to our friend Nikolai Goncharenko. Nikolai is the director of the Institute of Cancer to Cancer from Luxembourg. So, Nikolai, you have 10 years of experience in your institution. Actually, we have the same anniversary, more or less. So, please share with us your experience from these 10 years of working towards developing cancer strategy, and what are the barriers and what you could do in a different way if you were in the beginning again?
Kalimera, good morning everyone. Thank you very much for your invitation. It's a pleasure to be here in this distinguished audience and to have the discussion about the cancer control programs. So indeed, we have just celebrated our 10th anniversary in December, so it was 10th anniversary of the National Cancer Institute, which was created, by the way, within the first cancer plan. So I would like to just make a bridge to what Mark has said about the National Cancer Plan. So actually, we're at the end of our second cancer plan. The first one was 2013 to 2018, and now it's 2020. Was supposed to be until 2024, got disrupted by COVID, so we're still continuing until the end of this year. Of course, our cancer plan has started before the European Cancer Plan, Europe's Cancer Mission came into force, so we had to do some adjustments and some alignment afterwards, but we have seen that actually our cancer plan, which was quite comprehensive, covered already many of those dimensions. So it was more about tailoring and making the links between the European developments and our national activities. Just to go also back at 10th anniversary of INC, our National Cancer Institute, which was created within the first cancer plan, it was a very interesting experience because Luxembourg has despite being a very small country, it has a majority of different, a broad spectrum of different stakeholders, which used to collaborate, but not to a sufficient degree. So one of the challenges was actually making people work together across institutions, along different profiles, through different work groups and collaborations. And I think that was one of our biggest achievements. And all of that happened within the first cancer plan. Now we're sort of a more mature institution, which is covering all dimensions of care. And also, in a way, we're engaged in social activities and social projects. But now we're actually looking at how to move forward next. So, and as we're approaching the end of the second plan, we actually thought, okay, now we have a different possibility of continuing this work, which will be carried over by our institute directly on a project-per-project basis, integrating the European dimension and seeing where are the gaps and which steps need to be undertaken to actually improve care sector by sector. Finally, I wanted to highlight that Luxembourg is one of the smallest countries in the European Union, and as some of you know, we have a group of small member states who are collaborating on the questions related to cancer. So currently there are a few of them, so Cyprus, Malta, Luxembourg, Baltic states, Latvia, Estonia, Lithuania, Slovenia, and Iceland. And we have seen that the challenges of small countries are very, very similar, which are linked to the size. So learning experience from each other is a big role, playing a big role in how we want to undertake our project. So that's basically our main learning, is that you always have to tailor the system to the needs, and you can see where the best practices is and how you can adapt them in the country. So that's very briefly our experience.
Thank you very much. So we saw in one country, Belgium, we have a public health institute. In Luxembourg, we have a National Cancer Institute. So the diversity, there are many different ways to achieve the same objectives and have different organizations. And one of the key roles is the role of the healthcare professionals. We talked about prevention, and of course primary prevention is very important. But when we first get confronted with cancer, we are going to go to the health system. And the health system is not something, it's people. So I would like to give the floor to Mr. Arkadopoulos, who is the president, or I will switch to Greek now, sorry. O Proedros to...
He is the president of the Faculty of Medicine of the University of Athens and professor of surgery at the University General Hospital Attikon. So, give us the Greek context. How healthcare professionals, what can they do in the context of a national cancer plan? How they can support it? What's your role? Thank you very much. Good morning. Congratulations to ELLOK. Congratulations, Mr. Kapatanakis, for another conference that will be successful, I'm sure, based on the agenda. And I would like to begin on an optimistic note. I'm certain that a national cancer plan in Greece can be successful. As you said before, we are not at the beginning. Well, we're far away from the beginning. We are much beyond that. As we see in our everyday clinical life, we are near the EU average or above the EU average in many different indicators, such as the time to treatment. Time to treatment in Greece is very good. The same applies to the quality of services provided. I don't know any surgery or pharmaceutical treatment related to cancer that is not available in our country. Everything is available, so we're far beyond zero. We are doing very well. Yes, we need more coordination. This is why we needed the National Alliance for Cancer, the National Cancer Plan, because of the entire range of healthcare professionals feel that we are part of an alliance together with the state and the patients. And of course, in order for medical professionals to play a more active role, the university plays a major role. We need education that is cancer-focused, not only addressed to specialists, so not only to oncologists. All doctors, regardless of their specialization, should have the fundamental cancer knowledge, the key knowledge, and be part of this national effort, of this national cancer plan, because this will help eliminate inequalities. Let's say that a general doctor in a remote geographical area should have the key knowledge to address cancer, starting from prevention to palliative care. So we need decentralization of knowledge, and this will be achieved only through education. I have the honor to represent the largest and oldest medical faculty in Greece, and we play a decisive role. I believe that we have the necessary stakeholders in the healthcare system. The education is there. Of course, we need better coordination to make it reach everybody, but I'm very optimistic. Let me repeat that we are doing very well, and the medical community and the Faculty of Medicine, and as a professor of new doctors, we are ready to contribute. Thank you, President. Thank you, Mr. Arkadopoulos. I concur. You're absolutely right. There is significant progress and yet many challenges. We're doing very well, and we want to we want to stop acting in silos and start acting horizontally for better effectiveness. Mr. Olympios Papadimitriou is the president of the Hellenic Association of Pharmaceutical Companies. Mr. Papadimitriou, we know that the pharma industry has contributed so far, but how can it contribute structurally in the future to the implementation of the National Cancer Plan? How can we have a more stable framework of cooperation in order to allow you to give your added value? We want all stakeholders to play their part in this process. Good morning. Thank you very much, Mr. Kapitanakis, you personally and ELLOK for the invitation to participate in this panel. Well, look, what I'm thinking is that when we talk about a national action plan, one would expect, I think this plan is already written down, isn't it? It is an ongoing process. No, right now there is no national cancer plan in our country. Okay. One would expect that this plan would involve a series of actions and activities, and then at regular intervals, the follow-up to see if there is progress. As you said, although many things are happening in our country, good things, there are issues of coordination that don't do justice to the result. The pharma industry has been an ongoing supporter of the state. We provide treatment to many patients, and in the past years we have tried to be part of a more coordinated action and effort to address cancer. We were inspired by the European Cancer Plan. Therefore, in the context of our association, we've established a working group for 4 years. We are talking with all relevant stakeholders in order to find out how we can advance certain things in order to improve the care to cancer patients. I think that this effort, I wouldn't say that the National Cancer Registry was achieved only thanks to us, but we've contributed a lot to the dialogue. And now there is a National Cancer Registry, and hopefully the registry of biomarkers will be soon activated. It has been reviewed, and there are some procedural issues that are still pending. And this is another problem in Greece. that there is, it takes a lot of time in order to resolve these procedural issues. We have exceptional doctors, exceptional hospitals, but we need more speed, we need more coordination, because this disease does not wait. That's all on my part. Thank you very much. On my left, we have the professional of health policy, rector of the Faculty of Social and Political Sciences of the University of Peloponnese, Mr. Kyriakos Souliotis. I think he's very happy because he was at the football stadium yesterday for a match, and he's very happy about the result. Based on your experience, what's missing? Is it coordination? Is it guidelines? Is it speed? Not only because this disease runs quickly, but also scientific advancements happen very quickly. And this is why policies need to keep up. What does it take in order to go from a half-full glass to an almost full glass? What's missing? Good morning. Congratulations to ELLOK for another successful conference. I'm here among two dear friends. Yes, we're far from zero. And we're talking about an action plan. Why do we need an action plan? Is it a fetish? Is it just a box to click? No, we need it. And why do we need it? Because when we conduct a gap analysis, we can see certain things that need to be improved. 50% of patients change a prefecture in order to have access to treatment. But what happens in the meantime? This is a simple finding. What Mr. Arkadopoulos said about education is very important, and we have to support patients in between their treatments. There was a finding that when patients receive their diagnosis, many patients feel guilty about what will happen to their family as they are ill. We shouldn't accept that. This is an unacceptable finding. Another finding is that there is huge uncertainty about the financial sacrifices that the family should make in order to support the cancer patient or the carer. This invisible person that is not supported by the state. How many action plans have been developed in this country, and how many of them have actually been implemented? Is someone here that is part of the development of this national cancer plan? If no, I'm even more concerned. The entire team should be here. If a team has been assigned the preparation of this plan and they're not here, this is a problem. And the challenge is not simply to submit this plan. Who is going then to be assigned the operational part, the implementation part? There will be certain aspects regarding access, regarding prevention, regarding patient navigation. Who is going to be responsible for that? Who is going to monitor the implementation of the plan? Because politics and policies are not only about passing the law. We need also a monitoring system to make sure that everything is done correctly. There is a European umbrella about action plans. We need to translate them into our national context, and once an action plan is submitted, an update will be needed because there will be new treatments, there will be new challenges. It's not just delivering the plan and the job is done. That does not only apply to cancer care, it applies to everything. So we need an update mechanism, not of the entire plan, but of certain aspects of it. This gap analysis has shown that we do trust our healthcare professionals, Mr. Arkadopoulos. More than 80 to 90% of cancer patients trust their physicians. What do patients request? They request psychological support, better information on their treatment options, and an organization which has zero cost, better organization and support and coordination for the planning of their appointments, the reminders for their appointments, the support of their carers. For the example, they said, please send the reminder to my carer as well, in order to arrange their schedule as well. So to sum up, yes, we are doing well compared to where we've started from, given that we are a country that has undergone a major crisis. Today we have screening programs, we have good access to the healthcare system, and if you have an idea of systems in other countries work, indeed Greek patients enjoy good access, this doesn't mean that we are problem-free. This is why we need the plan, to identify the challenges, to find ways to address them. But a text that will be called a plan won't solve the problem. The challenge is to properly implement it. Now I would like to give the floor to the representative of the ministry. She is responsible for international relations, so she is the bridge of what happens in Europe and in Greece. What can you tell us, not necessarily about the participation of Greece in projects? We know that Greece has been actively participating in European networks and projects, but what can we gain from such participation? I would like to also thank you for this outstanding panel and this conference. It is very important because we all gain more knowledge when it comes to cancer advancements. I'm here wearing my institutional hat, and I want to confirm what you've already said. Yes, there is active Greek participation in all projects. I'm particularly happy because this participation is not only from Athens. We are a country that's indeed very much centralized, but right now there are stakeholders participating in EU projects that are based outside Greece, outside Athens, excuse me. There are many stakeholders that are also leaders in many of these projects. We submit our deliverables, and these deliverables are the infrastructure to build policies on. So once we have them, we're good at that. We're good at generating these deliverables, but we need to do something once we have them. EU for Health is a project that acts as a bridge for financing knowledge and best practices, but we need more bridges between us. These bridges come to Greece. We have to get to know each other. We have to know our strengths, our weaknesses, and fill in each other's gaps. We need coordination, as you pointed out. We may need a national institution for cancer. Someone needs to have the role of coordinating everybody, of bringing everybody into contact in order to be able to use all the material that we have. Thank you very much, Ms. Gozzi. Since March 2019, there is on paper the National Cancer Institution, but it's just on paper. It hasn't started its operation. It's just a provision. Dear Mark, I understand your surprise. Based on what Ms. Gozzi said, on joint EU actions and on how they can influence the implementation and change the cancer care environment. You also talked about the CCCs and their perspective. These projects have been funded for a certain reason, but what's the next step? What needs to be done? What will you do? And what needs to be done in Europe in order to scale after the pilots?
Yeah, thank you. Maybe to come back a little bit on what is being said on, I heard several times coordination, that you lack coordination to set up the action plan. Well, in Belgium, when they had the first cancer plan, it was decided that there would be really a service, and it's not an institution, but a service, the cancer center, that takes care of monitoring the implementation of the plan. I must say in the beginning, it's a joint activity of the Ministry of Health, also the payers, and the cabinet. And then there comes another one, a new element, the Cancer Center, which was hosted by the Public Health Institute. The first 5 years it didn't work, because it was focused on implementation, and then it's the ministry and the payers that implement. They used to do that. Again, this time, they are going to implement. And we didn't really find out what the Cancer Center should really do. We had to monitor. Yeah, so we made, I think, 250 indicators, of which 95% was not measurable because we didn't have the data. So you have to learn how to do that, but it's important at a certain moment that you find an institution that does that concept. It doesn't have to be big, but it has to do that, working together with the ministry, working together definitely with all the professional groups, with all the hospitals, with everybody, and drive that. Because now we do that. Now, after all these years, because there was a period where not really a lot, well, we had these strategies that we had, and then we had the implementation of the next generation sequencing. We had the implementation recently of the HPV testing in cervical cancer screening. It was all driven, and now everybody agrees. The ministry is very happy because they have no personnel to do that. It takes a lot of time. It's very labor intensive to do this implementation. And we build a strategy, a concept that is the road books. And the road books, for every action that you develop, you have to write a plan, what you all have to do, and it's a lot. Just for HPV testing, I can tell you, we had 15 sub-actions that we had to do, where you bring everybody together. But it works, and it's clear, and it takes time, you involve everybody, and that's, I think, if you want to really make a plan action, and you need an action plan we're writing now, and that's going to be 30, 40 pages, I think, and that will describe all what we do. For each of the actions, we will go back with the people of the field and write the road book, because then it's happening. And then you have the frictions, because then you have the clinicians want that, the technical people want that, the pathologists want that, the clinical biology wants that, the register is coming. Then you have these discussions, but that's working. So that's just something on the coordination, and I think, whatever I heard, it's there. I know that it's there. You've seen already, you have put in some biomarkers. Well, we can help. If you want, we can help. I think there was a joint action, Orion, who was on implementing the EBCP plan in national countries. But there are some tools that we can share with you. The joint action is finished, but I'm sure that the people from Dit Albrecht and us, we can help you in doing that. But that's I think, the main thing in what's happened. And there's indeed, there is a lot of things here. I know from colleagues, oncologists that work a lot with the oncologist community here in Greece. There's stop signs here, so yeah, I think it's all there.
Nikolai, it was mentioned before. Sorry.
Can I ask you something?
Sure.
At which stage do you ensure the financing of your actions?
We are now... No. Well, it's not at the end. It's now we are discussing on what are the topics. It's going to go soon to the minister. The minister will have a look, and he says this and this, because we have a lot. There's a whole wish list of what people want to do. Then this and this and this and this. from the beginning, the ministry or the payers will say, yeah, but this is not going to work, the budget is not there, and then the ones that we have budget and we discuss. There is already an agreement when the new government was formed, that there would be, it's in the governmental agreement, there is going to be a cancer plan. So there is already an engagement for all the parties in the government that there should be budget for doing the cancer plan. Whether, how much, and that's up to us now to negotiate and discuss and indicate what is a benefit. We also start to think more about the needs, not of the push, but what do you really need? And one thing that we definitely are going to, there is these wonderful papers from the OECD, the cancer paper policy analysis, and one of the critics that we got in Belgium that we have too many hospitals giving cancer care. So we should concentrate. Very difficult situation, and because oncology is often the driver of the financial driver of a hospital. So we have to rethink that. There's a rethinking of, it's obvious, but it's, so we are rethinking the financial of our hospital. So it's an exercise that takes together, but the essential thing, I think if you want to have a plan, you need somebody. It doesn't have to be, we always have the discussion on who is on the word coordinating. So we are not, the Cancer Center is not coordinated. The coordinator is the Ministry of Health. But they work together with us and they delegate to us and we work together. So that's, and I think also if you have a plan, it cannot be an institution that is the monitoring and the facilitating of the plan that should be the coordinator. It should be the ministry who takes that. It's an engagement of a government that you take.
Thank you. Nikolai, a small country, with challenges from your collaboration in Europe, what is if you had to choose one thing to use to do your plan, to achieve the objectives of the plan, what would you pick up from all these $500 million budgeted actions that are running and are providing things?
I think for small countries it's access to best practices, because basically plenty of frameworks have been developed in the context of the European project. There are plenty of really excellent ideas and setups which exist somewhere in Europe. I think introducing those, picking up the ones which suit you, tailoring them, that would be the one thing, right? So that's definitely one thing. And I just wanted to make a bridge to the topic which was just discussed, the question of budgeting. If we look at the feedback of Joint Action Orion, which looked at national cancer control programs throughout European Union, there was one single thing which was lacking in all of them: adequate funding for the actions. And I just want to stress that actually planning adequate funding for whatever people want to do, not just based on minimal possible funding, but what's really needed is probably one of those critical elements that are that need to be addressed.
So you are directly in the same line as Mr. Papadimitriou. The decision of the funding is critical.
Κύριε Παπαδημητρίου, ένα σχόλιο θέλω.
Mr. Papadimitriou, I'd like to make a comment. Well, inevitably, I'll talk about funding and financing myself. It is a sine qua non, it is a prerequisite in order to discuss precisely what we can do, what we can actually do. I can't hide that lately there have been concerns amongst us oncologists because state-of-the-art oncology drug has been withdrawn. I'm not a specialist to know whether this will create problems to patients, but this is alarming. We have warned the government repeatedly in the past. I hope that this will not continue, even though I am concerned. We need money, of course, if we agree that our priority, among other things, is also the management of cancer. Thank you. Thank you very much. Mr. Arkadopoulos. How can you turn a half-full glass to a glass that is full by 3/4? You talked about what is there. What is it that we lack? I would like to focus on some thoughts that are not strictly medical. Let's digress a little bit from the domain of doctors. What we lack in our hospital health system is nursing staff. This is the elephant in the room, always. in the health system. There are shortages in nursing staff, and the problem gets worse when we have great needs, as it happens with oncology patients. We need more nurses and better quality nurses. We need specializations in oncology nursing that are very, very important now all over the world. And we also need all the other specialties that Mr. Suliotis mentioned that patients ask for, such as psychologists, nutritionists, experts in exercise. Let me mention an example. This is a best practice example. At the Attikon Hospital, we have set up a pilot office for survivorship, focusing on patients that have survived all treatments and all problems related to cancer, and they have issues in their daily lives. Their doctors play a zero role. They act as moderators only. The main role regards special nurses, psychologists, nutritionists, experts in physical exercise, sleep, experts in family relations, interpersonal relations. So we need that. We have a strong absence of this aspect in the Greek health system. And of course, I need to agree with the first speaker and say that, in my opinion too, the Ministry of Health should coordinate, because it's the Ministry of Health that is the only body capable of coping with the bureaucratic demands of such a system, because we will need case law modifications and amendments. It's difficult for any other institute to do this to fruition. Indeed, the survivorship clinic in Attikon is truly a role model. Thank you for mentioning this, Mr. Suliotis. And I'm sure that slowly and gradually we'll have many more such survivorship centers. Governance and sustainability. These are the words that I think of. We're talking about a national cancer plan. We know that the Greek political scene is governed by lack of continuity and disruptions. So if we need to focus on such an initiative, what should the outlook be for success, apart from everything else that was mentioned? Standardization is also important. If we want a horizontal implementation of an action plan, we need to make sure that best practices like those of Attikon stands out. You should know it. It's outstanding. So a best practice needs to be imitated by other hospitals. So standardization is important. We need to make sure that a patient in Kozani, Ptolemaida and Athens, throughout the Greek territory, that is north and south, will follow the same path. Of course, we can't have specialized CCCs everywhere, but of course, we can navigate the patient through the system. I would talk about continuity and consistency. If a plan is compiled by some people, this does not reduce the value of the people that will come in the future. We need support of interventions by everyone. For example, we have enacted an organization. We have established it. We needed it for years. We finally decided to set it up in 2019, and in 2026 we don't have it. Where's the problem? Implementation. The ministry has many action plans. If we don't guarantee implementation, what do we have? Lost opportunities. Do you know what it means? That someone will be assigned the oversight of the implementation, and it will be their duty. It may be a lock. I don't know. It may be your task. Someone should undertake this task. Of course, we need intersectoral, interdisciplinary approaches. It's not up to oncologists, nurses, doctors, administration. No. All stakeholders, but realistically speaking, because the institute designed is pharaonic, let me say. It's an institute for another country, for France, for instance, not for Greece. We need to have realistic solutions. customized, that we can endorse. We don't need to be megalomaniacs. We don't need to be maximalistic. We need to tidy up things, a little bit of housekeeping. Someone sets something up, somebody continues and says, you will do this, you will supervise, etc. And then continuity. Before we conclude, let's hear a last word from the ministry. Indeed, it is as if you have been reading my mind. You took steps and you incremented what you said. You added steps. The nursing staff is a serious problem. We need suitably trained staff to implement all these things. And continuity is a major issue. You are right. It's a matter of consistency as well. Yes, when we have changes, we don't have the time to learn the ropes. The moment you get acquainted with something, somebody else takes over. If this happens, it's very, very difficult to implement things. And I will add here that we need to change culture in administration and have more contact and communication. I've met with Mr. Marietidis more times, even though we don't live in the same country, more times than I've seen other people that work in the same office building as I do. Let's see. Let's take a look. Who is to our left? Who is to our right? What can we do with them? Dear George, I think that many things, many truths were revealed. Okay, I'll touch upon two things. First of all, joint actions and the funding. The partners are willing to come when there is a person that will undertake the responsibility to execute the plan. Then the help will come. Best practices and the deliverables that you mentioned are ready. The European community dedicated to beating cancer is ready to come to Greece, help it compile the plan and help with the implementation with no funding. These joint actions, you know, have huge budgets. We need two closed workshops and focus on every pillar to the plan and bring you in contact with people who know best, who've been through thick and thin, who failed blatantly first time, but the second time they succeeded, who did something a little bit better for access, or the participation of medical staff, or access to innovative treatments, not geographic access, but access to innovative treatments, as it was said. We can come and we will come, so choose your own people, have the team working, and then you'll create a momentum. Then we'll examine continuity. Let's start somewhere. And if you pick up pace, then you run. And once you start running, you don't stop. You just go on. Governance is a topic that we all broached. Who needs to have supervision? How we can incorporate all these common actions in our health system. How we can diffuse all the things we learned up to now. Stable funding, sine qua non, data and evaluation of everyone involved. And of course, everyone has a place around the same table. All stakeholders need to be there to have a common view. Ladies and gentlemen, thank you very much for being discussants at this table. I believe that we lay the ground for a very good and prolific conference. Thank you very much. Thank you. Family photo, if you'd be so kind.
Ευχαριστούμε πολύ τους διακεκριμένους ομιλητές. Πραγματικά τέθηκαν οι βάσεις.
We'd like to profusely thank the distinguished speakers for laying the ground for the discussion to follow. Before I introduce the speakers for the next session, I would like to please ask you to keep within the time limit so that we can have our day, and with no delays, Mr. Kostas Thamasakis, Professor of Finances and Health Technologies from the University of West Attica, and Mr. Richard Price, Policy Director of the European Cancer Organization. They'll be moderating the next roundtable discussion.
Well, hello and good morning, everybody. Could I invite our panelists to come and join us on the stage, please, for the next session? Would you like to come and join? So, Commissioner Kyriakides, lovely, thank you for joining us. And we have Andreas Haralambous from the University of Cyprus. And online we have panelists from the European Parliament and also from Alberto Costa from the European School of Oncology. And I think, do we have Nikos Papandreou with us? He's online, is he? Okay, super. So thank you for joining this morning's session on EU cancer policy, unlocking the power of the multi-annual financial framework of the European Union. My name is Richard Price. I'm the Policy Director at the European Cancer Organization. We're an umbrella federation of healthcare professionals, patients, and many others working in cancer care. And we aim to try to facilitate the provision of a united voice to policymakers in Brussels and across centres of decision-making in Europe, including Athens. So you can think of us like a ELLOC for Europe. And I'm delighted to introduce my co-moderator for this session, Kostas.
Kalimera from me as well. It's going to be an interesting discussion with this one, I think. And trying to introduce a bit, a few elements about the discussion going on for the next few years on the MFF. And I think that this will actually influence quite a few things at the European level, but also at the national level. So we're looking forward to the contributions to the panel.
Yes, I think, and I congratulate ELLOC for having the foresight to put this topic onto the agenda, because so many of the projects and initiatives that we've already heard about this morning, joint actions on personalised cancer medicine, enhancing digital capabilities for cancer centres, networks of expertise across Europe on specific areas of cancer care, implementation of screening programs. There's a very long list, and they're all making an impact in countries across Europe, including Greece. They're raising standards, they're raising expectations, and providing means and tools for countries to have off-the-shelf solutions to some of the common problems and challenges they face. But none of them would have been possible without the support that was achieved for cancer to be an EU priority, delivered under the leadership of former Commissioner Kyriakides. And more on that later. And to help frame our discussion, I thought we could just recap a little bit on that history and provide a little bit of a sense of the political moment we're in. So could I ask for the slides to be projected? We have just a few to run us through. Okay, do we have the slides? There we are. Thank you. Well, it's very hard to summarize in a single PowerPoint slide the radical new departure that Europe's Beating Cancer Plan marked when it was published 5 years ago to this week for World Cancer Day in 2021. Prior to its publication, health initiatives had really only been a side thought of EU-level considerations, if we were being frank. But perhaps reflecting that moment of its creation, it was in the midst of the COVID pandemic era. It showed bold ambition of what could be imagined, still more what might be realized through proper implementation. So a significant year of consultation was taken to develop its contents, its structure, its actions and goals, and it's provided now a model for national cancer plans. And I heard Mark van der Bolke talking, for example, how Belgium has really adopted the structure of the European Cancer Plan as a means to galvanize and help all regions in Belgium meet the same goals. So those goals include eliminating HPV-associated cancers, creating a tobacco-free Europe, and significantly boosting access to screening and comprehensive cancer care. And it's now very much in operational phase. If we could go to the next slide, please. But over the past 5 years, next slide, please. Thank you very much. The world has not stood still. Dramatic changes in the geopolitical environment have included military hostility by Russia towards Europe, the trading challenges that we have with the current US administration, and the ongoing rise of China as a major global superpower. And all of this has bred some certain insecurities at the EU level, which do suggest themselves as needing to be reflected in the next 7-year budget of the European Union. So if we go to the next slide, please, we can see what is on the proposal table at the current time. So it's quite a significant amount of proposed change from the European Commission. And what would it mean for cancer specifically? Well, the disappearance of the EU for Health programme, which has funded the joint actions and other initiatives that we've mentioned, obviously raises some concern. It is placed within a common bracket in competitiveness alongside agriculture, bioeconomy, and other topics. So the ECO, we are more than a little bit concerned about what that could mean for the long-term sustainability and legacy of the cancer plan. Other significant changes include quite a reshaping or proposed reshaping of regional funding programs, and if you have family or relatives involved in the agriculture sector, you may have heard of that, but we do see some opportunities to perhaps better support countries and regions in making long-term investments in cancer care from that. Now, the reason we are choosing today to talk about it is because this is not a settled deal either. If we go to the next slide, please. What's important to note is all of this is subject to debate, discussion, scrutiny, and potential amendment by your elected representatives, by your national government, but also members of the European Parliament. And you'll see the flags there as well on the screen for Cyprus and for Greece. And they have more than a say in this because both countries are holding the EU presidency of the Council. And that means they get to shape some of the discussions that countries have on this. They get to put proposals on the table. And I think that's something with ELLOC, PASICAF and other partners will be continuing to look to make some use of. If we go to the next slide, just to help frame some of the things we think are necessary to be changed in that proposal, we'd like to see something like a 2 billion European Cancer Fund to be established that would sustain and secure the legacy of Europe's Speeding Cancer Plan. We'd like to see the confirmed maintenance of the research mission on cancer by being included in the future research moonshots that are being put on the table. And we want much clearer encouragement that regional funding, which is a very big bracket of EU funding, can be used to bridge cancer inequalities, to pay for vaccination, screening programs, workforce development, many of the other needs that countries do need to find investment sources for. So, final slide. If you'd like to read into this more, like to get a bit more informed, please do visit reachhigherforcancercare.eu. We've created something very special with the cancer plan and the mission, but it must be continued into the future and not lost to other priorities. So, with that background out of the way, I think we'd like now to turn to our panel to discuss this in more detail. And we've got a great array of perspectives to draw on, two very active members of the European Parliament with us, key figures in the implementation of Europe's Speeding Cancer Plan. But most of all, may I say, it's an enormous pleasure and honour to have with us today Stella Kyriakides, the former European Commissioner for Health and Food Safety, and a true leader in both developing and implementing Europe's Speeding Cancer Plan. We really have so much to thank you for. Commissioner Kyriakides, as we look back from 5 years ago and with the passage of time, the political will and the excitement that you were able to summon for the creation of Europe's Speeding Cancer Plan was really quite extraordinary. And then that was matched by an appropriate budget provision. But thinking now of how to ensure the future of Europe's cancer plan in the next EU budget, what sort of advice and reflections would you have? The world is different now to 2019. Can those who make those decisions on budgets be assured of the importance of cancer as a political priority?
Thank you so much. Thank you for the introduction. Richard, it's a great pleasure to be part of this panel and to see good friends, but I would say those who have staunchly advocated for health within the European Parliament, MEP Koundouras, and I see MEP Papandreou there on screen, as well as Dr. Costa. If I may, just to go back to where we were at the very beginning, and I think it is important. We had a Europe's Beating Cancer Plan that was in my mission letter when I first became commissioner by President von der Leyen. So we started off with the belief that we needed to do something at the European level on a different scale with funding to change the realities of cancer within Europe. And then, of course, we all faced the pandemic. And what the pandemic showed us, it showed us the weakness of health systems, but also the importance of working together, the importance of solidarity, and the importance of building up resilience. And I believe that there was also a shift, and it's a shift that we must not lose, that health is not only a matter that concerns the health ministries. Health has an economic dimension and a social dimension. And we saw with the pandemic, because of a pandemic, when everything came to a standstill, how economies also came to a standstill. So what I would first point for myself, that at least I will be advocating on and using my voice every day going forward, is that we need to keep health at the top of the political agenda. And the European Parliament has always been a very loud supporter, because the Commission puts forward proposals, but these proposals need to be discussed and adopted by the European Parliament. And the fact that we have a standalone program for the first time with a budget of over 5 billion when it started out, EU for Health, came because the European Parliament, across all political groups, supported this. And personally, as a former commissioner, I can only thank them. But now we have a changing landscape, and it is clear that the priorities are changing, and we are seeing that the next MFF proposal consolidates health and EU for Health into a broader European competitiveness fund. The MFF is what sets the ceilings and provides for the EU long-term budget. And it determines how much will go to health. This incorporation into the competitiveness fund has the positive aspect that it could increase efficacy and also simplification. But, and this is where I think we all need to work together, it also raises questions about the visibility and the stability of cancer funding. And this is personally one of my concerns, because we are going to go forward with competing budget priorities, and this will bring an uncertainty about how much we have earmarked for cancer funding. So I believe that we need together, as stakeholders, as policymakers, work very closely with the European Parliament to keep health as the top of a political priority despite the changing geopolitical situation, and secondly, to keep cancer at the top of the agenda. Otherwise, we could be seeing, I would say, an under-prioritization of many of the actions that we started 5 years ago.
Thank you, Commissioner. And some very important points there, I think, about the relationship between the investment in cancer and what it can achieve for economies, and the reminder that actually some of the first conceptions of a cancer plan came from the European Parliament. In a way, it is a baby of the European Parliament.
Also, if I may say, it's quite important to underline what Commissioner Kyriakides said about the health system being also a mechanism for economic growth and social solidarity and social welfare, actually. And I think, well, for me as an economist, this makes sense, but I think that this is an important message that should be conveyed across the discussions taking place currently at the European level, and probably, if I may say so, among the finance ministers, because they are the people with the money. Let me turn to Professor Costa for our next comment on this. Dr. Costa, yeah, can you hear us? Ah, perfect, thank you. You had the front row seat actually to both the drafting of the Europe's Beating Cancer Plan and all the early stages of its implementation. Could you please share with us what are some key principles that underline the plan? What challenges had to be overcome to implement it, and was it worthwhile?
If I may, before you give the floor, if I may just for a minute, because something that many don't know is that Professor Costa was the European Commission's special advisor for the cancer plan from day one for its implementation. So I always like to say that because he may have gone unnoticed, but he was really the one that kept the eye on this plan throughout the pandemic, and I have a lot to thank him for.
Dr. Costa, we cannot hear you. Could you, θα μπορούσαμε να κάνουμε κάτι παρακαλώ με τη σύνδεση του καθηγητή Κώστα. Ναι, το φτιάχνουμε.
Ο ίδιος πρέπει να κάνει.
Dr. Costa, we heard you for a second there. Can we try again?
No, I think that's a way to do it, I think, yeah. Should το ξέρω, το έχουμε πει. Should we proceed with Fevruariu and then come back to Professor Costa?
We'll go to our next speaker.
Okay, we try now?
All right,
okay.
That's perfectly good, yeah.
Yeah. The microphone was closed by the organizer. I could not open it. It's like in my family. Shut up. Okay. So, kalimera σας. Of course, okay, you call Stella Kyriakidis former commissioner, but Stella will remain the cancer commissioner anyway. No offense to the other commissioners, but that was, her mandate was really the one which changed dramatically the fight against cancer in Europe. So this has to remain. And this basically, you were asking for which reasons. I think from my experience, the first reason is that cancer is on top, as you know, of the concerns of European citizens, like together with unemployment and war and defense. So when the citizen is also seen as taxpayer, for the European taxpayers to see Europe spending and investing money against cancer, it's a great relief. It's part of building Europe. And this is because in this field, we always suffered a little bit the comparison with the US, because they started the first national cancer plan in '73, imagine. And this is because they have a federal budget and we don't. So they can have, you don't have a plan for Oklahoma or for Arkansas, you have an American plan. We did overlap and spend and did not rational investment because we were all having our own national cancer plan. So the great importance of having a European cancer plan, it's enormous for the resources that can be put, but mostly for the resources that can be used much better and with a much greater impact. The second reason is that the plan has boosted and has facilitated European medicine. Europe cannot, we have to stop. There is no French medicine, Italian medicine, Greek medicine. We all need each other, and we know very well. And we also need because of the different size of the countries. Nikolai Goncharenko in the previous panel session said it very well. How can you expect a country like Luxembourg to have all the knowledge and all the facilities to treat all the type of cancer? The small countries, I see Andrea Karalambos from Cyprus, I see, of course we need to integrate. And we need an integrated European medicine, cancer medicine. So these to me are the main two reasons.
Now, coming back to, I hope you understand the lamp. Yeah, thank you. Coming back to the resources element, many of the decision makers currently on the EU budget do not have particular responsibility on health policy, such as finance ministers, as we said previously. How do you think that they can be convinced that investment in cancer is a political priority that brings a return on investment?
I'm old enough, unfortunately, to remember what we did with the first plan in '91, the so-called Europe Against Cancer plan. And I remember the Minister of Finances wanted to kill us because we were proposing to put the warning on the cigarettes packets, smoke kills. And they were, of course, seeing that they were losing a lot of money if we had done a proper fight against tobacco, because all the governments take and get a lot of money from the tobacco taxation. But then they started to realize that in reducing tobacco and reducing mobility, they were saving money in other parts, less cost for the health system, more people continuing to work. And I remember this as a switch. For the first time, the Minister of Finances say, hey, hold on, maybe we can also have a financial implication in this. And the other reason is that this can release resources in research. Research generates patents, generates technology, and generates industrial production and income. So the first plan was certainly proved to be effective. You may remember it was checked by the IARC in Lyon, and they concluded that the goal was achieved of reducing mortality for cancer with the 5-year plan. This recent plan will certainly give even better results because it was much stronger and much more articulated. So I wouldn't be afraid to go back and expect the Minister of Finances to understand the importance of this. Thank you.
Thank you, Dr. Costa. And I'd love to be able to say that the debate's moved on a lot on tobacco, but in fact, even at the moment, with a new tobacco products directive in the making, not every country has been helpful towards that being as ambitious as it should. But anyway, I think if there was some concerning news about what the Commission has proposed for its next budget, the good news is that the European Parliament has an important say in what the final budget is. So we're delighted to have two members of the European Parliament joining us now for their reflections. And we'll turn first to Nikos Papandreou, who is a very active member of the European Parliament SONT Committee. So that's the Health Committee. And Nikos, can you share with us how is the discussion in the Parliament going on the next EU budget, and what sort of predictions do you have for the dialogue and the decision-making ahead? And do you think that Greece's presidency of the EU could be important in this respect?
Hello to everybody. Ευχαριστώ. Καλημέρα στους όλους συμμετέχοντες.
Thank you. Good morning. Ms. Kyriakidi, I'm very happy to see you.
Her legacy, we try and continue with the emphasis she had on prevention and population-based screening. So that was an important legacy that we're continuing now in the Health Committee. But the SND in particular, the Socialists and Democrats, have put health at a very high priority. Because today, I think we heard earlier that there is a problem, and I was very happy to hear Mr. Costa's analysis of the past, that finance ministers can actually be convinced. That's good news. Because it's a long-term effect from short-term spending. So in politics, because the cycle is 4 years usually, people don't like to give money that they don't see within their own ministership having effects. So we're trying to fight that. Now, the new approach, as everybody knows, and I think you pointed it out in the beginning, means that we're all at risk in the health to be underfunded. The discussion, however, is still very open. But the new flexible budget architecture, which has fewer named programs like EU for Health, gives more discretion for national governments and the Council. So in this new model, health is treated as being eligible but doesn't have guaranteed funding. So it's eligible if we can prove that it'll have effects, but it's not guaranteed. So from our Socialist Democrat perspective, we're pushing hard against that perspective and that logic. We have asked for a complete budget of 90 billion, and it's not so extreme because the last budget, MFF, the total was 80 billion, half of which was from the RFF, the Resilience Fund. So we're asking for 90. It's a big ask, but that's our goal. So far, the numbers have not been put down. So we do want the continuation of the EU for Health, a reset or reinforcement, and we want binding safeguards and minimum allocations. On cancer specifically, we want to continue the legacy of the Europe Cancer Plan, the Beating Cancer Plan, and we do not want it to disappear into the generic competitiveness. It's not clear what it means competition in terms of beating cancer. We're not talking about drugs, we're talking about results from people who are sick, but that's not clear how that's so competitive. We need to do studies to convince the ministers that that'll improve the health of the economy, etc. We're also working hard for the 2 billion for a standalone cancer plan, which was in the past. So there is, unfortunately, lots of resistance in the Council, especially from some net contributors to anything that'll give specific numbers. So some big net contributors, you can imagine which countries those are, don't want us to pin down those numbers from what we understand so far. But, as you said, Parliament has some strength, and S&D in particular, which the whole, all 130 of us, 36 of us are in favor of a strong health program. We've even proposed health for all committees to be subset in all the committees, health for all we call it. So I think we won't get everything that we want, but we will get some of it. So it's the typical, unfortunately, it shouldn't be that for health, lobbying effort that goes on in a good sense lobbying, that we have to push the commissioners and the Council to agree to put health as a top priority, which, it's strange, whenever health, in terms of priorities, health discussions in the plenary at Strasbourg are on Thursday afternoon. Thursday afternoon is when everybody has left, because people leave around 12 o'clock on Thursday. So that just shows how, until now, the priority for health from the system, so to speak, that I've been working in is not very high. And of course, we do expect the Greek and the Cypriot presidency a good chance to keep health quite high. And we hope to convince both the Minister of Health, who in Greece has some sway over the government, and the Minister of Finance to include that in looking at this word competitiveness, which when you put it with health sounds very odd, but that's going to be the new world, that we need a more flexible budget to be competitive in the geopolitical shifting sands of the geopolitical world. So for me, though, I don't think we can put health so easily into that. And our group at S&D is to make it a high priority. Will we win? We'll get something. For asking for a lot, as you know, we'll get something. Let's see what we get. That's my basic introduction. Thank you.
I think that, thank you very much for that. I think that apart from the budget headroom, there is also an issue on as things are planned to be set up, an issue on the coordination of the programs that will be eligible for funding, and by coordination I mean should they be structured towards a common European goal for health and for health metrics and for health objectives. And I think that this should also accompany the discussions for the budget allocation and the budget headroom for health. Επιτρέψτε μου να συνεχίσουμε λίγο στα ελληνικά και να συνεχίσουμε.
Please allow me to go on speaking, but use Greek this time, and speak with Mrs. Helena Koundoura, representative of Greece, the European Parliament. You have a particular viewpoint regarding this discussion. You've served for many a year on the FIRM Commission and as a member of the EMPs Against Cancer, this group. We'd be very much interested in listening to you talk about matters related to equality vis-à-vis cancer, and of course see if you yourself have identified differences in topics specifically related to female cancer, which is a topic that has been neglected for years, and how it is that we can make improvements in the care of women faced with cancer. Women have many different social roles to play, and of course we need suitable policies to target that. Good morning to you. I wish you to have a nice week and have a nice month. I'd like to make a short comment vis-à-vis what was said related to budget and funding, because without funding of policies that we agree on, as you probably understand yourselves, we can have no success. And that is why, as Mr. Papandreou, my colleague, said, we keep exerting pressure to have sufficient budget in the new multi-annual financial framework for the years 2028 to 2034, at least 2 billion euros for health, because, as it was aptly said before, and most of you active in the sector of health know that prevention costs far less compared to treatment. I heard that ministers of finance realized that this is the case quite late, but progress has been made. So we didn't only have the campaign against smoking and tobacco, but generally speaking, campaigns related to all topics concerning cancer. And for women, I'd like to say that we need to safeguard policies of equality, equitable access to protocols, to treatments. This is, of course, an objective, but prevention and early diagnosis, especially for breast cancer, is our uppermost concern. It should be. Insofar as I'm concerned, breast cancer has deeply personal and political implications. If you have heard me speak in previous conferences organized by ELLOK, I am a member of the FAM committee that tries to assert equal opportunities for women and tries to safeguard their rights. You should know that apart from an institutional framework, there are human stories. There are women who come to face cancer, and these women do not only need treatment. I'm talking about prevention, early diagnosis, and if a diagnosis for cancer is made, women do not only need treatment, they need a voice. Women practically assert their rights, and rights should be practiced. And what women assert, of course, is dignity, psychological support, and there are many policies that are combined to that end. And I'm very glad that we have with us Mrs. Stella Kyriakidou, because during her tenure she introduced the European Strategy for Cancer, a plan and a European agenda that has brought about major change, and especially for women, because now having a uniform strategy for prevention, for screening and for early diagnosis, we can have equal access to treatment. This makes a difference for the quality of life of patients to have a uniform strategy. And in the case of breast cancer, what I can say myself is that this is translated into more programs for breast cancer screening. It needs to be organized and accessible, because it's not only digital tools and artificial intelligence that facilitate diagnosis, but access to best treatments and state-of-the-art treatments and drugs and protocols in the framework of an integrated care before, during and after cancer in the same country. And despite the European and national efforts to establish population screening for the most common forms of cancer, I would like to tell you that Greece, according to the latest Eurostat data, ranked almost last in population screening, as against the Nordic countries that rank among the first. But here, this has to do with geographical inequalities, because in remote islands and very remote places, women, because of problems related to distance and high cost of fares, do not have the same access to screening and treatment as women living in cities do. Now, whether a woman who is ill can be diagnosed early and receive the best treatment is something determined by her income bracket and her employment status. Last year, I made an urgent interpellation when a substitute teacher was subjected to an irrational dilemma, either to go and have the treatment to be treated for cancer or to keep her job, because the distances she needed to cover were huge, and if she wanted to really receive treatment, she had to decide whether to go on working or pursue her treatment. These are irrational things that happen when we lack integrated policies that regard our health and our lives. And of course, women cannot be faced with such dilemmas and provide the answers themselves. So solutions need to be provided on a national level, European level, and especially in Greece, we need better convergence with Europe. The program that we've seen, EU for Health, has been implemented for the second year. It helps substantially so that in the coming years, hopefully, the gap will be bridged. That is, there'll be better geographic coverage regarding also screening programs. I need to say here that NGOs play a great and important role. For more than 20 years, I was president of the Europa Donna, alas, dedicated to breast cancer. Madam Commissioner knows, because she herself focused on the topic in Cyprus. Now the chairperson, Fiorita Poulakaki, president, and Mrs. Marcellou, who's the deputy president, pursue the basic objectives of Europa Donna. One of the objectives is, of course, a treatment of breast cancer. This has to do with population screening for all women in Greece, women over the age of 40. Here, let me add something I forgot to say before. It's not only the mammogram, but also the pap test for cervical cancer that women tend to neglect. This is also very important. We need to see the operation in practice of the National Cancer Registry, the certification of dedicated or excellent centers for breast care throughout Greece as part of the national health system. We had before this understaffing, not only nurses, but also doctors. There are many ICU units that cannot function because of the shortages. We need to safeguard the best collaboration between public and private sector, training, specialization of healthcare personnel full information of patients regarding all available treatments and protocols so that they can make an informed decision. Of course, financial support for scientific research, and I'll conclude by saying that all these policies need money. In order to safeguard not only treatment after the onset of the disease, but also treatment afterwards. And we are talking about a miscellany of services that need to be available to cancer patients, and especially breast cancer patients and women who need more support, because women play multiple roles, being partners, mothers. When a woman falls ill, you know that the entire family feels numb, the entire family suffers. So it's of paramount importance to have full access to treatment, to have psychological support even for the family if need be, and of course other rights that we have not really discussed, such as the right to be forgotten. When a woman is cured of cancer, she needs to be able to lead a normal life, to go to work, to be able to be insured. These are things that we still assert as rights. And I believe that what we need is political volition, investment in public health, and a strong gender-based dimension to all our policies. Thank you very much. Thank you very much, says our moderator. The truth is that we haven't sufficiently examined cancer in women. Not speaking about clinical approach to cancer in women, but the role of cancer in women society-wise, because women play multiple roles. They are the ones that do most of the work in the family, not only in our country, but many countries. We haven't highlighted this as much as we should. I'll send you the result of the survey that finished this weekend, because we want to raise proposals that don't have to do with the system alone, but the system, businesses, society at large. Let me add that breast cancer is 100% curable if it is prevented at an early stage or diagnosed. It's important for women to know, because prompt diagnosis, prevention and early diagnosis can give women longevity. This is a cancer that can be cured indeed, and this is of paramount importance. We shouldn't forget.
Points there, and I think the issue of care burden as well is one that we want to try and promote. The women are primarily taking that role across Europe, and if we want a competitive agenda, I think it would be good to address that topic too. I'd now like to turn to Professor Haralambous, who's been very active in Cyprus in making sure that institutions and entities there are engaged and active in the cancer plan, and indeed in projects relevant to the most recent remarks on telehealth and how we can find new ways to bring care to people in geographic challenging areas. But Professor Andreas, all eyes are on Cyprus at the moment. It's holding the presidency of the EU at the current time. You've been working with PASICAF and local stakeholders and politicians to try to bring the attention of the Cyprus government to the need to maintain cancer and health in the next EU budget. Could you share some of that work and how you've seen that so far? And are there any initiatives in the future that maybe our audience should be aware of?
Thank you so much, Richard, for the question, and thank you, ELLOK, for the opportunity to be here and convey my experience and expertise on the topic that you have just mentioned. Let me start by saying that the EU Beating Cancer Plan was undoubtedly one of the most political commitments made by the Commission in order to change cancer care across Europe. But the plan itself, it doesn't mean much unless there is a corresponding national commitment as well. So we need both in order to have an alignment, in order to be able to change things to the right direction. In Cyprus, I believe we are privileged and lucky because the EU Beating Cancer Plan came at a time with an already national cancer plan in place, a national strategy for cancer care in place. So the plan and the EU Cancer Mission gave us the opportunity to invest, structure, and restructure where possibly in order to change cancer care and improve the services provided to people affected by cancer. I know that I'm not here to project an utopic picture about how Cyprus has managed to do things, but let's face it, we all love success stories. And I do believe that Cyprus have managed in aligning the two to project very successful examples. The revision of the breast cancer screening program based on the new recommendations launched as a result of the EU Cancer Plan in 2022. As a result of the same recommendations, we are now exploring launching the screening programs for prostate cancer as well as lung cancer. And as we speak, the colorectal screening program has already been launched. The MEP mentioned the right to be forgotten. Cyprus was one of the first countries to instigate this right to cancer survivors, which I believe makes a huge change for those who manage to survive the disease and actually have a life after the disease and not being defined by cancer until the end of their lives. There's many other areas where we can mention success stories. And at this point, I would like to put my researcher's hat. I'm also privileged to lead EU for Health funded projects, such as Transition, Intervene, and also lead aspects of the joint action of ECAN Plus. What we do with these projects, for example, Transition, it builds the capacity of the oncology workforce in dealing with the challenging aspects of cancer care across Europe, especially with the rise of digital technology across health and, of course, cancer care. The project Intervene aims to raise the health literacy and digital health literacy, not only for patients and caregivers, but also for healthcare professionals and citizens. Because unfortunately, what we see in terms of health literacy is that we have a long way to cover, because we develop technology, but we are not adequately prepare the people to put technology into action. And of course, ECAN Plus joint action works towards making the digital capabilities of member states to improve to a higher level. And these are only some of the success stories that I could mention from the Cyprus point of view. And as Richard, you mentioned initiatives in order to support the new MFF in order to put or maintain cancer and healthcare in the spotlight. Last year, we launched the Larnaca Call, which called for an action for governments and MEPs in order to make sure that the plan stays focused on health and cancer. This year, on the 29th of April, we will meet again in order to see what we have achieved in this year, but also what new evidence have emerged in this year that can support the case further on. There's many more I could mention, because there is another dimension that I haven't heard anyone mentioning so far. The EU Beating Cancer Plan made Europe an international focal point when it comes to digital technology, for example, the European Health Data Space, the AI Act. Those things are things that no one speaks about at the moment, but we are pioneers in setting the pace on how artificial intelligence will be implemented in the present, but also in the future. Thank you.
Thank you so much, Andreas. And you touched on the sort of lesser heard stories of success from the plan, how it stimulates national action that might not otherwise have happened, but also that return on investment that can be bought from investing in training schemes that all of Europe can use, rather than having 27 training schemes for AI and cancer. Like DigiCan Train, we can make something available for everybody. So I'm conscious of time, and we do need to bring matters to a close, but before we do so, I'd really love to hear the thoughts and reflections of Commissioner Kyriakidis on what you've heard and some of the thoughts it stimulated for you.
Thank you. Well, a great deal has been said. If I may touch on a point that we don't have the time to discuss it today, which is women's health, but Elena raised a number of points, and what we need to do not only for prevention, early diagnosis, treatment, but for life after breast cancer. And a friend of mine, Katerina, today said something which I noted down, that women should not only survive, because we use the word survival, but they should thrive after going through a cancer experience. And this issue of thriving after cancer, I think, is going to be one of the most important topics that we're going to be looking at over the next few years. In terms of what has been discussed, first of all, how can I think economy and economics and economists are very important part of the discussion. And for many years, we as policymakers dealing with health, as stakeholders of organizations dealing with cancer, kept this part of the equation out of it. And I think it needs to be part of also our language, to put economics in our language when we're discussing health policy and when we're advocating. MEP Papandreou, I never use the word lobbying. It's not a word that we use.
That's a negative word.
Yes. I heard that he was also very careful. When we're advocating for healthcare, we need to put economics in our language and in our agenda. And when we're seeing ministers about health policies, we need also to see the ministers of finance and not only the health ministers, because health is also about economics, and we need to also put that into our language and our work. Now, what we have, and I believe in being pragmatic, is a proposal to have the health program and health being consolidated into the broader European Competitiveness Fund. Is there only a negative side of this? I would say no, because what it can do is also streamline funding and integrate funding. But what we need to ensure at the same time is that we don't dilute the funding, and that, especially in the area of cancer, there is a sustained long-term commitment. And this is something that I believe can be discussed, whether within the Competitiveness Fund we can have a structure that will be dedicated to health, so as to ensure that we have implementation, we have actions that we can actually follow up, because nobody is really discussing yet about who will be doing what with this change, so that we don't lose sight of health and of cancer, even if this is now within a broader network, a broader framework of competitiveness. So I think this is something that the European Parliament can see very carefully through the Santa Committee. And last but not least, it was mentioned, I think, by Andreas, by Professor Haralambous. What came out of a very difficult time of the pandemic was not only a Europe-beating cancer plan, but what came out was a change in the way we saw health. And we spoke of the European Health Union, which had cancer plan as one part of it, the European Health Data Space, and I'm now being in Greece, seeing all the mobile phones with the personal records on the phones, this digitalization in health, what we have achieved, came out of a very difficult period that we all went through as a continent, but also as globally. These we need to not lose sight of and keep it high on our agenda and keep health at the top of the political agenda, because societies cannot function without health. We saw it with the pandemic, we forget very easily, but we need to advocate for this all the time. And thank you.
So in this session, I think we touched on many issues. I hope we've conveyed what a critical topic this is. We'll be working with ELLOC, PASICAF, and many other stakeholders on this in the year ahead, and look forward to your involvement. Thank you to the speakers. Thank you to our audience.
Thank you very much.
Bye-bye. Thank you.
That would be a mic drop.
Ευχαριστούμε θερμά τους συντελεστές αυτού του πολύ.
We would like to profusely thank all the interlocutors for this roundtable discussion. Unfortunately, we are lagging considerably behind, so if you need coffee desperately, go out, get it, and please come back. And I'll call now, I'll ask rather Mr. Athanasakis to remain here and invite the discussants for the next table. The next round table. We have a big number of participants, so please be kind enough to speak only once, if possible. Thank you very much.
Ωραία. Όπως κατανοείτε...
As you can understand, there will be no coffee break. If you would like to get a coffee, go outside and get it. I would like to invite our panelists to join us on stage. Let's start with Mr. Aris Angelis, Secretary General of Strategic Planning at the Ministry of Health. Mr. Angelis, please join us. Zisis Kozlakidis, who is the Director of Laboratory Services and Biobanks at the World Health Organization. Ms. Labrina Barbetaki, Chair of the Pharma Innovation Forum, Chair and Managing Director of AbbVie for Greece, Cyprus and Malta. Mr. Dennis Hogan, who is the Chair at ARGO, Accelerating Research in Genomic Oncology. Mr. Spiros Goulas, who is the Head of the Directorate of Strategic Planning at EOP. Mr. Kostas Stamatopoulos, who is Hematologist, Director of the Institute of Applied Biosciences. Mr. Giorgos Vassilopoulos, Professor of Pathology Hematology at the University of Thessaly. Ms. Eleni Kourea, Professor of Medical Oncology at the University of Patras, and Mr. Antonis Karakis, Director of Corporate Affairs at MSD Greece. This roundtable is about our next steps, what will happen in the future. In terms of budget, the key issue is how we can build sustainability in the healthcare system. Sustainability means a healthcare system that seamlessly provides services So an important key issue is how the system can remain sustainable no matter what happens all around. We will start with Mr. Aris Angelis. What you see in the ministry, what's your plan in relation to the measures that will enhance the sustainability of the system and sustainable access to innovation? Good morning. Thank you very much for the invitation. Once again, I'm representing the Ministry of Health at the ELLOK conference, and it is very good to participate in such interesting panels when it comes to sustainability to healthcare services and pharmaceutical care. I understand that HTA will be the focus of the next session, so I'm not going to provide too many details on that. I will try, so please be seated, either leave the room or stay in order to continue with our panel. So now, in the past 2 years, we have been working on various actions at the Ministry of Health, focusing on the direct equal access of patients to new healthcare services, innovative healthcare services that are clinically safe and financially sustainable, which means that these services for the state and for society, it is beneficial to provide access to such services. What's the main problem which everybody needs to be aware of? The problem, or the challenge, might I say, is that we work on a tight budget. Our budget is very tight, and it is a budget allocated to the healthcare system in general, which includes not only pharmaceutical cares, it's also the payroll, it is the maintenance of the system. In the past 3 to 4 years, we're lucky enough because we have been received funding by the Recovery Fund, but under normal circumstances, this money should come from the national budget. So why is it important to be certain that new technologies, the new diagnostic tools, the new drugs, innovative equipment are clinically efficient and safe and financially viable? Because we should be able to achieve this balance and be able to provide these services. There is now a discussion in the UK on what is the threshold for this value of money discussion. What's the problem? The problem is that when we have to pay an X amount for a new technology, if we don't have the necessary balance in order to continue providing proven older technologies that are clinically safe, then most probably we will lose access to older technologies and to the benefits. So we always need to be certain on the new added clinical benefits and that they are actually better than the existing technologies, because we may not have enough budget to provide everything. We need to prioritize based on a scientifically documented methodology. In the Ministry of Health, we've been working on various pillars, and the key focus is to ensure direct and seamless access to new technologies, and at the same time, we are working on certain reforms. Many of these reforms will be part of the new bill, and they will concern the prescription of older technologies as well. If we better manage prescription, we may be able to assess the existing resources and provide the best possible treatment to the right patient at the right time. That's the thing here. We always need to know the right population which will receive the right treatment at the right time. It's not possible to provide every treatment to all patients. We need to prioritize. So only when older proven technologies have been tried and not been successful, then we can offer the new technologies. There are older drugs that are so effective that we don't need to change them. It doesn't mean that every new drug should enter the healthcare system. Many of the new innovative drugs might not be all that innovative, and maybe some existing treatments might be most cost-efficient and effective for patients. Now, to answer your question, the Innovation Fund will be the new provision in the upcoming bill. Today, we are going to have an internal meeting to set out all the relevant details, following, of course, the extended consultation we've been having with all key stakeholders. And as I said, we are trying to better organize all aspects of the market, have better overview and control and safeguards on how other drugs are provided. And there are other issues related to the National Medicines Agency, to the National Healthcare Provider, meaning AOP, and IFET. So we want to build a new framework for all aspects related to care and access in order to be certain that we provide the best possible treatment to the patients that really need it. At the same time, trying to save resources to use them in other healthcare services. Thank you very much, Mr. Angelis. Let's go to Mr. Koslakidis. We've talked a lot about these new elements that will fill in past gaps, but let's talk specifically about cancer. And let's focus on policies that are based on new data. I know that you've experienced in cancer policies and biobanks.
Because that's, so the way we look at things is there are three main points. From the WHO perspective, we have to look at inclusion by design. So when we design a policy, when we design the provision of healthcare, that has to be inclusive to as many parts of society as possible. Otherwise, you provide an innovation, let's say, but you amplify the divide in terms of access to care. The second part is that it has to be substantiated by education, and education at all levels. So I'll give you a personal example. In the UK, I'm leading on the teaching of the NHS executives for innovation. And we started 10 years ago with 5 NHS executives. Now we're at 50 NHS executives. But that meant across 3 governments' commitment that this training has to take place. It's interesting to see that now it's bearing fruit. We couldn't have predicted that 10 years ago. The third point is that we need appropriate governance. So the Commissioner Kyriakidis, he was talking about the governance that's in place and how the Beating Cancer Plan is in place. From the IARC perspective, we've also promoted the Code Against Cancer, which provides a more general framework, but also aligned with what's happening. So these three things have to coexist. Otherwise, we're going to talk about, very much like Ari said, innovative approaches that have marginal impact when they're implemented. So from this perspective, if we can align these three elements, we'll do very well.
Ευχαριστώ πάρα πολύ. Νομίζω ότι είναι εξαιρετικά σημαντικό να σκεφτόμαστε.
Thank you very much. I think it's very good to open up our thinking and not think only on a single dimension of access to innovation. This innovation should ensure equality. Healthcare systems do three things, one of which is social cohesion. And there are problems in terms of that, and this is why these 3 points need to definitely coexist. Some specific measures that concern Greece specifically?
Very good islands of excellence, or very good examples that have been provided as pilot studies or in particular locations. What we said before, making sure that this is able to scale and replicate it in other parts. That's the key. That's what we're missing.
Ευχαριστώ πάρα πολύ. Βεβαίως η καινοτομία για να υπάρξει και βεβαίως...
Of course, for innovation to exist and be assessed, we need the right financial and economic environment. What's your opinion on that in Greece? Good morning, Mr. Athanasakis. I would like to thank ELLOK for this very important invitation, for this very important meeting. Thinking of what we said in the morning and what this means for Greece in terms of innovation environment, I think we are at a crucial point. I cannot say that we live in an isolated environment. As previous speakers in previous panels said, in the EU there is an important discussion right now as to equal access of patients to innovation. I agree with you, such access should be equal. And there is a discussion globally, and there will be developments in the US as well, where they also seek to strike a balance when it comes to the funding of innovation. As the chair of AbbVie and of the Pharma Innovation Forum, I will talk about the pharma industry. I think that we need to accelerate the implementation of solutions. We all know the problems. All states seek this balance between restricted financial resources and comprehensive cancer care. Since we are talking about increasing number of cases of cancer at people below 40 years old, since we've been talking about patients who look for solutions using various mechanisms for a larger phase of their lives. So the expenses and the need to fund oncology will increase. We cannot, this will be never a zero sum. And this means that there will be need for funding. We've discussed with the Ministry of Health, we've analyzed data according to which the financing environment meaning hospitals and LP, are problematic. Problematic both in terms of funding and reimbursement. I know that you think that I keep repeating myself, but nothing ever changes. We agree with the ministry that it's not only an unequal fight, it's also about prescription. But when we talk of non-predictability and problems with reimbursement, then this equation is not yet equal. Those that finance oncology in Greece are the pharma industry and not the state. But I want to be fair. I don't want to only talk about the bad aspects. No, let's talk about what we've achieved. Mr. Angelis talked about the Innovation Fund. The Forum Innovation Pharma congratulates this initiative. It was part of our proposal in order for breakthrough treatments to reach Greece. But that's just the beginning. There is an initial funding of 50 million, which is not enough in order to ensure the entire financing gap that exists. But it's a good development. We've talked about access and early provision of treatments in Greece. Of course, we need assessment. Nobody's contrary to assessment. Correct and objective assessments, but at the same time, there are certain barriers that we need to remove. For example, provision 518, it's no longer needed. We can have more objective assessment of the budget and the financial elements without having to wait for this assessment. And let me talk about the third point, which is the value-based approach. Our country is definitely now able and experienced enough to link assessment to reimbursement, to look at the outcomes, who proves the effectiveness of technology. Once we prove that such technology can improve the lives of patients, can reduce hospitalizations, can reduce chemotherapy cycles, who will confirm that this innovation will be used and recognized in Greece? Because with a horizontal measure such as clawback, this is not possible. So let me inspire from the UK example that Mr. Angelis mentioned. And the UK has a separate memorandum with the industry in order to speed up access to innovative treatments, in order to ensure funding of new treatments, and increase the threshold of HTA that proves the cost effectiveness of a treatment. I don't want to further dwell on that. I would just like to say that an agreement between the state and the pharma industry, which will acknowledge the value of technology and will provide a framework, will ensure better weighting indicator results and will not threaten already existing technologies. When there are technologies for metastatic cancers that leave Greece and we cannot find an alternative, but only through EFET, this is not equal access. Equal access doesn't mean everything available to everybody. It means the right treatment to the right person at the right time.
This brings me to Dennis. How would you see things going through an international perspective about securing sustainable access to personalized approaches in care.
So thank you to ELOC for their invitation. And I mean, personalized medicine is really around how can we democratize it. I mean, because the story about personalized medicine is often focusing on therapies. But the real story of personalized medicine is how do we identify patients in an early stage of their disease? And how do we avoid late stage disease? And this is a core issue. We talk a lot about these therapies, these expensive therapies, but what we have now is we have more understanding of the biology of the disease. We have more understanding of which biomarkers we can try to treat a patient. By understanding these different factors, we can treat patients earlier. And then the real story there is to how do we find those patients at a quicker stage? Because a lot of the story is distracted. When we speak about personalized medicine, it's not how we're spending the most money on these expensive therapies, but how can we allocate resources in a society to ensure that the patients have the best quality of life. Now, a lot was spoken about the European Beating Cancer Plan, which is a great initiative. But a second great initiative that was done under the Commissioner's mandate was the updating of the EU Council conclusions. And there we added lung cancer and prostate cancer. And these are our core issues. Because once you see how breast cancer, cervical cancer, colorectal cancer, how these guidelines leverage treatment rates and diagnostic rates across the European region, this had huge impact. So having these council conclusions and these guidelines that were monitored by JRC, this supported early treatment and early diagnosis. And this really has this equity impact that what we're trying to talk about. Then the European Beating Cancer Plan has developed a lot of joint actions and different projects, and these has really supported the issue around equity because it socialized the willingness of the member states to cooperate and collaborate on issues where healthcare was a national issue. Now there's recognition that there needs to be collaboration and cooperation. But this went through different evolutions. You had in 2009, I'm not as old as Alberto Costa, but I'm young that I was in 2009, that we had the European Partnership for Action Against Cancer, then you had CanCon 1, CanCon 2, and then you had the European Beating Cancer Plan. The big difference was there was money put behind this in the European Beating Cancer Plan of 5 billion euros. And this facilitated this cooperation and collaboration, because one needs money to ensure this collaboration and cooperation. But so now there's willingness to collaborate between the different stakeholders, but when you look at member states, there's often a hesitant still because they see this as a national issue. When you come back to the council conclusions on screening, lung cancer, there's big pushback from Germany that we don't want to do lung cancer screening. And this caused this discordance in Europe to have a common approach, hence this stepwise approach in Europe. Similarly, when you look at health technology assessment, which we discussed in the next session, this proposal that came out from the European Commission, which we did a lot of work on, there was big pushback from the HD agencies themselves, and maybe not in Greece, but at the national level and the regional level, but depending how the healthcare system is organized, because they have vested interest to do this themselves. So they were pushing back around this joint clinical assessment. There was a lot of big discussions from different actors, and this delayed the purpose of how this will be done. When you look at the General Data Protection Regulation, where it was well-intentioned, how data should be shared and utilized to see, okay, do we have the evidence in different ways? Then there was created a whole architecture where you had a lot of ethics, where ethics is very important, but then this implementation at the country level frustrated what the intent of the legislation was. It wasn't to misuse the patient's data, because one can trust the healthcare actors. It was how we can utilize this in a more effective manner. And this led then, we tried to work around this with the 1 Million Genome Project, which we came up with having a mega initiative for Europe, Million European Genome Alliance. But it wasn't sequencing 1 million genomes. It was how can we have interoperability between healthcare systems. And there you need ministers' support. And this led into the European Health Data Governance Framework. A lot of these issues, we're trying to find workarounds to issues to get member states to collaborate and cooperate. But personalized medicine is really this democratizer, because how quick innovation is moving, one can see that we have more and more biomarkers for different types of diseases. We don't want to avoid different mistreatments or overtreatments. So if we invest in infrastructure, which they're doing with the Access and Diagnostics for All pillar, and as well as public health genomics, then this allows us to treat patients in a more effective way. Not to spend money just for spending money that a patient Googles on ChatGPT and says, oh, I should have this treatment. No, one has to follow the science, and the science says, okay, you're diagnosed, say, with this new biomarker on pancreatic cancer, which is a big killer if you late diagnosis, and then you can get the responsible treatment. So one needs a governance framework, how this can be done. One needs the allocation of resources, but one needs a common framework across the European region that this is done in the right place. And this is what they did in the rare disease area, but 80% of rare diseases are rare cancers, and we'll have more and more of rare cancers. So we need a common approach across the European region, how this can be done, so resources can be allocated. On this European fund, my last point, on this European fund, I think this is a fund at the national level, which you did in UK or in Greece, you're proposing, is a good idea, but I think it needs to be a fund also at the European level. How this innovation fund can support disruptive treatments that will come onto the market or come on availability for the patient, so this could be accessible. The countries have the problem because they don't have the evidence available, and each country collects the evidence in a different way. But having an innovation fund at a European level could support this access issue by giving a chance to see, do we have the evidence, and how does the efficacy of this in different ways.
Thank you very much, Dennis. I couldn't agree more about the common approach necessity in Europe on this, and I think it's an issue that we have to come back, because it's an issue inherent also to the MFF, and it's not just about money, but about how you can do things collectively in health. Let me switch back to Greek, and Κύριε Γούλα, ο ΕΟΠΗ θα
Mr. Goulas, ALP, which is the healthcare services providing body in Greece, will have to tackle many different approaches regarding reimbursements, and sustainability is an issue. How are you planning on dealing with such issues in the future? Yes, indeed, this is the case. Good afternoon from me too. Obviously, for the reimburser organization of Greece, ALP, the entrance of innovation is of paramount importance. We have limited resources, we have the clawback that we all know, so this is a difficult equation. And what we want is to be able to introduce either new medicinal products, drugs or technologies to the benefit the patients as early as possible, safeguarding, however, that the treatments will find their way to those that truly need them, and the difficult balance we have to strike in order to have a sustainable system overall. So I would say that what we see in the near future for our organization, the reimburser, is to turn it from a passive buyer of healthcare services that it is today to a strategic purchaser, buyer of healthcare services that will purchase on the basis of value, efficacy and quality of treatments. Obviously, a very useful tool is HTA, of course. We have had it for years for drugs and have used it successfully. And we expect very shortly to have the new bill for biomarkers, that is diagnostic tests. And the same thing will happen for medical devices quite soon, as we expect. So using HTA as an organization, as EOP, will be facilitated in our task to reimburse what is necessary. I'd like to place particular emphasis on the last bill of law, which is, in my opinion, an innovation, proving the shift, paradigm shift, concerning the entrance of new technologies. With a new bill, for the first time, we have broken the silos that we've had between drugs and diagnostic tests, and we have a uniform approach to them for all patients, in our case, oncology patients. So what will happen from this point onwards? We'll have an evaluation of both the drug and the biomarker concurrently, and the file will be forwarded to the responsible committees for drugs in order to be reimbursed or not reimbursed if the budget does not suffice. But this process will truly accelerate things, giving patients far easier access to new treatments. But most importantly, and in fact we have the General Secretary on the panel, the bill has his own personal seal. We have a total change of approach to new treatments, and I think this was the most important thing achieved with the last bill of law. So, summarizing all that, in conclusion, I'd like to say that we can go beyond clawback. I understand the impediments it raises, but we can go beyond that if in the future we have targeted approaches, if we look on diseases holistically and not look on healthcare services in a fragmented way, as we heard in the example concerning oncology drugs. And of course, synergies of all stakeholders, patients, medical community, Ministry of Health, health services provider, and AOP, the reimburser, that is. Thank you very much. Thank you, Mr. Willers. Now I'd like to proceed to Mr. Kostas Stamatopoulos. Kostas, you have experience with research and practice. How can these two contribute to sustainable access to innovation today and in the future? About 2 weeks ago, Mark Carney, Prime Minister of Canada, delivered a very important speech at the World Economic Forum, and he said that we find ourselves in a post-capitalist world with different alliances, different priorities, and different approaches. Your question, Kostas, does not need an answer. It has been answered already. Innovation goes hand in hand with research, free research, because if we want to go back a few years ago, in the year 2015, Katalin Kariko was dismissed from the University of Pennsylvania. She was working on mRNA vaccines. In 2024, she received the Nobel Prize in Medicine for the mRNA vaccines that actually saved us from COVID. So the answer has been given. The question regards ideology and politics. Both action and inertia are political choices. And everything we're talking about today is happening. It is possible. Technically speaking, it's all feasible. Mrs. Varvetaki, I'm a hematologist, as you know. We have the pleasure and the honor to work together. And as a hematologist, I have been focusing quite a lot on a disease for which the first drug of AbbVie in oncology, venetoclax, truly changed the landscape. When was this drug introduced? I believe the year was 2018, corrects the speaker. Not 1918, as he said mistakenly, correcting himself. So today, in terms of innovation, 2018 is a year that means the drug is old now and obsolete, or perhaps obsolete, but this old drug needs biomarkers, and the biomarkers necessary are not reimbursed in the country. So, Kostas, I see you nodding. Does it mean that you agree with me or disagree? No, continue. So, these biomarkers are not reimbursed. So, we are losing a basic tool that would enable us to democratize patient treatment, to safeguard equal access, and to take things one step further. Therefore, your question has an easy answer. Research and innovation go hand in hand, but nothing can be implemented if we don't make haste. And, of course, I heard the very correct and realistic approaches made regarding specific budgets, limited expenditure. This is a political position too, you should know.
The truth is that the discussion that has taken place in the past years in this conference and in other fora as well has led to some movement. I know that you might believe that it's not quick enough, but something is being done. There is a report by FP and the International Organization of Pathology in 2022, and Greece ranked last. Less than 1% of biopsies are controlled in the right way using biomarkers. Only 1% talks about genomic medicine. I don't need to give you further details. This is very interesting. Yorgos, you should give us more time in these roundtables to be able to discuss this. Ms. Kourea, what do you think about what Mr. Stamatopoulos said? First of all, I would like to thank ELLOK for inviting pathologists here. The beginning of the cancer pathway is the biopsy. Indeed, in Greece, and I will talk about the problems that pathologists face, the challenges that exist, and what can be done in order to improve the existing situation. We talked about biomarkers. Biomarkers are very important, simple biomarkers and NGS. Biomarkers are not just therapeutic markers, they are also diagnostic. Even the list that has been published includes only certain therapeutic biomarkers. There was a joint proposal by EOP, by us, and the industry. There was a much more detailed list, which needs to be approved at some point. Let's find a way to do that. Apart from the therapeutic biomarkers, there are also diagnostic biomarkers. Many cancer types today need a molecular profile that needs biomarkers to be diagnosed. So diagnostic biomarkers should become part of this equation. That's one point. I want to mention 4 more points, but I will be succinct. The second thing is the registry. The registry has been developed and it is a tremendous effort, but none of us has the time to actually register patients. Now, we are trying to automate this process. This will give many more information that will allow this cancer registry to include many useful data. So once this is possible, we will start with 5 cancer types, and once this becomes a reality, it will be a major achievement. The third point is the laboratory infrastructure. Not only NGS, I'm talking about other more simple biomarkers. We need new facilities, new laboratory facilities. Now, our job has a technical part and the medical part. The technical part involves people. Many people register, record the same material, and this means mistakes. Automation will be better because it will speed up our job and it will ensure quality. So, automation and following automation, accredited laboratories. In the previous panels, somebody talked about the quality of the diagnosis provided. When we improve the quality of our laboratories through accreditations and quality controls, we will be able to do that as well. The state should fund us and make us go through the accreditation process. We've been asking this from the ministry. We need to improve the work we're doing in the laboratories, and this will be ensured through certifications and accreditations. And my last point will be about tertiary centers, which will host laboratories that will conduct more detailed analysis. And these are the so-called laboratories/hubs that need to be developed. Let me just remind you that you talked about this extended list. This list now covers biomarkers that lead to reimbursed treatments. Let me remind you that biomarkers are health technologies, major health technologies, and they need to be assessed, so they need to go through HTA. But let's go now to the clinical field, Mr. Vassilopoulos. What's your opinion? I'm not that optimistic. I'm sorry for starting on a non-optimistic note. I'm here as a hematologist. Thank you, Mr. Kapitanakis, for the invitation. As a hematologist that treats hematologic patients, we are in the middle of a crisis. You might have heard that a major company withdrew a major drug that now can be found for patients, but without easy access. We have to undergo a huge red tape process. Let me tell you that about 90% of drugs that are used by hematologists today for hematological cancers are innovative drugs. When I was doing my specialization, I only used 10% of the drugs that I learned back then. And Greek physicians are not taught, and they don't know anything about the cost of these drugs. So faculties of medicine should include this in the curriculum, because it is our everyday job. We all depend on the same pocket for our payroll, for our pensions, for the drugs, etc. When it comes to innovation itself, we all talk about clawback that needs to be changed, but there is another parameter which is rather easy to fix. Recently, hematologists and hematology patients have been faced with shortages in cheap drugs. I'm talking about 40 euro drugs, not 2,500. With this pricing policy, many companies don't want to bring their drugs to Greeks. And then we have to again go through the red tape in order to allow our patients to receive these drugs. This can change very easily in order to reduce the administrative burden that we incur in order to allow patients to access these drugs, and it will provide certainty to our patients that are now very much concerned. It is important to say that right now, it is important for the EU to understand that the US is no longer the promised land for research. Right now, Europe has a unique opportunity to boost research. Now, in the US, the environment is not favorable because of the migration policies, etc. We should attract researchers from all around the planet, as US used to do in the past. Can you give me 10 seconds? 10 seconds, please. 80 billions were transferred from the research field, from the EU budget to the defense field. It was just a note. Are you talking about the new MFF or no, the previous one? That's a nice discussion, a lively discussion, but we don't have time. Yorgos, you should rethink it in the future. There are too many people that want to say too many things. The coffee break was cancelled anyway. Mr. Karokis, I know that you are aware of the EU environment. Can you give us a perspective of pharma companies? Thank you for the invitation and for the participation in this lively discussion. I don't know what to comment, but I will start on a positive note. Last week, the American Cancer Society published data on the life expectancy of patients with cancer. In 2023, since 2023, life expectancy has increased. It is now 70%. It was 63% in 1995, and now it's 70%. And this is a very good piece of news. There are many cancer types in which life expectancy is really good. When it comes to liver cancer, it went from 7% to 22%. In lung cancer, life expectancy has doubled. And the same applies to various other types of cancers. And this is thanks to prevention, early diagnosis, and new treatments. These three new elements are what made the difference. In this context, let's talk about Greece. In Greece, there is lower cancer prevalence, but our mortality is higher compared to the EU average. And why is that? Because we have 20% more lung cancers in Greece in men compared to the EU average. So the first measure to be taken is to reduce smokers, the number of smokers. The most drastic intervention for the oncology care will be achieved once there is a national cancer plan that will involve everything from prevention to palliative care. And of course, we have to monitor everything. We need innovation. Nothing can happen without innovation, especially within cancer. Innovation will provide solutions in the future. In the past, chemotherapy gave a life expectancy of just a few months, but now it's years. So we have to think how to organize our system in order to include treatment. And let's talk about more practical things that previous speakers said. In Greece, unfortunately, there are two major problems. The first one is that, unfortunately, we have the same pharma policy since 2012. And this policy was introduced in 2012 as part of the austerity measures. And this does not give any financial incentives to anybody, the entire healthcare system. So this approach needs to be changed. We have to find a balance according to which the state should pay for what it buys and not buy what it cannot afford to pay, because this is what's been happening today. And who pays for the rest? The patients and the pharma industry. the out-of-pocket expenses for patients have increased, and the same applies to the expenses incurred by the pharma industry. Clawbacks that have to be paid by the pharma industry have two dimensions. In Greece, you have to give a 20% rebate once a drug comes to Greece, and this might be given back by the government to you. And many people talk about EFED, and EFED is paid by the pharma industry, by the companies, not by the state. In 2021, this cost was 120 million. After 2021, it's part of the pharma expenses, so it's paid by the industry. In 2025, the budget is now 400 million instead of 120, and EFED doesn't pay for its clawback. So 205 million were transferred to the pharma industry because EFED is not paying for the clawback. Yes, Mr. Angelis talked very well about the new system, what they want to be done, the right control. Thank you very much. I will conclude this roundtable because the organizers told me that I have to. Yes, you can do the conclusion. We will. I really think that this was a very important roundtable. The discussion is not over. We barely opened it, so it needs to be continued. I don't want to waste more time from the conference, but let's get together in another event and talk at length about it. Thank you all very much, those of you that participated in the panel and the audience, of course, and we promise to continue this discussion. Without further ado, let's invite the next panelists on stage.
Θα μιλάω λοιπόν και λίγο ταυτόχρονα και ενώ παίρνουμε τη φωτογραφία. Ωραία, ευχαριστούμε πάρα πολύ. Παρακαλώ την κυρία Φλόρα Μπακοπούλου.
Thank you very much, and now I'd like to invite Ms. Flora Bakopoulou, Mia Nadia Gogozotou, Mr. Giorgos Zarkavelis, Mr. Christos Triantafylou, Dimitris Athanasiou, and Ms. Zoe Stefanidi to join me on the panel.
Ξέρουμε ότι είναι λίγο βαρύ το πρόγραμμα, αλλά...
We do realize that things are a bit hectic and difficult. I believe that the previous roundtable would have required even more time. We had proposals, recommendations for workshops, so we'll probably try to adopt a different dynamic, and this will happen for the next annual conference apparently as well. The minister will be with us soon, but we can start with some introductions. Well, I was kind of hoping that the Secretary General of the Ministry of Health would be the first to address the audience. But since we have time, allow me to take the floor. So this roundtable is part of the agenda as a starting point for us to discuss a very important reform that is about to take place in our country. And this has to do with the reform of the framework on health technology assessment, on HTA. It is something that on a European scale, especially when it comes to aligning and streamlining the various countries and member states. There's been work done since at least the past 5-7 years. And as most of you already know, on a European scale, we are entering a part of the procedure which is quite advanced. We discussed in the previous roundtable some of its aspects. The goal, the overarching goal, being to avoid overlap of work, both as regards submissions of files and as regards accelerating this procedure and making it more efficient. So discussion, what is becoming known as the regulation on health technologies assessment, was met with some resistance. And there was some pushback, both from member states and agencies of these member states. Some felt that they were losing ground in terms as regards their role, as regards their jurisdiction. However, this was not the case, and this was made obvious, and now we've reached a point where there is a new framework, and we are observing all that is happening on a European scale. Our country, next week, will conclude the largest part of the reconstruction efforts for the framework on HTA. And this was a great endeavor that was taken on by the Secretariat General of the Ministry of Health. So I would like the Secretary General to take the floor and tell us a few things about what has happened and what we can expect to see happening in the near future. Thank you for this question, and thank you for inviting me for the second time at a panel. Let me just point out that by 1:15, I need to leave because I need to be at the Ministry of Health today for a meeting. But before I answer to this question, I need to make a comment regarding the previous panel. I didn't have the opportunity. Lots was said, and I cannot reply to everything, so I need to make a selection. There is no such thing as a bias right now. I just don't have enough time to answer everyone and everything. So first of all, I need to stress that everybody needs to understand that the government has acknowledged the issue of clawback. I didn't want to mention clawback because this is a very technical discussion. Here we've got representatives of patients and patient associations. I'm not sure if they can understand all the technical aspects of this issue. This has fallen under the recovery fund. Our country keeps channeling lots of funds in that direction. The pharma industry keeps telling us we need more subsidies, more money. Patients, however, need to be aware that the government keeps increasing subsidies on a yearly basis. by the end of this year, we will have reached 500 million per year. And this is something that we try to do systematically so that we are not dependent on the recovery fund. Patients and their families need to also be aware of the fact that as regards subsidies as a percentage of the GDP, and I'm mentioning the GDP because we all know that countries, member states have different budgets, different economies. So when we're talking about subsidies, when we're not talking about financing on behalf of the government, we need to be specific to that country member. And how do we do that? If we focus on the percentage of GDP. And in our country, pharmaceutical and medical healthcare services and products as a percentage of the GDP are not doing that bad. Do you know what is the overall comprehensive public expenditure regarding healthcare? Regardless of clawbacks, rebates, what have you. What is the percentage of the GDP? Does anybody know? Can anybody answer? We rank either first or second in the EU as regards what the government pays to the pharmaceutical industry. Public money, public expenditure, no clawback, no rebates, not just lots of money, tons of money. And we keep trying to improve that. We need to undertake structural changes in order to allow for better access. In order to reduce clawback, we'll either reduce clawback or access. We know that this is a problem. We know that this is a difficult situation, but let's not keep coming back to it as if nothing is being done. Now, as regards biomarkers, in the last year, we were the only country to introduce new biomarkers as reimbursable, as compensated by the national healthcare system. And we also moved on to new assessments. And this means that we implemented many of the speakers, many of the panelists, many of the members of the audience know that we moved forward in order to improve financing of pharmaceuticals. And there will be a dual change as regards drugs that are being withdrawn. This is something that the company, the industry decides on. And yes, there need to be extra procedures, but that's not what is at heart here. That's not what's important here. Once a product has been announced that it will be withdrawn, and if it is unique, if it is indispensable, if it is about pediatric patients, you realize that we need to view this completely differently. I do not want to name names, but if it is if a pharmaceutical company decides to withdraw a medicine due to clawback withdraw a medicine for pediatric patients for reasons of pertaining to clawback, to me this is incomprehensible, immoral, and I have no idea how we are going to deal with this. I believe that this is the vilest of motions. Last year, we allowed for increases of pricing of old drugs. All things that happen, there are so many things that are happening because we are focusing on the patient. It's not just about novel technologies, new drugs, it's also about older drugs, it's also about trying to keep medicine in our country because they want to withdraw. And the state has acknowledged that we have those issues and we are working on them. But this also requires collaboration from everyone, all stakeholders, both representatives of the state, of the pharmaceutical industry, of the patients, of the organizations. We realize it's not just about extra money, it's also about extra changes, and new changes come with consequences on the physicians, on the patients, on the pharmaceutical industry. We can't have everyone satisfied. There will be political cost no matter what we do because we want to bring about important change. And if we truly are behind this change, back us, because we cannot keep everyone happy at all times. And this is not just the case in Greece, this is the case throughout the world, throughout Europe, throughout the EU. Conditions are difficult, circumstances are difficult, things are difficult, but we don't have a magical wand and we cannot come up with a magic solution. So I apologize for the delay, but I needed to point that out. Coming now to this panel, we have reinstated a new framework for the HTA from scratch. We have taken into consideration the French model that looks at compensation and extra additional benefit. We have with us Ms. Bakopoulou, Ms. Gogozotou, presidents of AOP that look into the costing and invoicing of pharmaceuticals. And they will speak about how we are hoping that this new framework will bring about positive changes in Greece. But what we're trying to do is implement exactly what all stakeholders have clamored for years now. We want to have a better relationship between healthcare quality and compensation and reimbursement. The state does not differentiate between some technologies, and we heard someone say that novel technologies, novel drugs should be tackled same as all. Yes, we hear what you're saying. But when we're talking about negotiating, when Ms. Gogozotou will be negotiating based on the opinion from the committee of Ms. Bakopoulou, they will need to understand what the patient requires and what the pharmaceutical industry requires. What does that mean? Some companies will need to pay more clawback if their drugs are not considered as innovative. If we want to manage novel technologies differently and healthcare technologies differently, we need to view novel technologies as different, as distinct from other products. What does that mean? That I need to cost this to find a distinct way of costing this. So this is what I had to say. We've got with us Ms. Bakopoulou, Ms. Gogozotou. They are the ladies in charge. Let me repeat that I will need to leave by 1:15. Thank you very much. I would like everyone to have the opportunity to say a few words, because everybody needs to leave at some point. Some people need to catch a plane. So I beg and implore you to be as understanding as possible. So I will stick to the schedule, to the agenda, and ask Ms. Bakopoulou, the president of the committee, the chair of the committee for the assessment and compensation of medicines, and I would like you to tell us how you view the new framework on HTA and what you think developments will be from now on. As you know, we have run the technical assistance program from the European Commission successfully, and we are now undertaking pilot stage the procedure for the first drug. I believe that so far results have been satisfactory. Yes, we can do more in order to ensure participation of assessors in this procedure. These are requests that we have forwarded and submitted to the Secretariat General, and I believe that we need to move in that direction so that we have national assessors, which is a demand, a consistent and persistent demand on behalf of the European Commission. So you believe that we can have such assessors? It's up to us. We have already interviewed several universities so that they may become subcontractors to the Ministry of Health in order for us to be able to supply assessors. The Europeans keep asking for assessors, they insist, and it's also an opportunity for our country to be able to create assessors and patient experts, because in that way it will be easier for our country to pay them when the time comes as well. I believe we can do it, and we should do it. Thank you very much. Moving on to Ms. Gogozotou regarding the day after in health, in HTA, what do you think the demands and difficulties will be?
So, what do you think will be the future in HTA in Greece? It is a huge challenge, but at the same time, we've been looking forward to it for many years now, before even these two committees were established. Ever since we've been keeping track of HTA and the practices in other countries, we thankfully now are at the point of implementing something that has been being implemented in Italy, for example, since 2012. This sounds very good, but at the same time, the companies that will participate should be certain for the efficacy of their technologies. It will clear the landscape because there are treatments that are conditionally approved by EMA until they demonstrate their treatment, whether they cover unmet medical needs, whether they increase life expectancy, and whether they are better than the already existing therapies. So this is what an assessment needs to prove. It's very difficult to implement this new system, and I truly want to see how we will be able to link all the databases available in Greece in order to better utilize this data, so as to be able to set the indices that will be followed, that will be monitored, in order to decide on the reimbursement of said drug. The risk mentioned by the Secretary General is the following. So, if you remove something from the reimbursements, then this amount puts a burden on the others. We say that innovation is not reimbursed in our country, but there are also cheap drugs that have to leave the country. And there is a huge increase of the expenditure by FED. It has tripled in 4 years, which means that patient access is not that difficult. Through EFET, we can get drugs that have been approved and authorized by EMA, and we are able to bring them in our country without any extra barriers. And to be honest, the negotiation leverage is lost now, because now many companies say, oh, I already bring it through EFET, don't reimburse it, I don't care. So we need the drugs quickly in Greece. We bring them to Greece through EFET. This process needs to be accelerated, but at the same time, we need more just distribution of reimbursements. The efficacy, the treatment supremacy should be at the focus of the assessment. So a drug that has proven to be effective should have fewer returns, but a drug that has not proven to be all that effective, all that efficient, should not be reimbursed. So co-responsibility applies to the state and companies alike, so that companies bring to the market proven drugs that improve life expectancy, reduce side effects, because we don't care about patients who will live longer but with a very bad quality of life. No, We want patients that will have also a good quality of life. Thank you very much. Mr. Zarkavelis, what do you expect or what would you like to see from this new decision-making system? Good afternoon. Thank you very much for the invitation. I'm here as an oncologist. I work at a regional university hospital, not in Athens. We have about 20,000 appointments per year, and it covers the western and northern Greece. This new process aims at reducing the time to access to novel treatments, we have, of course, to be fair. I agree with Ms. Gogozotou. There are drugs today that even they have been very recently authorized by EMA, we have the opportunity to bring them to Greek patients, Greek cancer patients. But on the other hand, the truth is that there are delays in having a drug reimbursed that is already being reimbursed in other EU member states. What's missing so far in Greece, and in the past month some things have changed, this process of recording patients in the cancer patient registry has now started, and this will allow us to take the information, to get the information we want. So, a drug that we will reimburse, is it effective for a patient that is in the registry? Quite often, the drugs that receive authorization have been authorized based on a clinical trial that has very specific details when it comes to the population that's included in the trial. And quite often, we are faced with a completely different population. For example, more aged people, more aged patients. So we need to be able to receive real-time information, and I'm counting on this in the cancer patient registry. There are examples of drugs that we thought they would be revolutionary, but they did not prove to be that efficient. But they were being reimbursed, and this burden was incurred by the budget, to the detriment of other drugs that could have been more efficient for patients. But I would like to believe that under this new process, with the cooperation of all relevant stakeholders, we will reduce the time to access to novel treatments. So Greek patients will be able to receive the necessary treatments on time, at the time they need it, eliminating the inequalities with the rest of Europe. And I'm talking about universal coverage of cancer patients. When a drug receives authorization even from FDA, they can get it. They can get it through the processes that already exist. Thank you. Universal coverage is very important. It is a major issue that is a priority according to the World Health Organization. The local office has supported a lot this reform of the assessment process. How did you experience this process, and what are your expectations? Because I think you are following up on a set of indicators. Thank you very much, Mr. Kapetanakis, for the invitation. Mr. Athanasakis, based on our experience, the job that has been done is very good. The colleagues at Copenhagen are very satisfied. As the coordinator of Health IQ, I will focus on data. As we know, HTA cannot be based only on clinical trial data. We need real-world evidence. We need national interoperable registries that show the clinical burden, the use of resources, and the inequalities of access. Without these registries, we cannot assess the actual impact of the technology in practice. We cannot set the right priorities, and hence we cannot design the right health policies. Also, the concept of value is not only biomedical. Patient-reported outcomes, the so-called PROMs, should be included. Also PREMs, equity metrics, and unmet needs using the right methodology, because needs are not measured only based on morbidity or mortality. The quality of life and should be taken into account. So we need a holistic, human-centered approach to value. When it comes to Health IQ, what we've done is that we have already developed a series of quality indicators. We've developed the Quality for All platform that has been presented to the Minister of Health, and the regional director of WHO for Greece will present it officially to the Minister of Health on the 3rd of March. Out of these indicators, most of these indicators will be based on already existing data, and the next stage is to further improve the quality of data. Concluding my remarks, I would like to say that HTA shows what needs to be reimbursed, and the cancer registries show whether what we've reimbursed has an actual impact on the everyday life of cancer patients. So we should care for both. Quality of data is very important. Integrity of data should be ensured, because when the input is garbage, the output is garbage as well. We need reliable data in order to draw impactful health policies, because we all serve people, we all serve human beings, and we need to understand that. It's quite often lost in the midst of all these processes. Thank you very much for this good news. These are very good news. If this platform is sustained and receives quality data, it will help us navigate the system. And Mr. Athanasiou, I know that you are very well concerned with health technology assessment. Your association has organized many actions to empower patients. HTI should be an inclusive process based on the international practice and literature. What's your take on that? What do you see happening in Greece and in Europe?
Thank you and good afternoon. My name is Dimitris Athanasiou. I come from rare diseases. That is my field of expertise. I guess you realize that there is a direct link to cancer, because cancer and rare diseases go hand in hand. So it's interesting to look at how we can tackle the distinction between them. Let me say that Ares was very courageous when we met with WHO, because the plan only mentioned a label, only labeled participation of patients, and there was nothing beneath that. And during that meeting, I saw Ares and I asked him, maybe we should also participate. It was quite an oxymoron because, on one hand, patient associations should participate in drug evaluation because we've seen files and folders, and we've been seeing them for 3 years now, either as members of the EMA or GCA, and in our country we don't have access, or we cannot facilitate access via the regulatory pathway. So at this point, I would like to salute Aris for his courageous decision to include us, and that comes with lots of responsibility. We're not there to look pretty, and we're not ready. The system is not ready. I believe the other stakeholders also are not ready. But for sure, we are not. So we need to take on the effort. We need to rise higher. We need to find the right staff and train them. I hear Aris when he talks about access, but we also need to realize that we all have a role to play. We all have our own biases. Some are for profit, some are not for profit. And then there is the reality, the everyday reality, which is definitely unclear. There's lots of pathways intertwining. And yes, when it comes to reimbursement, I believe that the pilot went very well. I believe we can also participate on the external aspect. We've got strong allies in patients that participate in assessments, and their participation is substantial because sometimes it can lead to a complete overthrow of the outcome, because the expert of a disease is the patient of that disease, suffering from that disease, and that's information that nobody else has. So somebody might be able to analyze data beautifully, but be fully unable to understand what it means with struggling on a daily basis with that disease. So their input is invaluable and irreplaceable. Everything else is replaceable, and that's something that I believe we all need to take into heart and into consideration. In closing, I would like to say that when it comes to educating, when it comes to training, we need to deepen and broaden our efforts. We need to understand what are the other players, what are the other beasts in the jungle that we live in, as we call it in rare diseases. We need to realize that we've got experts in the academia, we've got experts among patients, and we need those people. We shouldn't push them aside. We need to send them abroad. We need to reimburse that. We have the willingness. Aris is quite committed, and everybody should do their job professionally, systematically. I believe it is high time in Greece that we as patients have a role where we respect ourselves. We should no longer be pretty observers and decorating a panel. We need to be catalysts, because these round tables exist because we exist. Thank you. I fully agree. And I would like to say that the way that you provide the input of patients into this procedure is beautifully structured, and it's quite clear. There are examples. We have tried to merge, bring together various stakeholders. This is a bit more complicated. We will be undertaking our own efforts, moving in that direction, but it's very important to have patient input so that this input is delineated and represented in a well-structured way in specific sites. I know that Aris needs to leave us pretty soon. So Aris, please give me a couple of minutes because we've got questions from the audience. But before that, let's listen to Ms. Stefanidi, a representative of the pharmaceutical industry. Thank you very much for the invitation. I would like to put forth some practical issues. We upgraded and we changed procedures, not because it was imposed by the European Union, but rather because the goal for all of us is to constantly be improving services and products provided to patients. And given that access is a non-issue, let's call it that, this improvement needs to come hand in hand with improved efficacy. If that is the reason why we're moving in that direction, we need to focus on the practical issues, methodological and substantial problems that we've been facing so far. First of all, that there is a confusion as to what happens in Greece. All that we use comes from abroad. We've got data which are in silos and we have no access to that data. So if we're discussing about improving efficacy and efficiency, we need to look at the data showing us where we stand today. And there's registries that come with a huge amount, a plethora of data, which is now inaccessible and therefore missed source of wealth, of information. This should also be taken into consideration when we're talking about improving efficacy. What we have so far in terms of data is that so far there's been assessments, a huge effort was undertaken by the committee, but we're not sure if this has had an outcome that improves efficacy, so we need access to the data. And we need to also decide on the angle. Should we look at the pharmaceutical cost? Should we look at pharmaceutical expenditure? Should we be looking at the healthcare system? Maybe we are a country that has substituted technologies, other technologies, with medicine, pharmaceutical products. Is that the right way to move forward? I'm asking questions. These are not rhetorical. These are genuine questions. You said that we need assessors in our country. A small part of assessments will be done centrally in the coming years, but a huge part of assessments will be done locally. The Europeans are asking for assessors. I'm not saying that we shouldn't give them assessors. If we do not participate in the joint assessments, it is a loss for us. We've got so many people who are so knowledgeable. I'm not attacking you personally. I'm asking you, generally speaking, if we do have so many good assessors, why not also send them abroad? But we haven't seen assessments so far. We know that there are assessments being carried out, but the results are not publicized. Each company receives an extract of the results of the assessment, of the findings. Please, let's try to avoid dialogue. And there's other players in the ecosystem when it comes to prescription regulations. The national list, for example, is a black box. We don't know what happens when we need to object. How do we object? This is also something that needs to be regulated in order for us to be able to move forward. Even therapeutic protocols. Are they therapeutical recommendations and indication, or is it also something that is reimbursed? Should we cost them? Should we not cost them? Should we post-costing them? Should we decide on how they can become more efficient? These are all questions that I'm asking because they pertain to the entire procedure of assessment. If the overarching goal is for us to ensure the improvement of services and efficacy, then all this needs to be set into motion, and we need to constantly be measuring all that is being done. Thank you very much for your input. I believe that most of us agree on lots of what you've said. I would like to ask the Secretary General for a few words. I know that there's a question towards the Secretary General. Until Ms. Barbataki phrases her question, let me just say, assessors is something that is moving forward by ministerial decree in order to find the right motivation and incentives. 511 is going to be removed, but it will not be fully removed. It will go into undership because depending on the category of medicinal products, we will be providing extra capacity. We're issuing new guides. We're changing the framework. We're trying to strengthen the committees and the overall assessment procedure start to end, start to finish. But we mentioned effect, expenditure, other countries. We're trying to put everything, to arrange everything in some modicum of order. And this is not easy. It cannot be done in a single day. As regards the third question, yes, we're moving forward. But as regards the assessments from the committee regarding medicines for human use, I can tell you that we're moving forward. They are being reimbursed. Patients have been included as institutional representatives, and there are delegates. There has been a selection because we couldn't listen to everyone, and we're trying to keep everyone happy to the extent that this is possible. And of course, there can be no public opinion regarding the assessments, but we're making changes to the entire framework. Let me also add that next Monday there will be a presentation of the TSI project with the support, of course, of WHO and the Athens office and the regional headquarters in Copenhagen and Geneva. We've got 3 offices working together for the first time ever, and there will be a presentation next Monday of the pilot that was run, of the studies that have been conducted, and lots of you have already received an invitation. There is unfortunately restricted capacity, but you can now join us online as well. I don't want to keep you because I understand you need to leave, and I don't want to shift the focus from HTA, which is very important. But let me just highlight this. We're talking about accountability, responsibility, which is very important when it comes to patients. And we've got many patient associations represented here. And when there is a rebate, 50% of the medicine is financed by the pharmaceutical industry, which means that we take on more accountability than if it's 70 to 30, the ratio is 70 to 30, then things are not fair. So I would like to discuss the clause of co-responsibility. We want some form of ability to anticipate what will happen in the near future. And I cannot, I do not believe that words like immoral should come into play. We all want to sit around at the same table and come back to some solution. We know that the UK is changing things because things are not sustainable, and we can look towards the next step. I'm not talking about this 15, but I wanted to make that comment so that it is taken into consideration. I fully agree. Well, I wanted us to reframe this immoral decision. I believe that 17% is a very important decision. Let's agree to disagree. Comment off microphone. Nobody is withdrawing medication on their own. It's a discussion. Yes, we have identified the issue, but I still consider that such a decision is immoral, and I feel that we need to have this discussion. Do we have time for one more question? Question off microphone, unfortunately, cannot be translated. I believe that this was not the topic of our discussion, but thank you. We spoke of payback and the consequences. Thank you very much. We can now conclude this roundtable. There is a new roundtable that begins immediately.
Τους ομιλητές του τραπεζιού. Καταλαβαίνω ότι το ενδιαφέρον παραμένει πολύ ψηλό.
I would like to thank the panelists. Thank you for striving to keep the time allocated to you. Now I would like to invite on stage the moderator of the next panel, Christina Maria Ms. Nikki Psalti, who is a health journalist at υγεία.gr. Ms. Psalti.
Καλησπέρα σας. Να καλέσω παρακαλώ πολύ την κυρία Χριστίνα Μαρία Κράβαρη.
I would like to invite on stage Ms. Christina Maria Kravari, Secretary General of Public Health, Mr. Konstantinos Sirigos, Professor of Medical Oncology, Ms. Debra Montag, President of Lung Cancer Europe, Ms. Daphne Kaitelidou, the President of the Organization for Quality Assurance in Health, Ms. Georgia Hardavella, lung specialist, Mr. Athanasios Halazonitis, the President of the Hellenic Radiology Society,
Πώς είναι αυτό, ακούγεται, είναι εντάξει, να υποθέσω ότι είναι εντάξει. Σας καλωσορίζω, σας ευχαριστώ.
Welcome, thank you for being here with us. We will have a discussion and we will hear from all of you. The topic of this discussion is the design of the care pathway in cases of lung cancer. It is important to say that lung cancer requires a clear and quick pathway, and we will try to map it today, hearing different perspectives. We will hear the perspective of the state, the clinical perspective, the imaging perspective, and the European experience, the European perspective. And we will hear the patient voice as well. The aim is to highlight all key steps that will lead to a human-centered and effective lung cancer care pathway. So, in the previous panels, we focused on innovation, but now we will focus on a very serious and difficult disease, meaning lung cancer. Thank you for your attention. I will start with you, Ms. Gravari. Thank you for being here with us. I will give some time for all of you to share your remarks, and then I will ask you a question. What I would like to say is that right now in the system, there are inequalities when it comes to patient access to healthcare services. Lung cancer patients are no exception to this phenomenon. What does the ministry intend to do in order to tackle this phenomenon? Thank you for the invitation. I would like to thank the president of ELLOK, the Hellenic Cancer Federation, to participate in this very important panel. I would like to say, as the Deputy Minister said, that right now we are shaping the pilot program for screening, lung cancer screening, taking into account the guidelines that have been submitted by our extended scientific team in cooperation with ELLOK in June 2023. This is a very important first step on the part of the Ministry of Health. We've taken into account geographical restrictions and limitations. We know that this sensitive part of the population have very specific needs. But starting from early diagnosis, we want to create a network of care, and the network of care begins with prevention. And then we need a structured pathway for lung cancer patients within the healthcare system in cooperation with the interdisciplinary team and patient associations, which are a key partner to the Ministry of Health when we shape all our policies. You talked about social inequalities. It's something that we've identified and we've taken into account in all strategies that we are developing. And so far, mobile health units help us have access to patients that live in remote areas. So this is the direction we're moving towards. We are now working on the pilot project, taking into account the geographical limitations that exist. I would like to give time to the other panelists as well, and I will come back to answer your questions. Thank you. I would like now to go to Mr. Konstantinos Sirigos. Professor, my question to you is the following. Of course, we've been talking about lung cancer, and we need to talk about the therapeutic developments that allow patients to have hope to be treated. I'm not going to say cure, I'm going to say treatment. So there are therapeutic developments, but at the same time, there is the issue of access to these developments. Would you like to further elaborate on that? Right now, Oncology is at the forefront of medical research, at the forefront of innovation. Things change day after day, year after year. It has been estimated that about 30% of medical knowledge in the next year will be obsolete, and another 30% needs to be reviewed and updated. You can understand how quickly science advances. This is relevant to early diagnosis, access to novel treatments, etc. Unfortunately, we are not all of us able to keep up with this rhythm. Not only scientists, but patients as well. There are those that are not that fortunate. This is why we need policies and strategies so that everybody can benefit from these developments. Remote areas have been included in the design, but what about deprived populations that can be found in urban centers? Populations that live in prisons or in mental health institutions, or people in poverty. People that have been poor in their childhood, even if they get richer afterwards, they have fewer chances to survive cancer. So cancer is a deeply toxic disease. Now, when it comes to access, we've heard a lot about clawback, about a lot of aspects. Right now, Greece is doing really well when it comes to access to novel treatments. But this is a financial hemorrhage because they are paid through effect. I'm worried about the future because I can see practices implemented by certain companies in order to avoid invoicing their products in Greece. This is very concerning, and it should be the concern of patient associations or the medical community. Some companies advertise that they have a really great medicine, but they don't bring it to Greece. And as I said before, there are early access projects. They advertise them so people find out that there is something useful, and then this project is no longer available. These practices should be banned. It's true that most EU countries, EU member states, are not able to pay, but it's not only the responsibility of the state. It is the responsibility of everybody, of the patients, the medical community, to demand some things, and then it's up to the companies to have a moral and ethical code. So there is the issue of navigation of patients through the system, which is not always easy. Let's go to Ms. Hardavella, who is a pulmonologist at Soteria General Hospital. You are the specialist that addresses these patients that feel confused in this entire system. There will be delays, they might have to repeat tests. These problems might have started even a step before they come to you. So I would like your comment as to what would be the best sequence of action in order not to lose valuable time and avoid delays in the system. And this pathway to be an accessible pathway, an effective pathway for all patients. Thank you for your question. And I would like to thank ELLOK and Mr. Kapetanakis for the invitation. In order to reach the best possible sequence of tests and procedures once the first symptom appears, we need to see what happens in our country. And I will share with you the experience from the largest pulmonology hospital, Soteria. We have started mapping the current situation. It seems that the diagnostic pathway is probably the most complex compared to all other cancer types. Patients try to access the system using various ways. The percentages are surprising. 18% of patients that come to our offices, to our practices, have gone straight away to the oncologist without having a biopsy. So more time is lost. 13% gets the CTA and then go to a specialist which might not be the right specialist for their disease. So we have healthcare services, but the way in which access is gained is rather complex and weird. This is what we realized in the Hellenic Pulmonology Society and the Hellenic Thoracic Society. So we asked the cooperation from the Hellenic Thoracic Surgery Society, the Hellenic Society of Nuclear Medicine, the Hellenic Radiology Society, and ELLOK, and we established a task force in order to develop guidelines about this pathway, which should be adjusted to the Greek context, to the capabilities of the Greek national healthcare system. And of course, patient-centered. That's an effort that we are now embarking on. It will start on February. That's the end goal, to come up with this best sequence of actions. And it's the second time that the society, together with patients, starts this effort in order to come up with something that can be submitted to the Ministry of Health and then be implemented in a pilot manner.
Now, my next question to Ms. Kaiteliadou is directly linked to what you've just said. This task force that is going to be created for the lung cancer patient is going to try to tackle obstacles and difficulties that you know of. So would you like to tell us what needs to be done so that there is benefit for the lung cancer patient? It's easy to claim, but we all know that we've taken, for example, our mother, our father to a hospital, and we've gotten lost in the aisles and wards and corridors trying to find our way. So how do we overcome such challenges, such obstacles? Thank you very much for the question, and thanks to ELLOK for the kind invitation. I believe that the first panelists have already highlighted the challenge that exists, which is the lack of a coordinated pathway in the system. We have a system which can offer access, which is open compared to other systems. There's no such thing as gatekeeping, and yet some people might think that it's not the case. Actually, we see it practically that access is not easy, it's not open, because both for lung cancer and other diseases, we have not been able to map this pathway so that no one's left behind. This is exactly the aspect that we must focus on. All studies and research, both national scale at a European scale, indicate that those with a higher financial status, with a higher educational status, will find their way across the system, within the system, but things are far more difficult when we're talking about inequalities, when we're talking about non-mainstreamed population groups. So a framework for lung cancer in our country is indispensable. Unfortunately, we have very poor statistics. We still have smokers. It's declined as a habit, but it's still quite prevalent, especially teenagers. Teenage smoking and vaping has tripled in the last 5 years. It's moved all the way up to 27% in 15-year-olds. So detection is very important. Screening is very important. And we did something last December. Most people present here today had been invited and were informed about the outcomes of what we did. And what we did was focus on what needs to be done. A national strategy overall for cancer, but also specifically for lung cancer, which is adapted to Greek reality, which is mapping the pathways all the way from prevention, early diagnosis, up to the extreme of palliative care. We need to have a continuum, and a continuum that is recognizable and understandable by the patient, so that, for example, what we have identified is that there's a need for a navigator. We ran a study a couple of years ago, not long ago, and we realized that for kidney cancer patients, once they enter the hospital, things move swiftly, patients are happy, satisfied with the quality of services provided. But what happens until they get to the hospital gate? And there were cases where 3 to 4 months were lost until those patients could navigate the system all the way to the hospital. So we need to identify our lacks, our unmet needs. Lung cancer is not an easy task. It's not just about smokers. It's also about people that live in highly polluted areas, people with a family history. So this is a program that needs to be implemented. And within the discussion we held, we all agreed upon the fact that there needs to be sound governance of this endeavor, that there needs to be a very good combination when it comes to the traceability of patients, excellent design for screening, because we need to overcome the fear, we need to overcome the stigma for some people. We need to strengthen primary healthcare in order to achieve this, and we need to strengthen the patient. So we are the first step is already underway. We are mapping the challenges, the difficulties, and the next step, coordinating a new procedure with all stakeholders, among all stakeholders, this is also underway. And what is very important with such endeavors is continuity, consistency, and a follow-up. Since the ministry has already decided to run this program, then we need to have a pilot. We need to ensure the continuum. We don't want a once-off firework going into the sky. We want something that for the entire country will ensure that the proper pathway is established and acknowledged, recognized, that it's made visible. And I would like, of course, to thank all the participants to that endeavor, the representatives of the Radiology Society, the academia, many societies actually, the academia, the patients. I believe that there's a lot of work that is moving in the right direction. Okay, so I'm noting that there is this endeavor in order to ensure that we are improving timely diagnosis, early diagnosis, and of course this includes screening of lung cancer. And I know that within this framework there is an examination which is considered key when it comes to screening and early detection of the disease. The low-dose CAT scan point when it comes to imaging examinations within the screening program. So could you please talk to us about the value, the benefits of this examination, and how would you comment on the program that we are expecting to see running soon? Because as I understand, we're still at the early stages discussing optimal CAT scans performed on specific target audiences, what benefit can we have? 50 to 70% identification of cancer at first stage, stage 1. In the beginning, you didn't want to speak about cure, but if we catch the disease at that stage, we can cure the patient. That is extremely optimistic, what you're saying. That's why I tried to avoid the term cure. I apologize for interrupting you, but it's to save time. So when a patient leaves the imaging department but does not have such a program underway, then he leaves at a later stage because he did not get to us on time. So with this prevention program, what can we achieve? Identify cancers, lung cancers, at a much earlier stage. And with patients participating in this program, there will be an increase in this early detection by 25%. It's huge. And even the chest X-ray among smokers, something that we're all forgetting nowadays, can bring down mortality among smokers due to lung cancer by 20%. You mentioned traceability. That is an issue. Among international programs, we see that they are focusing on 50 to 60-year-old patients to offer them this low-dose imaging test. And these are either smokers or people that quit smoking after more than 15 years of smoking. Or, I think you've covered just about everything, populations that have been exposed to specific environmental triggers like asbestos. For example, perhaps employees in shipyards should be included. Or it could also be people with a family history. Who is that not for such a program? People that already have an advanced form of the cancer. And who else could be excluded from this program? People who are smokers, but for a much lesser time. So before you come to us radiologists, because of a national program, we, the clinical physicians, need to identify who of you will come to us, because resources are missing, resources are lacking, unfortunately. And what happens with the state? The state is now listening for the first time, hearing for the first time this low-dose imaging exam, and has therefore not identified a cost for it. You might ask, do we have the necessary equipment? Yes, we've got the greatest per capita ratio of such equipment in Europe. What do we do not have? We do not have a diaspora, a dispersion of this equipment, especially across insular Greece. So the pathway towards treatment, one might say, is interrupted when it comes to islands, when it comes to mountainous villages in continental Greece. We have the equipment, but perhaps not necessarily everywhere. And we have enough radiologists. We've got some radiologists, but we're not sure if they are enough. What do we not have? We do not have a protocol that abides by European and international guidelines as regards the medical note that accompanies the image procured. There is no such protocol, which means that the state does not care for the medical notes. So we need to regulate those medical notes. And what else do we need? We need a software of volumetric analysis of the nodes detected. This is something that we do not have right now, and it is mandatory as per international literature. What else do we need? It is not mandatory, but it is desired. we need a CAT, computer-assisted detection system, so that if there is something that I, as a not-so-good radiologist, miss, then the system will identify it. It will not replace me, but it will substitute any deficiencies I may have. And what else do we need? Awareness raising, so that people are convinced that they need to have this screening examination, because screening entails asymptomatic patients. We've got among us people that have such nodes and they don't know of these nodules and they don't know of it. And let's say that we detect those nodules. And we're very happy, not for the patient, but because we've actually detected them. So what do we do after that? There are protocols that need to be introduced into our daily routine in order to, and this is not science fiction, it's part of all protocols in the EU. We need to understand the progression rate of this nodule. So what we need? Re-examination every 3 months. So where does the clawback come into play with this? So what do we ask of the ministry? As you did with breast cancer, and we salute your efforts, we want to see the cost of this very important imaging examination excluded from the closed budget. Otherwise, nobody is going to do it. And we need the support of the private sector in primary healthcare. I will stop here, and I apologize if I tired you. You did not tire us, and you set forth very interesting information and data. But since now we're talking about designing the pathway of care, and the patient's voice is very important, we have among us 2 representatives of patients. First, I would like to ask Ms. Montag.
I would like to ask you, from the European experience and from the things that you have just heard about the screening program that it's going to be implemented in Greece in this year, 2026, in a pilot form, of course. Do you believe that such a program could actually help patients along the care pathway, the healthcare pathway? And from your experience as president of Luce Lung Europe Cancer, at which point along this health care pathway do you believe that patients are most likely to get to feel lost, to fall through the cracks, to be unable to find their way towards a treatment that they saw there's such a need for them? Thank you.
Firstly, I'd like to say thank you very much indeed for the invitation. I'm delighted to be here representing lung cancer patients. So looking at it from a holistic point of view, I think patients can fall through the cracks from before diagnosis all the way through. I think it's fantastic to hear that you will have a pilot for a screening program. That's absolutely brilliant, and that will, as has already been highlighted, you know, really increase the rates of diagnosis of earlier cancers, which will lead to people living longer. If we don't want to use the cure word, that they will be living for much longer and very healthily. I think one of the challenges is what we mustn't forget are the lung cancers that are they're not due to smoking, and you know they can make up to 25% of the population of lung cancers, and a screening program won't help them. What we need is to enable earlier diagnosis is we need primary care physicians to be a lot better at thinking about lung cancer. You know, I mean, I would love to see a comprehensive training program for all medical trainees where, you know, they really spend a lot of time to understand what are the signs and symptoms so that it becomes second nature. So if someone comes to them and they say they've had a recurrent symptom, whether it might not be a cough, it might be a pain in the shoulder, but if they're younger and you haven't seen them on a regular basis, so they're not a hypochondriac, that's one of the things that gets levied, that they might be a hypochondriac. If you haven't seen them before, they're not likely to be, but if they're complaining of recurrent symptoms, then what doesn't happen at the moment is for primary care physicians to think, oh, let's exclude lung cancer at this stage. And that's what we're talking about, is excluding it in the vast majority of cases. You know, I don't want to scaremonger, you know, the general public to think that any shoulder pain is, that's it, you've got lung cancer. But it is an important factor. That will bring in earlier diagnosis for those oncogene-driven lung cancers. So that's definitely something, and we know from, there've been a multitude of studies that for every 4-week delay, that can impact survival by 10%. That is significant in a younger population. So what I would say is every day matters. So, you know, when we're starting to design care pathways, it is really what's the fastest route to get a conclusive diagnosis for that person. In the UK, they're actually starting a pilot of self-referral. And again, the worry from the people who didn't want to start the pilot was that they would end up with all the worried well turning up. But it hasn't been the case. Actually, the diagnosis rate of lung cancer for the ones that are self-diagnosing is the same as if primary care has referred. So that says something that patients know their own bodies. So if they're complaining, there's a reason for them complaining. So I think that's very important. I also think when you're designing a care pathway, and it's already been mentioned this morning, around the support for patients, you know, a diagnosis of lung cancer doesn't come alone. The multitude of patients who are diagnosed will end up with mental health challenges, you know, anxiety and depression. You know, it should be expected, and yet so few patients are asked about their mental health state and how they're coping with that diagnosis, or the treatments, or the surgery, which can be extensive, you know, and we need far more mental health services that people, not just the patients, but their families, because a cancer diagnosis doesn't affect one person, it affects a whole family. And so everyone should be looked at and supported. A lot of people don't know whether they should exercise or not, so they all give up. Well, actually, that's not helping the situation at all. You know, you want people back on their feet, so there should be, you know, prehab and post-hab, exercise, you know, support, and dietary advice as well. You know, it's rare to find hospitals with dietitians that patients can access. So I think there's a whole multitude of steps where patients can, they do fall through the cracks. We're waiting too long for a diagnosis, and then you're waiting to be referred on to start treatment, you know. So I'd like to see, with the care pathway that's being designed, is, you know, optimal use of your resources, in giving patients access in the evenings, not just during daytimes. That will help as well. But for me, it's great news around the screening. The evidence is all there. We know it works. We know it will save lives. So that's fantastic for people who are affected through smoking. What we now need to look at is those populations that are diagnosed without a link with smoking, and how do we find those earlier? Because, you know, they're under 50, 2/3 are very often female who are responsible for their households. So the knock-on effect is enormous if we don't.
I thank you very much for everything you told us. It's very important and allow me to... Θα προχωρήσω στην επόμενη ερώτηση της κυρία Πατέλη.
The question to Ms. Corina Patelli. You are also representing patients. You represent Fair Life. The question is the same. At which point in this path do patients and their families, as Mr. Montag said, it's not only about patients, it's their entire families, an entire system that suffers. So, at which points they need support, and do they receive such support? Thank you very much for the question. I would like to thank Mr. Kapetanakis and ELLOK for their kind invitation to Fair Life. I would like to say that we believe that the most important part in this care pathway appears before the patient appears before a physician. This is very critical in today's meeting. The lack of screening in combination with the social stigma around lung cancer because it's linked to smoking, this leads to delayed diagnosis, unfortunately, when the cancer has already advanced. So, what I would like to say before answering your question is that unless we do something about the social stigma, unless we include screening, and if we continue having 70% of diagnosis at an advanced stage, we don't prevent, we keep generating more and more patients because the system intervenes when the disease is already there. I'm very happy because the ministry and the people from the ministry, because it's the people that make the difference, people such as Ms. Kravari. So they have announced that the screening program is on its way. So once this happens, I know that at the pilot stage, everything might not be perfect, but as Deborah said, the lung cancer diagnosis is accompanied with complex medical decisions, many problems, absence from work, financial problems, and patients need support all the way through. It's not only during the first phase of diagnosis when they lose the ground under their feet, both them and their families. It's experienced in a tragic way. They don't get the right information because there is no guiding and support. There is also the second phase, the phase of treatment options. It's important to have an interdisciplinary council in order to give a holistic approach. It is important to reimburse the biomarker tests, to have a full biomarker panel in order not to lose the opportunity to receive targeted treatment. And also there is psychological support that should be all the way. We have supported more than 1,100 patients and their families, and they feel grateful because we have managed to do that. But we're talking about 7,000 diagnoses, so you can see how many people have not received support. I focus on screening. It is very important to prevent and not to generate more and more patients. When it comes to psychosocial support and palliative care is not just end-of-life care, hospice care. It is having a palliative care team once there is a diagnosis, together with a physiotherapist, a dietitian, that will guide the patient and the carer through this pathway. Because the carers receive so much pressure that they cannot stand it. And we know that in Greece, we rely on the family, we rely on the personal support by healthcare professionals. Physicians receive a lot of burden. They need support and strength as well. And of course, there's the family, there are the physicians, and we need a holistic approach in order patients and families to feel more protected. That's all on my part. Thank you very much. I was succinct because I know that we're running out of time. Now, I would like to ask from Ms. Cravary to conclude the panel. What can by telling us about this screening program? A lot of things have been said. Have all these things been taken into account for this pilot project? When our distinguished panelists were speaking, I took a lot of notes because I have to convey them to our political leadership, and I want to have a better plan now that we are at the end stage of developing this pilot program. And I want to clarify that this pilot program, everybody has said yes to it. Everybody knows how important it is. But for us, it's not an individual intervention. It will be a point of entry to an integrated, comprehensive care pathway. So, in this organized pathway, we should also take into account early referral for tests, interconnection between services, the role of primary health care, and active involvement of patients. Patients should be involved in the shaping of their treatment. Let me add that something we've taken into account is better coordination of these actions between the scientific community, the patient associations, and the better cooperation between all stakeholders. That's just a first step. This screening program is just a first step, is a bet we want to win, is a good challenge in order to collect data on the effectiveness, acceptance, and collective challenges that will be highlighted through this screening program in order then to make use of this data and improve, optimize the design of the screening program and extend it to other population groups as well. There was a press conference in the Ministry of Health today for the extension of the screening program with the introduction of renal dysfunction and morbid obesity. I would like to draw on this occasion and say that investment in prevention is an investment in public health and is the only way to ensure long-term sustainability of the entire health system. It's not only about cost, it's about how many lives we can save through these interventions if they are offered based on a design, consistently and with social responsibility. This is what we've been trying today, taking into account the EU guidelines and the very important tools and pathways already shaped in other countries. The Ministry of Health is here to take into account all these parameters and collectively shape a new lung cancer care pathway. Thank you very much. At this point, I would just like one comment from each panelist on whether navigation and access to the healthcare system will be better after this screening program. A very, very brief comment, though. Mr. Sirigos, do you believe that it will actually improve access? Is it a positive first step to help patients?
I believe it is a very positive step. It's not a first step, it's a first mile covered. There are very few countries that have gone down this road. So we will belong to an elite number of countries. As the chair of the Hellenic Society for Lung Cancer, I can tell you that we will offer our support. I see enthusiasm and I approve of that. Ms. Hartavella? Thank you, Mr. Sirius. I know, Ms. Hartavella, that this is something that is very close to heart for you because you come into close contact with the patients. You will be among the people that will first meet them when they start this program. Are you convinced that this is going to be successful? I'm very, very positive and optimistic. Scientifically speaking, we've been working on this pilot project for 3 years and a half before submitting it to the ministry. I'm very happy because the ministry took into consideration our proposals. We are there to help and support them in any way asked of us. The pathway has been mapped, has been designed, adapted to Greek reality, so we are quite eagerly looking forward to seeing it implemented in real time. Thank you very much. Ms. Kaitelido, a comment from you. I believe that you are one of the strategic developers of this endeavor. Do you feel that there's still lots to be done, or are we on the right course? This is a window of opportunity. You hear so many voices aligning. Very often we don't have the political will. Now we do. We don't have involvement of all stakeholders. Now we do. So this is very, very important. I'm very happy to hear that this project is being designed by a team that is knowledgeable, that has included the voice of patients because they have lots to offer in such design attempts. And I would like to conclude by saying something that Mr. Laonidis said. Let's not forget that we're tackling secondary prevention. And we need to make the link between secondary and primary prevention. So I believe that one of the messages that needs to be conveyed loud and clear from this endeavor is that the population that we will be able to identify, to attract so that they participate in the screening tests will go hand in hand with policies against smoking and campaigns against smoking. And it's very important to have all stakeholders equipped to undertake this and to tackle all challenges. For example, when it comes to cardiovascular diseases, the ministry was able to design, to map a pathway that went from the very early stages all the way to the end. So we need to be ready and prepared for the day after, for this critical mass of people. And I will close by saying that we have collectively accumulated important experience at the national stage with similar pilot programs. And I believe, as Ms. Deborah said from the lung cancer patients, training of nurses, of physicians, of patients is very important. It is vital, and it will help us move forward. Thank you very much. So now I would like to go to Mr. Halazonitis. You mentioned just about everything in your initial comment, but now I would like to know if there is research that shows that we will be able to run this program seamlessly. I'm very optimistic, and I will let you know why. A year and a half ago, in a medical journal, a European medical journal, there was an article published on a joint effort regarding screening for lung cancer with the support from you, and honestly, congratulations. And why am I optimistic? Because with breast cancer, we had to wait for 30 years in our country before we had a screening program. But nowadays, Mr. Styrigo said that we will be among the first countries to show to the other European countries how to run a proper screening test for lung cancer. So starting with the scientific aspect as physicians, the contribution of all societies such as the ELLOK, the Hellenic Cancer Federation, other societies, radiologists, thoracic surgeons, what have you, all societies and the support of the ministry, then okay, if we have all that, we can be optimistic despite the problems we're facing. Mrs. Rundak.
In your experience, do you think that such a screening program, I think you already mentioned it before, will actually help ensure fair access to all patients in the healthcare system?
I think it's a fantastic start. I think that's what we can say. And that one of the things I would urge is for you to share the success stories. It's obviously easier than for others to say. I think it's really important because it will encourage others. It will reduce the stigma around lung cancer as well. It will change the narrative that a lung cancer diagnosis is the end, and it will show what's possible. So I think that would be, for me, part of the process behind the scenes is to share those success stories. We know it's worked in the UK, and that will then hopefully ensure that you get a continuous, stream of patients going through the screening process and not turning down their invitation to get screened. So yeah, those success stories are really important and really motivate people.
Thank you so much. Θα κλείσουμε με εσάς, κυρία Πατέλη.
Ms. Patelli, coming to you for a closing remark, the voice of patients needs to be heard. How do you believe that patient associations can contribute to making this a success story? Perhaps by focusing on their training, and of course, as patient navigators, we can work on it. We are very happy because the results of screening programs that we have already run via the project Lung Health have been submitted to the Hellenic Thoracic Society, presented to the ministry, and those results we could say constitute a pilot on how the participants assessed the project themselves, and this ran with 4 societies in Larissa, Thessaloniki, Patras and Alexandroupoli. And now we continue with the Soteria Athens Hospital with a different model, a hybrid model for health services supplied, which will combine virtual screening and live assessment. So we're moving forward, and all this is submitted to the ministry. So along with the new assessment that will arise from the Soteria Hospital, Ms. Hardavella, and so on and so forth, we will take things one step further. And abroad, we see the international practice is clear. No project exists about lung cancer that has not involved patients. This is the only way forward because we can be there for them, we can inform patients, we can work to bring down stigma and support them throughout the pathway. So we're very happy because the past 3 years we've seen substantial change and improvement. People are making a difference, and we are very happy because the ministry has understood, has shown that it understands how they need to move forward. Thank you very much. It is true that lung cancer is a difficult disease, one with innovative treatments, but what is most important is to ensure that there is an equitable access and pathway of care for all patients. Thank you very much all for your input. Thank you kindly to all panelists. We can now go to the Foss restaurant on the upper floor, on the mezzanine floor, for a light lunch. Please come back at 3. Let us resume at 3 because we've got speakers that will need to catch a flight afterwards, so we need to be true to the time allotted to lunch. Thank you.
Καλησπέρα. Μετά από ένα σύντομο...
After this short lunch break, even though we do need it a longer one, I'm happy that you are back here. So I would like to start the RASA Roundtable for this session, which is about survival and healthy aging. The moderator of the panel is already in his place, Mr. Giorgos Pisakas, radiologist oncologist, coordinator director of the radiology department of the Alexandra Hospital, and I will now give him the floor to invite the other panelists on stage.
Λοιπόν, μπορούμε... Ακούγεται? Λοιπόν, μπορούμε...
Can you all hear me? Let's begin. After this lunch break, we are going to talk about survival and healthy aging and how to link care with policy. As you all know, the Chinese have a wise saying which says, better healthy, rich, and young rather than old, poor, and sick. I don't want to talk only about this in theory. When somebody is in this population group, an aged person, who is also a patient. Mr. Battisti, is he already online?
Hello? I can hear you and I can see you.
Δεν έχει απευθείας. Έχει κολλή, ωραία, ωραία. Το σημαντικό με τον κύριο Μπατίστη.
Mr. Battisti is from Italy, and I asked him yesterday to let us know what are the conditions in the UK and in Italy, because he's well aware of them.
Μια που σας έχω πει στα ελληνικά, οπότε δεν πειράζει. Allora, un primo commento su questo argomento che abbiamo oggi.
Grazie, Giorgio.
Ho detto che c'è un vecchio proverbio cinese che dice che è meglio essere giovane, sano e ricco che vecchio, malato e povero. Allora io vorrei avere il tuo aspetto su questo.
Riuscite a sentirmi? Mi sembra che il mio video sia ancora frozen per qualche motivo. Potete confermarmi che mi sentite?
Δεν πειράζει, όχι, τα έχω πει αυτά. Δεν χρειάζεται. Εγώ ό,τι είπα στα ελληνικά τα λέω, τα είπα και στα... Allora, ti ascoltiamo.
Okay, perfetto. Thank you. Well, I'll speak English if that's okay, because I assume probably you guys are more likely to, apart from you, George, to understand English rather than Italian.
Yes, in English.
I would say that's very good. That's very well said, and as usual, there's lots of wisdom in old sayings and so on. I would say, when we talk about survivorship in oncology, obviously we talk about a success, a success of modern oncology with treatments, with surgery, radiotherapy, systemic treatments, and so on. So we're really talking about more people, more patients that are living longer because we are getting to diagnose them with cancer earlier, and we're treating the cancer much better. What I think sometimes we tend to forget is that obviously this is something that comes at a cost for the individual, but also for the society. There are lots of implications in terms of physical function, psychology, social consequences of cancer treatments. And these are all aspects that can be quite challenging sometimes for all the patients with cancer, all the cancer survivors to cope with during the survivorship phase. So I think this is something that in the field of oncology we tend to forget too frequently, but survivorship is really becoming a big issue for the geriatric oncology field, or survivorship in the elderly is becoming a really important aspect that systems should take care of increasingly. I don't think our current cancer care models are actually designed to address this long-term complexity. And I think, there is quite a lot of work, policy work that we can actually do to implement better, cancer care models at, country-wide system, also, European system, to make sure that we align to the needs of this increasing number of patients and cancer survivors. So we know that, obviously the cancer disease of aging, 50% of cancer diagnosis, 70% of mortality. These are the statistics that we typically bring up when we discuss cancer in the elderly. These are, older individuals. However, again, survivorship care plans are still very much focused on specific tumors rather than, this large and increasing patient population. We also know that with the broader multidisciplinary input that includes geriatricians where available, but also, pharmacists, nurses, physiotherapists, occupational therapists, dietitians, a broader range of professionals and specialists, we can actually reduce the burden of cancer care and cancer survivorship on healthcare systems. There are randomized clinical trial data showing that we can reduce hospitalizations after surgery, hospitalizations after on systemic anti-cancer treatment. We can improve quality of life. We are now seeing more and more data also on what we call the cost utility of a broader multidisciplinary, what we call oncogeriatric care input. So there's really no longer an excuse to actually start and looking at implementing more widely these care models also in the survivorship phase. And I think really policy matters enormously here. While survivorship and healthy aging frameworks are really increasingly mentioned in various strategic documents and so on, we are still focusing too much probably on survival metrics rather than what are the lived outcomes of our patients and what gains we can achieve by closer integration of different specialism, professions, and broader multidisciplinary input for this aging patient population. So I would really like to conclude this few words by saying that I think increasingly the question will need to shift from did the patient survive this cancer to did the patient survive the cancer well while the patient has been aging. And that's something that really requires us clinicians in the clinic, but obviously policymakers and patient advocacy groups to really do some much more work together. And this is why I really commend your effort for this ELLOK meeting today and this week. I'm so sorry I couldn't join you, but I'm here stuck in the clinic with a very busy clinic. But I'm really looking forward to this panel discussion. Thank you.
Thank you very much, Nicolo. Probably we have the occasion to another question after the other speakers. Λοιπόν, πάμε στον κύριο Καρατιανό.
let's go to Mr. Karaitianos. There is a philosophy not to pay too much attention to the elderly. So, even though we know that you are a geriatric specialist, but there are other physicians that believe that elderly people do not require so much attention as younger people. What's your take on that, and what we need to do to change that? Dear Yorgos, dear friends, indeed there is a problem in our country. This country is a country of elderly. 23.9% of the population is over the age of 60, and this percentage will reach 25% very soon. And that's an oxymoron, because in our country there is ageism at all levels, even though we have so many people in that age group. Today, this round table, which focuses on healthy aging, has a lot of things to discuss, but the most important is that our diet, our physical activity and mental activity, and our modus vivendi in general, since our childhood, plays a major role in order to avoid chronic problems as we grow older. Cancer is indeed a third age disease, and as the life expectancy increases, the same will apply to cancer incidence. And more than 55 to 60% of new cases concern people over the age of 65. As medicine and nursing advances, as we have new treatments, and as surgery treatment of cancer improves, and as prevention and early diagnosis improves, we have more and more cases that are diagnosed in very old ages. So it is important to treat these people that will be unlucky enough to suffer from cancer. It is very important to say that a big issue that is of major concern today, to Yorgos Kapetanakis as well, he has studied a lot the issue of long-term survivors. In the US, there are about 18 million people that live disease-free of cancer. So we have to manage these patients to reintegrate them in society and in the workplace. That's a major challenge. And on the other hand, there are inequalities as to their insurance coverage, because they are no longer patients on the one hand, but on the other hand, they suffer from barriers in order to reintegrate into the labor market, to reintegrate in society, in their friendly environment, and they have financial problems because they have lost a lot of income. They have problems when it comes to healthcare services where follow-up is necessary, such as breast cancer, for example. So there are many challenges and many problems that we need to deal with. As specialists, we have to find a way to improve these problems for those people that are long-term survivors, because these people are usually elderly. So there are challenges that we have to tackle as to the access to healthcare services, as to their insurance coverage of these individuals, their reintegration into the workplace, reintegration in society, mental and psychological support. And let's not forget that these people will will survive for many years disease-free, but they will suffer all these barriers. This is a major challenge for modern societies, especially Western societies, which believe that the welfare state should be a sine qua non privilege. Thank you very much. The topic of this conference is People at the Center, Bridging Pathways of Care. How can a state build these bridges, especially concerning the elderly? Ms. Karayanidou, you are very experienced in that. Thank you very much. I was thinking as well, what should we say in this session, in this panel? I would like to say that we have people that are disease-free, they are elderly, but there are also those people that may not be suffering from cancer anymore, but they may have cardiovascular problems, or they may be suffering from dementia. And as our population is aging, these population groups will get bigger and bigger, and they have huge care needs. Unfortunately, in our country, there is no provision for that. In the UK, there are some care pathways which can be used as a source of inspiration. It's the so-called secondary prevention. So after an elder person has already suffered from a disease, then the system isolates these people through their GP. They are recorded, meaning people over a certain age threshold. They have a follow-up from their own physician. There is a dedicated pathway to assess them, evaluate them every 2 to 3 years to receive the necessary services. It's not an ideal system. There are several problems, again, because this population group keeps increasing, and there is a lot of pressure on the funding systems, but there is a certain pathway. So we have to find, first of all in Greece, how many people of a certain age with certain health problems are also cancer survivors, and create a dedicated care pathway for them. The general physician could play an important role, for example. The program of aid at home, assistance at home, there are certain structures, but we lack coordination and we lack a more general framework of long-term care. So my point is that in Greece we start from scratch. We don't have basic care for the elderly, so it's difficult to develop dedicated care for the elderly that are cancer survivors or they suffer from cancer. You talked about inequalities. When there are no services, the inequalities get even bigger. People that can afford financially to take care of these people, they do it. But many of them do not receive any care and their need is unmet. And let me give you an example, a personal example. People around their 50s, for example, I live abroad, or at least I'm not in the same city as my parents. My mother is old, she has mobility problems, and she's suffering from cancer. In order for me to be able to care for her, I have the financial ability to pay for somebody to be at her home, but my family had to be separated, and my husband should come back to Greece to provide extra care. So my option was to leave my job in England and come here, and I can afford having a dedicated carer at home for her. Imagine how many people cannot afford this, and they don't even have the minimum care. They are not even able to receive their medicines. Let's now go to the expert in psychology, Mr. Pruskas. As we grow older, our psychology fluctuates. I don't know whether Greek people are ready to look for psychological support. Older people are quite reactive when it comes to that. They say, am I crazy? Why should I go to a psychologist? What can we do to break this taboo? Thank you for giving me the floor, but I will pass. Because, as Ms. Karagianidou said, there are very important issues in this country. There is a huge issue when it comes to long-term care of all age groups, particularly elderly people. So our country leaves this care up to the family. And Ms. Karagianidou said that her family lives in 2 different countries in order to be able to provide such care. So this is a very important problem for all elderly people, especially those that suffer from a major health issue. There are lack of facilities, lack of structures, apart from the aid at home and the KIFI, which are the community day centers. For example, if a person receives a pension from the state and they suffer from dementia or from cancer, they are not entitled to an allowance for a carer. So this allowance only goes to people that are in the labor market, not those that have retired. But even when we talk about the aid at home program, the people that work in this program are not properly trained, and we lack such personnel, people that want to work in care. As a country, we have not made the decision to import, let's say, such personnel. So sometimes we use carers that don't have papers to be in the country. And when people move to a closed care, there are very few public facilities, and most hospices are non-for-profit hospices, but they provide the services in exchange of a price, of a fee. So there are too many gaps. And in the closed care units, there is a huge problem as well. Lack of specialized personnel, untrained personnel. And can technology help? Could AI help in bridging this gap of the expected outcome and the untrained, unskilled staff? Could the AI provide guidance to these people, for example, to the unskilled workers that work in care settings? When we resolve all these issues, yes, indeed, the psychologists have a crucial role to play.
Crystal clear. Unfortunately, so far this discussion seems to be revealing the gaps that exist in our country. And since we have interpreters working for us, Nicolo, you heard that we're faced with a multitude of problems, but you have experience both in the UK and in Italy. Do you have structures, mechanisms, bodies, households, I don't know, anything that could make the life of these people easier, that you could recommend as examples?
I think I got the question. Can you repeat it again, please?
You heard about the problems that we have in Greece as regards supporting elderly people who are also patients. You have experience from two advanced countries, Western countries, the UK and Italy. Can you give us your thoughts about what is done for this population in those countries?
I'm not getting the translation real time, I have to say, but I think that this is about implementing specific care models in Italy and in the UK and other countries, isn't it?
In England and in Italy.
Thank you. Yes, I would say there is quite a lot of work to do here because essentially there are very few countries where this is something which has been adopted in a national cancer control plan, for example. One of the few examples that I'm aware of is France. So in France, for example, you do have specific provisions in the cancer plan that mandate or supports the creation of what we call oncogeriatrics units, where you have geriatricians working alongside the oncology team to co-manage these patients. But that's one of the very few examples here. Here in the UK, we do not have anything like that. I can tell you that in April last year, there was a consultation for the development of the cancer plan here in England. And from the SIOC, so the International Society of Geriatric Oncology perspective, we have put in some recommendations that we are hoping that will be taken up in the cancer plan. In Italy, same. There isn't any national strategy to actually support the creation of or the development of these models. What happens in most countries are initiatives that are limited to individual centers. Typically, you have big, large cancer centers or general hospital with a strong geriatrics department or lots of interest, research interest on the care of older patients with cancer, where specific models have been set up and been developed over the years, but not a national strategy. For example, I can tell you here in the UK, we have our geriatric oncology service here at the Marsden. We have another one at Guy St Thomas's Hospital here in London, which has been the first one to be developed in the UK. Another one in the cancer centre in Manchester, the Christie, and various others. But these are not supported by national strategies or policy work. It's something which is left to individual hospitals and clinicians and managers to actually look at the specific business case to develop these models, which is, as I said, a big, to me, missed opportunity because whether we like it or not, this is the way we should increasingly manage cancer in these longer-term survivors and aging longer-term survivors. And there are, lots of, as I say, benefits of doing this also when it comes to returns and savings for the healthcare system. There are some data that have been published recently by some colleagues in Canada, Princess Margaret in Toronto, looking at the cost utility of comprehensive genetic assessment. So again, broader multidisciplinary co-management of these patients, showing actually you can save also financial resources for that individual institution. And again, my hypothesis is that if you take this to a national country level, you would see similar results also in a broader system, because maybe you're also saving resources to primary practice, so GPs, primary care physicians, or acute hospitals that would have to admit less frequently these patients because of toxicities or other problems and so on. So, yeah, I think definitely we need to do much more work on that. I can tell you that from a SIOC perspective and also the European Cancer Organization perspective, we're trying to push more and more to support some policy work around these aspects at the European Union level, of course, but also with, from a SIOC perspective, especially also in other areas of the world. A few years ago, SIOC also contributed to the Philippines National Cancer Plan, for example, to put into some provisions in that line of work. And we are also now in discussion with the WHO also to try and bring some provisions, maybe, being aware of the different level of resources available, also to lower and middle income countries.
Thank you, Nicola. Νομίζω την κύρια απεικόνηση.
I feel that Ms. Karagiannidou was the one to offer us the most personal experience because she spoke of what she's dealing with. But I also feel that the patient and the carer feel so alone and so limited when they have no money, especially in our country. I believe that many of us know that we have felt that when there is the lack of a specific dedicated structure, when there is the lack of somebody that will stand by you, this is something that is vividly felt. And carers and families are the ones who need to replace that gap. Mr. Kapetanakis, I believe that this is just a symptom of the long-term lack of care offered by the state. And I'm not sure how easy it is to open up the perspective, the eyes of the state, especially so that they recognize and do something about this need. We haven't yet talked about palliative care, which is also a huge issue. How are we going to tackle that? Ms. Karagiannidou. Palliative care is part of another piece of the same puzzle. It's not distinct to end-of-life care. I believe that the term National Action Plan is misconstrued. We need a plan that is well suited to the needs of patients, cancer patients in our country, that will be implementable. So not just a theoretic document, something that, as far as I'm concerned, should be an integral part of long-term care, something that does not exist in Greece. So what we need to do now is to create something that we will be able to implement in the long run, not just tomorrow. Allow me to also take the floor because this is a topic that we will come back to again and again in the years to come, given that the population is increasingly aging and at the same time we have an increasing trend in cancer occurrence and incidents. Let's not forget that what we want to do is to focus on survivors of cancer who are now able to live for long years post the disease. And yes, this is something that is coming. It's around the corner. What are the guidelines? What are the instructions? How do we help people who are aging with a history of cancer? This in itself is a challenge. On the other hand, we've got the disability committees, and once again, there's a problem here when it comes to the assessment, to the recording of these patients, and the most important part is the reintegration, rehabilitation of these patients so that they can become, once again, participants in social life and equal beneficiaries of insurance coverage, of welfare services, and so on and so forth. So it is a challenge because it is something that is bound to happen in the years to come. So we need to make sure that we will be prepared to take care of these people. Let us not forget that we are all potentially patients. And we need to look into the challenges that society and the government will need to address. As far as I'm concerned, the greatest challenge is to intervene as regards the mentality of long-term care, the taboo of long-term care. There's a huge problem for all diseases that accompany the senior citizens and their life, but also cancer patients. So we need also to build a system of self-care which does not exist in Greece. The capacity of self-care is not directly intertwined with disability. So there we need to have a proper distinction between the two so that perhaps in the future we will be able to tackle actual needs of the population. Thank you all very, very much. Our time has run out, unfortunately. The organizers are already shooting threatening glances at me. Nicolo, grazie tanti. And thank you to Kostis, Maria, Yannis. I believe that this is a huge issue. As Maria very well said, it's part of palliative care, which unfortunately is a field in which our country is largely and hugely lacking. Thank you all.
Ευχαρίστησα τους ομιλητές και για την προσπάθεια να...
Thank you very much to the previous panelists for their attempt to stay true to the time. And now let me ask Ms. Maria Samolada, a journalist, to come up and moderate the next roundtable.
Κυρίες και κύριοι, καλησπέρα και από
Ladies and gentlemen, good afternoon. I would also like to welcome you to the 10th annual conference of the Hellenic Cancer Federation. I would like to deeply and warmly thank the organizing committee for the honor to moderate this roundtable regarding the shaping of the care pathway for the patient. I believe that this is a pathway which is dark, unknown, filled with obstacles, hazards, and we need to shed some light, pave the way as best we can. And we can do that by what is actually the title of the discussion we will be having with my distinguished panelists, by investing in efficacy and assessing care. Let's not forget that for a person who's diagnosed with cancer, the healthcare system is not the protocols, and it's the pathway. Who can they address? Who will guide them? How fast, how swiftly can they get care? And what will be the quality of this care? Who can they trust on this unknown, unfamiliar pathway? And this is precisely what we're going to be delving into by focusing on efficacy and the assessment of the pathway care for the cancer patient, and always with people at the center. Today we have the opportunity to discuss these issues, critical issues, with representatives from the scientific community, both of Greece and abroad. They will share their input with us, and I will invite them to come to the panel. We have Mr. Athanasios Vozakis, from the University of Piraeus and the director of the Economics and Health Economics and Administration Lab HEM. With us, Mr. Eduardo Pisani, CEO of OCAN International, Mr. Anastasios Boutis, medical oncologist, the director of the NHS at the Athea, and member of the Board of Administration of the Society for Medical Oncology of Greece, Hellenic Society of Medical Oncology, Mr. Iraklis Katsoulis, Director of the Surgical Oncological Department of Iosavas Hospital and Chair of the Hellenic Society of Surgical Oncology. We have also with us Mr. Ioannis Kosianidis, Professor of Hematology at the Democritus University of Thrace. And then we have also with us Mr. Dimitris Papageorgiou, the Chair of Oncology Nurses and Chair of the Department of Oncology Nursing of the Hellenic Nursing Association. So, we've been discussing data a lot, so let me set the data on the table. What happens when it comes to efficacy and in practice? Mr. Vozikis, along with Mr. Athanasakis, you performed a study on efficacy in cancer care. It was implemented as pilot in Alexandroupoli, Theagenio, Larissa University Hospital, Iosavas, University Hospital of Heraklion in Crete, among others. You have worked together with OLCAN, because I believe that it's from cancer, not OLCAN, we can. And I would like to know a bit more about how we can achieve efficacy and what we need to focus on in order to have improved efficacy. So, could you please tell me a few things about the findings that were resulted from this study? How can we better capitalize on human resources and existing infrastructure? And how can all of the things that we have together help have a better planning of cancer care? First of all, thank you very, very much for once again inviting me to participate at the OLCAN session. I don't want to eat up all the time, so let me very swiftly speak to you about the study that we conducted. We aimed to assess the preparedness of the national health system and of the key stakeholders that are involved, so as to be able to implement an action plan the way that this has been described by OLCAN International in Greece. In order to do that, first of all, we ran an extensive research procedure because we wanted to identify the key stakeholders when it comes to implementing such an action plan. Besides, I believe that it is a very timely issue. I mean, of course, it is necessary, and this is obvious in itself, in and by itself, but at the same time, let's not forget that we are currently discussing the new regulation, the new action plan about cancer in Greece, and we hope that the findings from our research and all research conducted by and with the support of OLCAN International will be merged so as to form a good contributor to the national action plan that we've been waiting for many years now, especially the patients. So key findings when we address the stakeholders that are not just hospitals, we identified and believed it wise to include in our research bodies and representatives of healthcare suppliers, of physicians via HESMO, politicians via ODP, anything pertaining to digital health here in Greece. We wanted to have a comprehensive understanding, not just of the hospitals that will need to shoulder the task of implementing the action plan, but also of all other stakeholders who would have a pivotal role to play in this, in any intervention that would ensure the success of any policy, any strategy, any national action plan. So, swiftly speaking, as regards the findings, what is our degree of preparedness? Well, I would say that we've got some positive findings indicating that, yes, we can implement an action plan in Greece. For example, we have a quite solid regulatory and legal framework for care. We don't have a national action plan yet, but it is supposed to come any day now. We have a very rapid procedure to enrich data, generally speaking, in the health field, and this also includes, of course, cancer care data, and I'm talking about the National Registry for new cancer detection, and we also have highly specialized good staff, both physicians and nurses with distinct roles, and we have ways to support them that are considered quite satisfactory. We have a very important intervention on behalf of patient associations. I'm not quite sure how, but they help shape decision-making. But they are there, they are present, their voice is heard. And in the past few years, where we've seen a very intense activity of patient associations, we have seen that many of their demands are actually starting to materialize. But we also have problems. We have lack of communication in between services. We have data that should follow the patient from primary health care all the way to palliative care. There's no connection in between these two. We have a cancer registry that could be further enriched with very useful data in order to better map patients, the world of patients. We do not have an overall comprehensive mapping of cancer care when it comes to infrastructure, equipment, structures, and human resources. We don't have indicators as regards the outcomes, the 5-year-long life expectancy. We've got no feedback from the patients themselves or other people, healthcare professionals involved in the national health system. However, if we wanted to have a look at the overall image and see the trade-off, let's call it that, I believe that Greece, with a number of interventions that we can discuss down the line, could be ready to implement a national action plan primarily based on timely and efficient capitalization of existing resources in such a way that Okan has already explained, that will allow for all stakeholders to participate, all stakeholders that are now participating in the consultation process. Thank you very much, Mr. Vazikis. And now let's have a look at a broader image. Mr. Pisani, you are here representing Okan International, operating in 22 countries, aiming at improving cancer care through the optimization of existing resources. What is the importance of this study on an international scale? How do do Greek findings compare to findings from other countries, and which do you consider to be the steps to come, especially as regards comparing assessments and assessing pathways? And of course, Mr. Pisani, how do the findings of this pilot study here in Greece, how can they translate into actual models to be implemented in the future?
Thank you very much. First and foremost, thank you very much to ELLOK for the invitation and for the ongoing partnership. It is a very special moment for us, thanks to the work that has been conducted here. But I would like to submit to your consideration some very initial thoughts. First, there is a need to balance vision, long-term vision, and pragmatism, realism. This is what came out of several sessions in the morning already. There are objectives that should be reached, and there are opportunities, let's say, to get there, however, certain instrument resources are necessary. Now, let's make sure that we all have on the table the big picture, which I have the impression has not been sufficiently underscored in the morning. Number one, in the next 20 to 25 years, the incidence of cancer will increase by 76%. IARC data published at the end in the course of last year. This means that approximately 20 million people will die in the next 20 to 25 years, and in my calculation, it's approximately 2 member states of the European Union that disappear from the face of the earth. And the third consideration, which is connected to this official data, is that 25 trillion euros will be spent for cancer care still in the same period of time, 20 to 25 years. Okay, so that's the big picture against which we strategically are trying to develop a framework. Then the policy framework, which has been illustrated, may inform, may shape, should shape national cancer control plans, national strategies, but should also, and here we bridge the gap with the money piece, the funding, the financing of all of this, should also speak to financing authorities or finance ministers, because the investment made in cancer care in particular, let alone in healthcare at large, brings a return which is calculated, depending on the intervention, between 4 and 7.5 times the euro spent. Again, to be precise, I quote the WHO regional office, which indicates HPV vaccination, $1 invested, 4.5 gained, saved in the system. For breast cancer, $1 invested in early detection and diagnosis, 8 euros gained in the system. So, I mean, I'm not a mathematician and I'm not a finance minister, but the numbers are very telling, are very compelling. So let's bring it down to another piece, which is exactly what you were asking. The focus that we have is on efficiency in cancer care and in the healthcare system. As a footnote, again, for the big picture, between 20 and 40% of the resources invested in healthcare are wasted. Okay, OECD, you can find easily the publications. This is quite ridiculous when you think about all the opportunities that we have to invest better in healthcare. That's what efficiency means. So I have to say that it has been a journey with Olcan in the past 5-6 years. 5 years ago, efficiency was a mystery. Everybody would say, okay, what does that exactly mean? Today, believe me, many authorities, national authorities, and international institutions, they say, okay, maybe for the sustainability dimension, for the funding part, we have to be looking at efficiencies in the system, which imply that we do not only need to add money to the pot, but we can also redirect existing resources for better health outcomes. And I'm making another step forward to your question, which is that a person-centered care pathway, according to all the experts and according also to different stakeholder groups, clearly the patient perspective is fundamental and has been fundamental in defining also the action guide that was the beginning of the discussion. The person-centered care pathway is delivering better outcomes than a disease-centered pathway, if you see what I mean, with all the various nuances. Now, practical sort of piloting of a strategic framework with specific clusters. The clusters you were mentioning are built on timeliness of care, coordination of care, and person-centeredness. It's a sort of catch-all category which has been created in order to identify value-added interventions, policies, guidelines that put the person at the center. These buckets have been compared for now in 3 countries around the world. Greece is the country that represents Europe, then Australia and Mexico. We will have the fortune to receive the final reports and compare the final reports in a more formal manner, but I would anticipate that the work that this gentleman here has conducted in Greece with colleagues is outstanding and is really an eye-opener, and perhaps also, how would you call it, the North Star, the North Pole, the North Star that can guide and inform the drafting of a national cancer plan, because there are very concrete recommendations which are, by the way, emerging in all geographies around the world. Perhaps there is a maturity level which is different, say, in Australia compared to Mexico. The systems are very different, but certain objectives, certain expectations from the people and from healthcare professionals are exactly the same. And as somebody said very interestingly in the morning, the knowledge, the scientific knowledge is also accelerating. 30% will be changed in the next few years. I can't remember the quote exactly from this morning, but that's the point. The new technologies, whether it's AI or whether it's any digital instrument, will accelerate the process, but will also create a level playing field. Everybody can use a telephone or will be in due course able to read a database. So there is an acceleration and hopefully also leveling of the quality and the standards that can be applied in different geographies around the world. Let me perhaps conclude on one point, which is the practical part. Let's extrapolate just one element within the action guide and within any national cancer control plan. Timeliness of care. In other words, early detection, early care of cancer saves millions of lives and reduces the consequences, I use it generically, deliberately, reduces the consequences enormously on the personal side of individuals with lived experience and their families. So investing in early detection and investing in early care is a very pragmatic component of a broader strategic vision. And that's my start.
Thank you.
Thank you.
Thank you very much, Mr. Pisani. Έρχομαι σε εσάς τώρα, κύριε Μπούτη, να περάσουμε...
And now let's go to Mr. Boutis to talk to us about his experience in the field. How can you see in your everyday practice the need for more efficiency? And what are the practical outcomes from the OCAN study in your hospital, the Theagenia Hospital? Thank you very much for the question and for the invitation. Further to what the previous panelists said, early diagnosis and early treatment saves millions of lives, and at the same time, it saves money, millions of euros. And it saves workforce. Now, as to the question on how the need for efficiency presents itself in our everyday practice, well, we can see the need for better and more quality care to patients, cancer patients. So the results of the OCAN study showcased that even though the level of medical nursing care is rather high, there are unacceptable delays at the diagnosis level, at the treatment level. There are unacceptable difficulties and inconsistency and of different healthcare structures and facilities. And of course, we don't have the infamous cancer care pathways. We're far from having them ready and implement them in practice. Earlier on, I was listening to all panelists and I was thinking about the cancer patient pathway as I experience it in my everyday life. I thought of snakes and ladders, you know, the game that we used to play, snakes and ladders. So, due to random factors in this pathway, you can get ahead and accelerate your treatment because of random conjuncture, or you can lose valuable time and stay behind, precisely because there is no clear pathway for an initial referral, for management and referral for primary to secondary and then tertiary care centers. Thank you very much. It's the second time in a very short period of time that this discussion revolves around money, around the financial aspect. So, in fact, where we should invest this money and whether we can reduce cancer cases and improve quality of life of patients. Mr. Katsoulis, I come to you now. What are the major challenges from a surgeon's perspective? Given the complexity of surgery procedures, which are the more critical factors that can boost efficiency in surgical care without compromising patient safety. I would like to thank ELLOK for their kind invitation towards the Hellenic Society of Surgical Oncology. Before sharing some thoughts or recommendations, I would like to let you know what surgical oncology is in a few words, because I have the impression that most surgeons and no surgeons have a very blurry idea about what this is. Surgical oncology is the right surgical practice of a tumor, how to manage surgically a tumor. For the Greek state, all surgeons are general surgeons. We are not specialized in a specific kind of surgery, regardless of our personal efforts to specialize in a specific field. But for the Greek state, officially, there are only general surgeons. We have medical oncologists, we have pathologists, we have radiologist oncologists. However, Greek surgeons that work with cancer patients are not accredited, are not specialized, and there has been a decision from the Central Board of Health, and they have said that there should be a separate specialization, surgical oncology. Mr. Katsouli, sorry for interrupting you. This is very relevant to the pathway. Yes, clearly. So when a patient looks for a specialized doctor for their cancer, and when the medical oncologist tells them that you need a surgeon, it is better for them to know which are the certified surgical oncologists. Of course, this is relevant. I want very quickly to let you know how important it is to have the correct surgical treatment in tumors. It is the #1 factor for a good prognosis to have undergone a good surgery. I think all cancer patients should be directed towards the same concrete pathway. There should be accredited centers by the state that should be able to collect all cases of cancers. And these types of cancers, especially rare cancers, should be treated in the same hospitals, because we need to build experience. We need all cancer cases to undergo surgery in the same hospital, let's say, to collect all of them in the same place. That should be part, in my opinion, of the national plan. So we need specialized surgeons, we need special dedicated, how should I call them, surgery centers, centers of excellence, because excellence is a buzzword, let's say. A third aspect is the evaluation of efficacy. As in other fields of oncology, 5-year survival and other metrics are measured, but we have lack of data as to the outcomes of the surgical intervention as well. We don't know a lot of things about the complications and the operational results as well, because surgical oncology doesn't mean simply excising the tumor, removing the tumor. It is also to prevent disabilities. In some cases, we might opt not for a radical removal of the tumor in order to prevent disability. We also don't have specialized oncology nurses. Quite often, people from pharmaceutical companies take care of people that have undergone surgery. Abroad, there are specialized nurses. I can see that Mr. Papageorgiou agrees. He nods. He's been nodding. So, of course, in Greece, we only have general nurses, not specialist nurses. These are all points of concern. We need to have deep knowledge, expertise, specialization, but this should be supported by the state. And the way to do that, I ask, as the president of the relevant society, to legislate surgical oncology as a separate specialization. Thank you very much, Mr. Katsouli.
Mr. Kotsianidis, on behalf of hematology, how do you experience the pathway of care, and what do you think are the critical points that need to be improved? Thank you very much, Ms. Samoulada. I would like also to thank Chair Mr. Kapetanakis and ELLOK for the kind invitation. There are so many critical points that I can't name them all. Let me move to generic principles. First of all, like Breton used to say, like Oedipus used to say, the answer to everything is the human being. What do we need? We need skilled staff. We have this era of technology, lots of new things happening. The registry has been mentioned, and we have the same personnel. We have an approach on behalf of the hospitals that depends largely on the physician. Hospital administrations are incapable of adapting and adopting all the new technologies and knowledge. Unfortunately, the main handicap of hospitals today has to do with the administration of hospitals. Up to 60% of a physician's daily routine is administrative tasks. Can you imagine how much that impedes their clinical practice when they have to spend 60% of their time in administrative tasks? Forgive me for interrupting, but I'm tempted to ask, would you place your faith in a specialized nurse? Maybe you could dictate and they could write down. Or, and this is even more challenging since we have touched upon AI, a tablet or a smartphone where you speak into the tablet or what have you, and you say, prescribe this milligram dose to this of this drug, and because I understand that all that takes time, takes you away from your field of operation. The administrative task that I'm discussing is not writing down the history or the prescription. It's about DRGs, it's about filling out forms, and this is something that has been taken into consideration throughout Europe and Israel. Just the appointments. Imagine that we physicians are the ones that make the appointments in hospitals. So that's what I'm hinting at. We gave Hippocrates' oath, and we never said while we were taking Hippocrates' oath that we will record DRGs. No. And then what? Cancer has become a chronic disease. So we speak about action against cancer, but how can we have that if it is not holistic, if it is not something that involves all specialties. These are chronic patients with tons of comorbidities. If we want to come up with a national plan, health plan for cancer, then it needs to fall under the national health plan in general. And this is what I wanted to hint at. Yes, but this would raise discussions that would take hours to conclude. I think, Mr. Kapetanakis, this is something that we should focus on for the 11th annual conference. Let's move on to our final panelist, medical oncologist. What is a patient-centered care in practice, and where is the line between efficacy and burnout, and what should change so that nurses become an integral part of the care pathway and not a silent mechanism set aside? Thank you very much, Mr. Kapetanakis, for the invitation. I see so many specialties represented in this panel and in all panels. We've got the academia, we've got physicians, we've got pharma. I would like to share a personal story. I had a lousy Christmas because I had I was diagnosed with tachycardia, and I lost my father at an early age due to a stroke and an AMI, and I was wondering what would happen. It really concerned me. I had to reach out to colleagues in order to set up all the exams that needed to take place, and it took me days to actually go through that. And I was thinking to myself, if it takes me days, me being a clinical physician in the throes, in the heart of clinical practice, how difficult is it for an everyday person who does not have a doctor that's a friend, a nurse that is part of their family? And trust me, the pathway is not just about care, it's also about quality of life. And we need metrics. We need metrics within hospitals. And in the cardiology conference Saturday, there was a cardiologist from 10ο Hospital, and he said that we have a shortage of nursing staff that is unimaginable, and we need to deal with that. We have certified approximately 1,200 nurses in various forms of chemotherapy, immunotherapy, and now we are creating specialized certification examinations for dedicated cancer types like breast cancer and so on and so forth. And this is something that will need to be done for nurses in hours that go beyond their shifts, which are already difficult to tackle. And we're also preparing a research platform. In our hospital, in our university, we are running 4 different projects with patients at end stage, end of life stage, for people that can participate either as nurses or as patients. So we're running lots of different programs in our university. And we looked at administration, we went to OVP, and the minister knows that they talk about day hospitalization centers, and we had to look at all the administrative tasks that are very important there. And there are steps that are already established that we can take to facilitate the life of the patient. Let's go back to what we said before. Cancer is a chronic disease. We can find dedicated nurses. We can train dedicated nurses, not just for subcutaneous infusion of drugs. That's not enough anymore. And we can look at assistance at home, not assistance at the end of life stage, but assistance that is of essence, that is substantial for patients at all stages of their battle, of their pathway with this disease. But first of all, we need to understand where were there gaps, where there is deficits, and then look at how we can fill out these gaps for the benefit of the people who need our help, who need our assistance. So, with our panelists, I've got many questions, individual ones for each and every one of you, but let's close this with one question for all of us. If we were to begin today to design such a pathway, what do you think is the first step that should change, that we should change? I am no physician. In order to clinically assess the importance of the different stages that the cancer patient's journey involves. But I believe that what has been understood by all is that it's very important when we have the procedure of the initial diagnosis and how long before that leads to initial treatment. I believe that there are gaps here, and this interval, which is also very important psychologically speaking for the patients, as well as regarding the responsiveness of the healthcare system, this is an interval that is very, very important. And let us not set aside the complete lack of palliative care in Greece, which is an issue that is only now, that we are only now starting to address. It is an issue that we need to focus on. It's extremely important because the number of patients is increasing, but also we see that the needs of people who need support are also increasing. Thank you.
Which goes in that direction but tries to capture different things. I'm from southern Italy, so I'm used to cheat. The investment which I think would apply across the pathway in order to create a data-driven learning healthcare system which allows to measure the performance of the system itself has got to do exactly with data collection at all stages. If we collect data and we learn from those data how to improve what needs to be improved and how we can benchmark from one period of time to another, I think it would benefit the entire pathway. Thank you.
Ναι, κύριε Βοζίκη. Να, τώρα ανάβουν θέματα. Πόσο χρόνο έχω, Πρόεδρε?
Mr. Vozikis, I would like to add to what Eduardo said. I believe especially because it's at the very heart of this panel, of this round table. You know that I'm a health economist, and performance, efficacy, efficiency, these are all very appealing terms for anyone dealing with economics, especially in the field of health. There are two difficult questions that need to be answered, and I will be quite harsh. One is your life or mine. What does that mean? How do we efficiently allocate funds in order to save more lives, improve quality of life of our patient? This requires documentation, this requires evidence. Unfortunately, the state makes decisions that are not based on evidence. And the second has to do with the reply to the major question, is this a jungle or a zoo? Meaning, is there an organized decision-making process that leads to decisions, or are funds channeled to those who can claim those funds, who can fight to get those funds? In both cases, be it technical, efficacy, allocation, what have you, it always comes back down to evidence-based decision-making. Only in that way can we have substantial and efficient health care. It's true that data can help in all in all in this way. Mr. Boutis, I believe that I've been covered, but very shortly, I would say that assessment of efficiency is not a means to an end. It's not something that we like to rehash whenever we're at a conference. It is an invaluable tool that can be used by politicians creating health policies to benefit patients and their quality of life. And of course, the questions are well known. The answers are all training, specialization, and proper organization. I apologize, but I have to insist. This efficiency, when is it truly beneficial to the physician and when is it an obstacle? It is beneficial when it brings down red tape, when it accelerates procedures, and it is an obstacle when it remains purely theoretical, which means that it becomes part of red tape and not a way of improving a procedure, which is unfortunately something that happens a lot. Mr. Katsoulis, the first step? Well, we don't have much time, so a couple of terms. First, human resources. We need to invest in human resources. Many departments of the healthcare system are understaffed. Somebody mentioned that in Greece today we have clinical physicians that have such a huge clinical burden to also take on administrative tasks. We have departments with 10 physicians that only have one single secretary for all 10 physicians, and that person cannot cope with the administrative tasks of 10 physicians. So, human resources, invest in them, and specialization and recording of the problems. If we do not record a problem, we are unaware of it and we cannot improve it. A question to you before we move on. On this pathway, how can we bridge in between before the surgery and pre-operatively and post-operatively? Oncology treatments, cancer treatments, have some specificities. There are time windows within which it is possible to have a surgery. If we're talking about adjunctive treatment, there needs to be added value that is proven. We cannot have delays. So I don't want to go into details because we don't have time. People who are in the know can understand what I'm trying to say. So if we have an understaffed hospital, somebody said that we make the appointments ourselves. Yes. Yes, says the moderator. The patient also makes his or her own appointments. What I'm trying to say is that we need to do everything on the right time. Okay, moving on to Mr. Kosianidis, what do you believe should be the first step to change when designing this new pathway? And a further question specifically for you. If we are talking, can we talk about efficiency without equal access throughout the country?
When I start a pathway, the first thing to do is to look at the map. And I will answer your question. That's what's missing in Greece. We don't have a healthcare map in this country that's based on objective criteria. Age data, population data. If you now look at the distribution of the healthcare personnel, is random. We've never been asked to give them this data. And the so-called healthcare map, its preparation has again been suspended, as I found out a few days ago. You know that health regions are different from administrative regions. Then we have the healthcare centers, and this is a very complex structure in a country with a very difficult geography. So that's a pressing need. Thank you, Mr. Papageorgiou. Let's conclude with you. What's the first point in this pathway, if we designed it today, and how the navigation of patients would be different if the role of nurses was different. Well, of course, I think patients need to go to university. I was in a university, an old student of mine was there studying medicine, and he told me that we are taught public policy, psychology, communication. Well, this is medicine as well. Patients need to go to attend a university lecture to listen to what doctors are taught. Right now, we don't have patient centricity. We have to be honest with each other. We are now rather treating than providing care, and there's a big difference between them. And this is what it should change in this pathway. I spent my weekend with a woman whose father is a patient. He exited the hospital with laryngeal cancer, and I had to find a hospice for them, and I had to talk to them, to train them on what to do. And the lady didn't know where to take her father after he was discharged from the hospital, and that's a very bad thing. Thank you, all of you. A warm thanks for everything you've shared with us. It's become clear that efficiency and efficacy are not just technical terms and not random tools of management. They are the means in order to achieve something more substantial, a healthcare system that's consistent, transparent, and human-centered, patient-centered. The care pathway is not just a chart, not just a map, it's the experience of people within the system. And this pathway can be improved only if we take into account all the various aspects discussed today. Thank you. Please remain seated, ladies and gentlemen. We will follow with another round table focusing on cardio-oncology in Greece. Connection between clinical excellency, research and patient care.
Ευχαριστούμε θερμά.
Thank you very much. This was a very interesting panel, round table. I would now like to invite Ms. Marina Xneri, Head of Policy Affairs at ELLOK and moderator of and coordinator of the Hellenic Cancer Mission Hub, to moderate the next round table.
Καλησπέρα σε όλους.
Good afternoon. Hello, good afternoon, everybody. Today we are going to do a little bit different. I won't ask you to keep your phones in your pockets. I will ask you to use your phones to scan the QR code that you see on the screen. Once you've scanned the QR code, please answer the 5 questions that will appear on your screen. It's not a contest, it's just a way to find out and understand better patient experience. Each question has 5 possible answers. Just choose the one that better reflects your opinion or your experience. You have about 4 minutes to do it. If you need any help, my colleague Panayotis is going around the room. Your questions will appear on the screen in real time and will give us an idea about what participants know and how is this reflected in patient experience. So, what are the questions? Do cardiologists play a role in cancer patient care? Is there any chance that chemotherapy or radiotherapy harms my heart, yes or no? Is hormone therapy dangerous for my heart? Who runs a higher risk for their heart when they receive chemo, younger or elder patients? And last question, once I am cancer-free, do I need to be followed up by a cardiologist? That's all. It didn't hurt, I suppose. So we will see the results on the screen, but let me explain to you what cardio-oncology is. There is a new subspecialization of cardiology that aims at preventing and treating harm to the heart during and after cancer treatment. Long-term survivors, the number of long-term survivors keeps increasing, and cardiovascular diseases are the number 2 cause of death in this population group. To raise awareness, you will find on your tables a leaflet which has the title, What Patients Need to Know. It has been published by the European Society of Cancer together with the European Council of Cardio-Oncology, and it has been translated into Greek. I think that at least everybody should read it at least once. Thank you for answering the questions. I can see that you are no longer using your phone, so I believe that you've completed the exercise. The platform is now closed, and I will ask from my colleagues in Connect to display the results. Ms. Keramida. Good afternoon. I would like to thank you for the invitation and for giving me the opportunity to discuss with you this very interesting topic, what we know about cardio-oncology, what's its importance in the patient care pathway. Do we all know whether cardiologists play a role? Yes, as far as I can see from your answers, you do. I'm happy. Second question, is there a chance that chemo or radiotherapy harm my heart? Yes, 100%. Correct answer. What about hormonal therapy? Is it dangerous for my heart? 70% said yes. I think you did your homework, most of you. Who runs a higher risk for their heart when they undergo chemo? Younger or older people? Older people, you answered older people by 68%. That's true to a great extent, but we will further discuss it. Once I have been cancer-free, do I need a follow-up from a cardiologist? Yes, 96%, that's correct. I think you did brilliantly. And now, I would like to welcome Ms. Kalliopi Keramida. She is a cardiologist at the Cancer Hospital, Agios Savas, specializing in heart failure. And she is a member of the Hellenic Cardiology Society. And the chair of the working group on cardio-oncology of said society. I had prepared a few slides, but after these results, I can see that most of you know a lot. That's an animation by the International Cardiology Society, which aims at raising awareness amongst patients on what cardio-oncology is, who needs to be followed by a cardiologist once they're diagnosed with cancer. What's the objective of the cardiologist? It's not, of course, to be an obstacle for cancer treatment, but to facilitate it and help patients complete it safely. So, information and awareness raising is the first step. Once there is a diagnosis, many of them should be referred to a cardiologist to see whether they run a high risk of developing cardiovascular diseases. It might be people with a bad cardiovascular profile, or they are patients that are about to receive cardiotoxic treatments. Of course, at the center of all this lies cooperation between hematologists, surgeon, cardiologists, and oncologists, because all of us together should coordinate, orchestrated by the treating physician, the follow-up and the monitoring of these patients. So, as it was said before, the number of people that are cancer survivors keeps increasing. But as we distance ourselves from the diagnosis, then there is a higher risk of death due to cardiovascular issues. So, patients need to be referred to a cardiologist to assess the cardiovascular risk, and they should be followed up even after the conclusion of cancer treatment. This is why we've developed this poster that exists in our hospital to let our patients know that they should visit a cardiologist both during cancer treatment and afterwards. And we translated the guidelines of the European Cardiology Society. I'm talking about the guidelines that concern patients. They talk about the symptoms and when to come to ease. And there is a network of cardio-oncology practices and clinics in our country. There were just 8 in 2018, but as years and days go by, we realize how much more they're needed, and now there are 29 clinics all around Greece. Of course, in Agios Savas, we are the first clinic for long-term survivorship, and we've been following up on the long-term cancer survivors. I won't bore you with too many details because I want to leave room for discussion. Thank you, Ms. Keramida. The floor to Mr. Farmakis. You are Assistant Professor of Cardiology at the University of Cyprus. As board of the Cardiology Society, the European Society of Cardiology, and the Council of Cardio-Oncology, have you identified the need for coordinated care towards patients? Can you describe the European perspective, and how has this partnership between cardiologists and other specialists has developed, and how is this reflected in the everyday experience of patients?
Thank you very much. Thank you for inviting me to this very interesting roundtable that deals with a topic that has been at the core of my activity for the past 12, 13 years. Let me just say that I started my training in cardiology within an oncology, a cancer hospital, Metaxas. And I first came in contact with cancer patients and then with cardio patients. And while I was moving on in my cardiology career, I decided that I needed to go back to that early stage when I talked and was surrounded by cancer patients. And at the time, there were only two clinics that were specializing in cardio-oncology in Europe, one in Milan, Italy, and the other one in Bern, Switzerland. And I went to Switzerland. It was then developing, and I came back in 2014 at the Attikon Hospital, made the first clinic, a cardio-oncology clinic. And then we had all these developments that Ms. Keramida showed us. And we was a small group of people throughout Europe, and we were friends. And we decided, when we're talking about what we're doing amongst ourselves, that this should become a bit more official. So we reached out to the European Society of Cardiology, and we spoke to the association. And then back in 2018, we had the council you mentioned that was created. And ever since, developments have been so rapid, so swift. We saw an amazing evolution of this field throughout Europe. We started off back in 2016 in Europe with some position statements in order to accumulate existing knowledge, and in 2022, by accumulating the knowledge, we were able to create the first European guidelines, which were a document including just about everything we could think of at the time. And the patient's document that we issued was translated also in Greek, as were the guidelines. Was this a text written by cardiologists alone? Let me tell you straight, this was based on an initiative of both the Council and the European Cardiologists Society, and we also invited oncologists and hematologists and radiologists. In the beginning, ESMO did not officially participate, but they did send oncologists. EHA, which was the European Hematological Association, and the equivalent society for radiologists they participated unofficially, but we have improved relationships, and we have the official collaboration of ESMO ever since. And in 2023, there was the European co-curriculum on training on this subspecialty. Once again, in collaboration with oncologists, hematologists, and radiation therapists. And in 2025, so last year, we launched the first official EU training project, and we started providing accreditation. In 2026, we continue down this path. And I believe that a very important step is the fact that there is a specialized journal from the European Society of Cardiology that will be launched. There are already 2 cardio-oncology journals from the United States, and we will be launching a more advanced cardio-oncology course as well as other initiatives. As time goes by, even though this began as an initiative under the auspices of the European Society of Cardiology, we started working closer together with societies of oncology, hematology, radiation specialists in Europe. And last year, we also started collaborating with similar agencies from the United States of America. And always when we hold a conference or some other event activity, we try to bring together all stakeholders, oncologists, hematologists, radiation therapists, because we're radiologists, because we want to help them in their very difficult task of treating a cancer patient with no interruption, with no compromise, which is due to a heart-related problem. Another question: in the guidelines that the European Society of Cardiology have issued, given that most of us in the audience are either patients or families of patients, did you include patients? That's right. Thank you for saying that. It is a strategy of the European Society of Cardiology. Whenever we have a guideline or an important official document, we involve patients. This happened in heart failure. This is happening now with cardio-oncology. This is always happening for every document created by the European Society of Cardiology, which is expert-based, as we call it. We know that patients are very knowledgeable, sometimes better than we are on some topics. They're active participants, very strong-minded. Many times we disagreed and we had to compromise to meet in the middle. And it's very important that all efforts that take place are patient-centered. And this is a key strategy of the European Society of Cardiology. Let me just share with the audience that if you're interested in reading the guidelines that Mr. Farmakis has mentioned, in a few days they will be available on the ELLOK website, as is also the case with the leaflet that you have on your tables. So thank you very much to Mr. Farmakis and the European Society of Cardiology and the workforce that is truly working very, very hard. The other day I was talking to Ms. Kiramida over the phone, and she was breathing so deeply, and I asked her what's wrong, and she says, I'm running up and down corridors to put up posters because I want people to be informed about cardio-oncology. And I was quite impressed by that initiative. Now let's move on to Mr. Panopoulos. Mr. Panopoulos, you are an oncologist, and you are head of the oncology department, the oncology clinic of Euroclinic in Athens, Euroclinic in Athens. How do we make the distinction of the treatment based on the patient, the stage of the disease, and the overall complexity of the disease? First of all, thank you very much for the invitation. I find not just this panel, but all panels very interesting throughout the agenda. I believe your question boils down to, is there a reason for cardio-oncology to exist? why should there be a cardio-oncology subspecialty? When I set out on my career as an oncologist, we had very few drugs in our arsenal. Our choices were limited. Some of us decided to have some sort of cardiac test run at the beginning, but this was not the test, the kind of test that we can run today. We've got triplex, we've got lots of tools that were not available at the time. And we moved from empirical learning to scientific learning. What does that mean? It means understanding the mechanisms of action behind what we are facing. We started realizing what various drugs do, and then we saw the addition of new drugs in our arsenal, new ways to treat cancer. As a result, in the past few years, there's been an increase in survivors, both male and female, because in Greek, as you well know, there is a different term for a male survivor and a female survivor, as we also have different terms for those who survive and continue to have cancer and those who survive cancer-free. So do we need to follow up? Yes, even those that are cancer-free, but of course. Why? Because there are comorbidities. There are sequelae when we have cancer treatment. What kind of consequences can these be? There are three types: acute, subacute, and chronic. Am I right, Poppy? Thank you. Acute, like arrhythmias that can become dangerous in some cases. And this is due to some drugs that we need to understand, we need to know. Subacute problems, what does that mean? It means that we follow the ejection fraction, which is the fraction that shows us how well our heart pumps blood, putting it in very plain terms. And here, if we have an overexpression of HER2, which is a protein that increases volumes, then we have subacute incidence. What does that mean? What do we do? We will look at the ejection fraction, and then we will moderate, regulate, add, and reduce various drugs. And then there's heart failure, which is a chronic disease, and this is something that has been clinically documented. Do we have large percentages of people that show those manifest those adverse events? Luckily, no, but these are not the only adverse events, because we are adding novel treatments that have a completely different mechanism of action and a completely different toxicity and cardiotoxicity. We've got the standard chemotherapy, which is enriched by new drugs, and then we've got immunotherapy, which has a completely different profile, because we're talking about a stimulation of, let's call it, body cells, T lymph cells, so that they will fight against and kill the tumor cell. This increase of lymph cells, the stimulation, can take place in other areas of the body, brain, heart, and there it can be harmful. And then we've got targeted treatments, targeted on a cellular level, extremely highly complex pathways, like looking at the metro map of Athens with numerous stations. And we try to disrupt the pathway and thus not allow a cell to survive. And this is something that we can now do with targeted cellular treatments. But are these treatments toxic? Of course they are. If we have a mutation of the EGFR gene with a lung cancer case, people might ask, how high is the toxicity? Toxicity is close to 4.7%. It's not too high, but it's not negligible either. So the question is, can we, or the cardiologist next door, manage all these new challenges on our own or on their own? And here comes the first reply. This is why we need cardio-oncology as a science of excellence, as a specialty. We don't want to just learn better what is already known. We want to come up with answers for future questions. And then another question. Drugs. One patient is different to another. And we speak of cancer, but cancer is 200 different diseases minimum, at minimum. And we've got lung cancer and breast cancer and prostate cancer, CRC. And some patients can have the same increased risk factors as heart failure patients. They can be a coronary disease, for example, which means that we need to assess the disease, the patient, and the drug. So things become a bit more complicated, and this requires a different team collaborating. And if we take this even one more step further and see how this all evolves, the patient, the drug, the treatment, and so on and so forth, and if we take into consideration that oncology is changing as regards progression, as regards incidence, as regards prevalence, we've got lots of new cases, we've got increased survival and increased survivorship, if we can translate the Greek terms as such into English. We see that there's lots of variations. We're looking into why. And that does not mean that we can turn our back on toxicity because, for example, young people can suffer for a very long time due to the toxicity of the treatment. We need to take all of that into consideration. I had a patient that had a stroke, rather an acute myocardial infarction, and at the same time he had cancer and he needs he has CRC and he needs chemotherapy now. And he also needs FU. What do? Do we delay the chemotherapy? No, we cannot. We're monitoring, we are surveilling. We know that there needs to be close, tight cardiological surveillance because there needs to be a pump used and so on and so forth. It went fine for this patient, but are cardiologists equipped to always identify symptoms, for example, symptoms of pericarditis? I can vouch that most of us will need a slight time lapse before we know how to tackle pericarditis. What does that mean? It means that it's not just about intervention, it's also about awareness raising and upskilling. And upskilling, oncologists from cardiologists need to train with cardiologists. Cardiologists need to train with oncologists so that we exchange our viewpoints regarding toxicity, especially cardiac toxicity. And this is indispensable. I would even suggest that a cardiologist participate on tumor boards. I believe that it would be very, very useful, because in that way we would be able to prevent lots of sequelae. And I do not want to tarry any longer, so bottom line is, yes, cardio-oncology is necessary. It needs to evolve, it needs to grow, it needs to become a specialty, specialization, because we require people who will know how to manage this entire aspect, which is far more complicated than you might imagine. Thank you. Thank you very much. You mentioned close surveillance and monitoring. And the other day, I was talking with Mr. Economopoulos, who is a hematologist, a consultant, bone marrow transplant unit head in Ayosava's hospital, cancer hospital, and he said it always pains me that when we have cancer-free survivors, I need to tell them, you're not out of the woods, you need to keep seeing your cardiologist. And he said that I want them to feel liberated and not restricted. What do you think that women who want to bear children but have undergone chemotherapy in their adolescence or in their past, what should they be advised of?
First of all, thank you very much for the honorary invitation. I agree with all previous speakers regarding cardio-oncology. It's very useful for us too. It is a concern indeed, because when you are face to face with patients who've managed to survive from a hematological malignancy, and you need to let them understand that monitoring doesn't stop at the moment when we stop cellular treatment, chemotherapy, radiations, and other treatments. You understand that patients would want to be at ease at home, not having to visit the cardiologist, etc. Thank God we have very good collaboration with Mrs. Keramida at the Ayosava CCC, and patients consult with experienced cardiologists that can help. You asked me what I wanted to say. Cardio-oncologists are very experienced indeed, so my contribution in their sector will be minimal, I believe. So I decided to touch upon this topic that has to do with hypofertility that both women and men may be faced with when they have been through the stage of chemotherapy. People who may, at the age of adolescence, pre-adolescence and young age, people who are concerned when they come to a hematologist, talking about whatever will happen to them vis-à-vis their fertility. There is a problem. Conventional chemos can affect fertility. Drugs that oncologists and hematologists use are detrimental. There are irradiation treatments that may have to target sensitive areas and of course will have an effect on fertility. There are techniques that could help, but it's not always certain that there is time for a woman or a man even to manage and do what it takes in order to spare either ova, talking about women, or sperm, talking about men. I work at the Ayosava CCC. We have gynecologists who help us there, but there is no such thing as an organized public center, because there are private ones, where patients could actually go and receive consultation on the topic and correct advice. Areteo, you are telling me. At the hospital of Alexandroupolis. Alexandroupolis is away from Athens. In fact, it's in the northernmost part of Greece. I didn't know that, says the speaker. In Ayosavas, we have such a department. Gynecologists try to offer advice. I don't know if you work in Alexandroupolis, northern Greece, but theoretically, you need 2 to 3 weeks in order to freeze your eggs. Sometimes it may appear to be a short period of time, but patients either don't have this time, and this is truly very sad, or there is no time on the part of the public department to undertake the patient. For men, it may be easier because sperm collection is different and perhaps easier. Not always. I'm glad to hear that we have something like this in Alexandroupolis, northern Greece. I didn't know that. And if only we could truly cater for the needs of patients with such needs. Off the microphone. We'd wish, says the speaker, it's important. In Athens, we have the Ayosava CCC. In Athens, we also have Areteion, somebody from the audience said, and perhaps in the Alexandra Hospital of Athens. Aratean is very good off the microphone. We apologize. The rest of the phrase was lost on us. This is very important. Thank you. Thank you very much. You are welcome. Mr. Babonis, let us give you the floor. They passed a very polite note to me, reading that we need to come to an end. So I would like you to conclude connecting your scientific expertise with the daily experience of patients. What is the overall cause of this problem, emphasizing on today and now? Thank you very much. Thank you for the invitation. Thank you for having me here. And thank you for enabling me to take part in this very interesting conference and topic. Ever since we started the first chemo treatments, the Metaxas Hospital has had an experience of 10 years since the time we started. From the time when we had Davida cure the first patient, this is a time that lapsed. So all the difficult years of fierce chemotherapy with anthracyclines, the high doses of endoxan and then sun conditioning regimen in Ayosavas Hospital, and the new drugs, we experienced an entire story in itself. At first, we thought it would be wonderful if we could avoid anthracyclines, but gradually we realized first that, as Mr. Panopoulos said, we can avoid the direct, but we cannot avoid the subacute or chronic side effects, and therefore we had quite a few children. I remember two at least with UE who left our country. They had been treated and they served the German army and they suffered sudden death at the time of drills and exercise. What I'm trying to say is that there were many such problems back then. It was very difficult for us to check. We had the Muga scan, whereby we tried to fix the ejection fraction, and we had the biopsies of belly gap with staging in order to understand the extent of the problem of the heart. But we lacked a basic biomarker showing us whether this patient receiving a specific treatment has already started having a problem in the heart. There was indeed quite a commotion, positively speaking, when we discovered a natriuretic peptide, and there was a publication of the New England Journal of Medicine, and we hurried and said we finally solved the problem, but we hadn't, as it seemed. Afterwards, we broke free from anthracyclines, endoxan, and the big bolus doses of FU that Mr. Panopoulos mentioned so eloquently that led to ischemic problems, talking about the last one. And we moved on to targeted treatment. We moved on to molecules like Avastin, anti-HER treatments, and lately immunotherapy. Every time, I forgot to talk to you about liposomal anthracyclines. We said, okay, now we'll manage to bypass the problem. And of course, doxorubicin, a compound that was useful to protect the heart. But in effect, it never managed to get approval and to become a real problem, doxorubicin. Talking about liposomal anthracycline, it didn't meet requirements, and therefore the drug we all expected never came to exist. So cardiotoxicity was there, lurking somewhere. We were learning slightly better, but in a difficult way through problems. Cardiologists were trying to grasp the entire spectrum because, as the previous speakers eloquently said, the spectrum did not only regard the destruction of the cardiac muscle, but it also involved arrhythmias, heart failure, pericarditis, fibrosis. There were many, many different forms of cardiotoxicity manifestation. And now we said with TKIs we won't have a problem. Everything, in fact, is made wisely, and in our efforts to treat cancer, it appears that we disrupt this balance. So a very basic, strong but sensitive organ is the heart, and we end up disrupting the way it functions in different ways. So we actually made the heart hypertensive. We increased the level of embolisms, and many targets in the cancer cell also exist in the heart muscle, and unintentionally, with some miraculous drugs for cancers, we ended up destroying the muscle of the heart. We said, okay, now with immunotherapy we'll be spared all this, but immunotherapy proved to be the worst indeed, and I believe you'll agree with me on that. It is a sly situation that leads to myositis, destroying the muscle fiber altogether, and the patient and the doctors remain totally hopeless. Patients ask for help, and doctors cannot offer the help, and it's the most lethal of all the drugs that we mentioned previously. Have we made progress? We have made progress in the sense that we have realized the importance of cardio-oncology. We have created units, and we have shaped sensitive attitudes towards this domain among some people. We have biomarkers, GLS, echo, for example, that has come to improve the triplex and say that, okay, your triplex may be normal, but mind you, this heart is susceptible to collapse. And in fact, it will collapse shortly. And we have the ancillary help of troponin, an enzyme of the heart muscle. So in a few words, all in all, throughout these 50, 60 years, we've been struggling to beat cancer. We have taken many steps to the right direction, but few steps to understand why it is that we end up hurting the heart and how we can avoid this. Cardio-oncology is now coming to bridge this gap precisely, as it is very aptly mentioned in the brochure of the Society. We'll be allowed to continue our treatment, but without placing our patients at risk. Thank you ever so much. And we have better tools today, if I may. Vasilis mentioned a few of tools like troponin PNP, natriuretic peptide, and so on and so forth. But we also have other tools like the MRI of the heart, which is a very useful tool. And with the progress in technology, we have better prospects. Suffice it to know how to use what we have. And it all depends on the colleagues here and the work they do and will be doing. Thank you. Thank you very much.
Ήσασταν σχεδόν στην ώρα μας. Μία τελευταία παράκληση παρακαλώ στο ακροατήριο. Ήσασταν φανταστικοί. Ευχαριστώ που
We almost finished on time. Thank you very much for answering. I'll ask you for a final favor. On your table, you'll find a questionnaire that the work group and we have created in unison. And by filling it in, you'll help us understand how to better approach your information. Thank you very much, both audience and speakers. Thank you.
Ευχαριστούμε θερμά και για την τήρηση του χρόνου και τη συνέπεια.
Thank you very much for keeping the time limit, and thank you for the very interesting information you have shared with us, says moderator to the doctors. I'd like to now invite Mr. Kyriakos Souliotis, professor of health policy from the University of the Peloponnese. Mr. Suliotis, after the photograph, we'll wait for you to take the floor.
Ναι, παρακαλώ η κυρία Κανή, ο κύριος Νικολάου, ο κύριος Μπουρλίβας, κυρία Στεφανάκη να προσέλθουν εδώ στο πάνελ. Όπου θέλετε καθίστε. Θα τα ανακατέψουμε. Όχι, ας έρθει πρώτα η χαρά εδώ η κυρία Κανή, που θα ρωτηθεί πρώτη, μετά ο κύριος Νικολάου, ο κύριος Μπουρλίβας και παραλιακά η κυρία Στεφανάκη. Ελάτε εδώ να είμαστε παρέα. Λοιπόν, δεν έχει διάλειμμα, πού? Από ό,τι ξέρω δεν έχει διάλειμμα, οπότε ξεκινούμε αμέσως το πάνελ. Παρακαλώ να καθίσετε, γιατί έχουμε ένα πολύ ενδιαφέρον θέμα. Τραπεζιού με τον τίτλο ΕΟΠΗ, άνω κάτω τελεία, νέα θεώρηση και νέες προκλήσεις.
Ladies and gentlemen, unfortunately, we didn't have the scheduled break, and the interpreters really need one, so we'll discontinue for about 10 minutes. Thank you very much.
Συγχαρώ τον οργανισμό για την πρωτοβουλία της διανομής φαρμάκων κατοίκων και να μοιραστώ μαζί σας ένα πρόσφατο έρευνα μιας δικής μας έρευνας, έβριμα μιας δικής μας έρευνας, που δείχνει ότι η αποδοχή του μέτρου είναι πάνω από 80%. Δηλαδή το 80% του πληθυσμού δηλώνει ότι το μέτρο της διανομής φαρμάκων κατοίκων, αγαπητέ Γιώργο, το σχολιάσαμε και πρόσφατα αυτό, το θεωρούν ωφέλιμο το 80-85% του πληθυσμού και απαραίτητο το 80% του πληθυσμού. Πάρα πολύ ψηλά ποσοστά ικανοποίησης. Νομίζω ότι με την κοινή λογική να σκεφτούμε, καταλαβαίνουμε το γιατί συμβαίνει κάτι τέτοιο, αλλά είναι άλλο να το υποθέτεις και να το εικάζεις και είναι άλλο να το μετράς. Άρα νομίζω ότι πρέπει να συγχαρούμε τον ΕΟΠΗ και θα ήθελα να δώσω αμέσως το λόγο στην διευθύντρια της σχετικής διεύθυνσης, την κυρία Κανή, για να μας πει μερικά λόγια για το πώς εξελίσσεται το πρόγραμμα, τη δική σας οπτική.
Ναι, και να αναφέρουμε και τα καινούργια που θα ανακοινωθούν.
Και, μπράβο, και την ενδεχόμενη επέκτασή του.
Καλησπέρα από μένα. Ευχαριστώ πάρα πολύ για την πρόσκληση και την τιμή να βρίσκομαι σήμερα εδώ. Το κατοίκον είναι εμβληματικό έργο για μας, γιατί νομίζω ότι είναι το μόνο τόσο εξωστρεφές έργο του ΕΟΠΗ που αφορά απευθείας βελτίωση υπηρεσιών υγείας προς τους πολίτες. Η αλήθεια είναι ότι όταν ξεκίνησε, ήταν ένα πάρα πολύ φιλόδοξο έργο, ξεκίνησε χωρίς να έχει καθόλου πιλότο, οπότε ήταν τεράστια η προσπάθεια η οποία έχει καταβληθεί. Ξεκίνησε σε όλα τα φάρμακα υψηλού κόστους, μέσα στο καλοκαίρι, οπότε καταλαβαίνετε ότι αντιμετωπίσαμε πάρα πολλά πράγματα. Όμως, αυτή τη στιγμή έχουν αποσταλεί και κατοίκων και σε σημεία διανομών του ΕΟΠΗ περίπου 240.000 αποστολές, με στοιχεία της πρώτης εβδομάδας περίπου του Ιανουαρίου, και η μέση χρόνη, παρόλο που όταν μπαίνει κάποιος στην πλατφόρμα μας βλέπει ότι ο μέσος χρόνος αποστολής ενός φαρμάκου είναι από 6 έως 10 εργάσιμες μέρες, αυτό το κάνουμε για να έχει κάποιος την έννοια και να γνωρίζει ότι αυτές οι υπηρεσίες δεν είναι άμεσες. Αν είναι κάποιο επίγον περιστατικό, πρέπει να πάει σε φαρμακείο ΕΟΠΗ. Αλλά παρόλα αυτά, οι χρόνοι αυτοί δεν ισχύουν. Από δεδομένα που ανακοινώθηκαν και στην ιστοσελίδα του οργανισμού, ουσιαστικά ο μέσος χρόνος παράδοσης πανελλαδικά είναι 4,84 μέρες, ενώ ο μέσος χρόνος παράδοσης στην Αττική και στη Θεσσαλονίκη είναι περίπου στις 3,6 μέρες. Οπότε καταλαβαίνετε ότι οι χρόνοι αυτοί έχουν συντμηθεί και ο στόχος είναι να συνδυμηθούν ακόμα περισσότερο. Η δυσκολία του εγχειρήματος ήταν μεγάλη, γιατί εκτός από το να πάρει κάποιος ένα φάρμακο στο σπίτι του που δεν δύναται να μετακινηθεί, έπρεπε να γίνουν όλες οι προσπάθειες για τη διασφάλιση ότι αυτό το προϊόν φτάνει σε άριστες συνθήκες. Οπότε και επίσης ότι υπάρχει και πλήρη χνηλασιμότητα. Για πρώτη φορά ο ΕΟΠΗ μέσω του Β' κεντρικού φαρμακείου έχει πλήρη χνηλασιμότητα του φαρμάκου που φτάνει τον ασθενή και σε επίπεδο παρτίδας και σε ημερομηνία λήξης. Οπότε και για θέματα ασφάλειας ή ανάκλησης παρτίδων μπορούμε πολύ πιο εύκολα να δούμε ποιο φάρμακο έχει πάει σε ποιον, άρα μπορούμε να βοηθήσουμε το κράτος να κινηθεί πάρα πολύ πιο γρήγορα. Παράλληλα, πάνω σε αυτή την καλή εμπειρία, η οποία θα ήθελα να πω ότι είναι μια δράση που είναι μοναδική, γιατί στοχεύει σε έναν πληθυσμό στόχο που δεν μπορεί να πάει σε φαρμακείο. Είτε λέγεται ιδιωτικό, είτε λέγεται κρατικό, είτε λέγεται φαρμακείο ΕΟΠΗ. Παράλληλα, είχαμε ξεκινήσει πιλωτικά και την αποστολή φαρμάκων στα ιδιωτικά φαρμακεία. Αυτή η διαδικασία μέσα σε αυτή την εβδομάδα θα γίνουν και επίσημες ανακοινώσεις ότι ξεκινά άμεσα. Εγώ μπορώ να σας πω ότι τεχνικά είμαστε έτοιμοι. Πριν έρθω εδώ σήμερα είδαμε το τελευταίο κομμάτι της πλατφόρμας, οπότε από αυτή την πλευρά είμαστε έτοιμοι. Θα βγουν και οι αντίστοιχες υπουργικές αποφάσεις, οπότε θεωρώ ότι μέσα στο επόμενο δεκαήμερο θα είναι και πλήρως υλοποιήσιμο και η αποστολή των φάρμακων στα ιδιωτικά φαρμακεία. Αυτό που θέλω να ξεκαθαρίσω είναι ότι η αποστολή φαρμάκων στα ιδιωτικά φαρμακεία αφορά ένα υποσύνολο των φαρμάκων που διακινούν τα φαρμακεία ΕΟΠΗ, δηλαδή ουσιαστικά αρχικά θα ξεκινήσει με ένα μικρό κομμάτι φαρμάκων, είναι τα φάρμακα σκλήνης κατά πλάκας και κάποια αντικαρκινικά τα οποία ήδη δίνονταν και σιγά σιγά ανάλογα με το πώς θα πάει το πρόγραμμα θα επεκτείνεται. Όσον αφορά την παρηγορητική φροντίδα, εκεί, στο κομμάτι της φαρμακευτικής περίθαλψης, το μόνο το οποίο κάναμε είναι ότι επειδή, θα είμαι ξεκάθαρη, υπήρχε μια πολύ μεγάλη συζήτηση στο Υπουργείο για έλεγχο παραβατικής συμπεριφοράς και για χρήση φαρμάκων στον πόνο. Αυτό που κάναμε είναι ότι ήρθαμε σε επαφή και με την ομάδα παρηγορητικής φροντίδας. Προσπαθούμε να βάλουμε φίλτρα για να κόψουμε την παραβατική συμπεριφορά, αλλά ταυτοχρόνως αφήνουμε τη δυνατότητα στους γιατρούς να μπορούν να γράψουν και σε κάποιες ενδείξεις οι οποίες ενδεχομένως δεν περιλαμβάνονται στην άδεια κυκλοφορίας. Επίσης, στο τελευταίο χρονικό διάστημα ουσιαστικά βελτιώσαμε και κάποιες υποδομές στα φαρμακεία ΕΟΠΗ και πρέπει να το έχετε δει. Πρώτα απ' όλα το φαρμακείο αυτή τη στιγμή του Πειραιά έχει περισσότερα γκισέ, έχουν μειωθεί πάρα πολλοί χρόνοι αναμονής. Επίσης θα αναπτυχθεί φαρμακείο στο Θεαγένιο, το οποίο ουσιαστικά θα βοηθάει στο Day Clinic, καθώς επίσης παραχωρήθηκε και ο χώρος πάνω από το φαρμακείο της Αλεξάνδρας, όπου εκεί θα γίνονται τα Day Clinic του ΕΣΥ, οπότε θα υπάρχει και η δυνατότητα της απευθείας προμήθειας. Ταυτόχρονα θα αλλάξει και το φαρμακείο που είναι στην Ηπείρου, θα μετακινηθεί στο Άτριουμ, το οποίο είναι ένας πολύ μεγαλύτερος χώρος και πολύ καλύτερος χώρος για την τακτοποίηση και για την εξυπηρέτηση των ασθενών. Οπότε νομίζω ότι αυτά.
Εξαιρετικά. Πολλά νέα σχέδια. Ακούμε και χαίρομαι πάρα πολύ. Να σημειώσω και εγώ ότι δεν είναι ανταγωνιστικά τα προγράμματα της διανομής φαρμακοκατοίκων και είναι συμπληρωματικά και αυτό ας μείνει, γιατί είναι συγκοινωνούντα δοχεία. Αυτό που μας είπε η κυρία Κανή, ότι μειώνονται και οι ουρές σε κάποια φαρμακεία του ΕΟΠΗ που κρατούν το ρόλο τους, αυτό οφείλεται στο γεγονός ότι μειώνεται ο φόρτος λόγω του ότι κάποια φάρμακα διακινούνται μέσα από τα πρόσθετα κανάλια. Και αυτό είναι πάρα πολύ σημαντικό και είναι προς όφελος των ασθενών. Θα γυρίσουμε να κάνουμε μια δευτερολογία στο τέλος. Κύριε Καπετανάκη, αυτό το τραπέζι όχι μόνο θα πειθαρχήσει το χρόνο, πιστεύω ότι μπορεί και να γλιτώσουμε για λίγο. Για τέτοια συνέπεια μιλάμε. Λοιπόν, κύριε Νικολάου, εσείς έχετε ταυτιστεί με την κατοίκον νοσηλεία. Έχουμε κατοίκον διανομή φαρμάκων, έχετε ένα εξίσου εμβληματικό και πρωτοποριακό έργο υλοποίηση στον Άγιο Σάββα με την κατοίκον νοσηλεία. Πού είμαστε σε αυτό?
Ευχαριστώ πάρα πολύ καταρχήν για την πρόσκληση. Να ξεκινήσω από το μέλλον. Έχουμε μία μελέτη από τη Microsoft που μας λέει ότι η τεχνητή νοημοσύνη θα καταργήσει κάπου στα 40 επαγγέλματα και όλος ιδιαιτέρως αυτά τα επαγγέλματα που είναι τα βαριά πτυχία. Δηλαδή εμείς οι γιατροί με μεταπτυχιακά, διδακτορικά, 40 χρόνια ταλαιπωρία σε πανεπιστήμια, σπουδές, μπρος πίσω βιβλία και τέτοια, για να δώσουμε μία απάντηση θα μας αντικαταστήσει ένα μηχάνημα που σε 5 δευτερόλεπτα θα δίνει ισοδύναμα, τεσταρισμένη και πιστοποιημένη απάντηση. Και αυτό θα γίνει σύντομα. Δεν είναι τώρα βέβαια η αξιοπιστία τέτοια, αλλά σύντομα θα γίνει. Αντιλαμβάνεστε λοιπόν ότι ο κόσμος θα κάνει μια στροφή περισσότερο στο χειρονακτικό κομμάτι. Αλλά αυτό έρχεται το Υπουργείο Εργασίας της Αμερικής και αποδεσμεύει τεράστια κεφάλαια για το κομμάτι της κατοίκων. Και είναι το μόνο που όχι μόνο θα μείνει αλόβητο, αλλά θα αυξηθεί. Αυτό το λέω για να συνδέσω και το οίκοθεν ως ένα εμβληματικό έργο, αλλά και αυτό που έχει κάνει ο ΕΟΠΗ με τα φάρμακα στο σπίτι. Η αλήθεια είναι ότι στην Ελλάδα έπρεπε να ξεπεράσουμε πολλά εμπόδια του μυαλού, ότι πώς θα φύγει το φάρμακο από το νοσοκομείο, πώς θα φύγει το φάρμακο από το φαρμακείο του ΕΟΠΗ. Σκεφτείτε όμως ότι αυτή τη στιγμή έχουμε τα smart hospital, τα έξυπνα νοσοκομεία σε παγκόσμιο επίπεδο, σε πολύ πολιτισμένα, υπερπολιτισμένα κράτη, όπως είναι το Ντουμπάι για παράδειγμα, έχει 3 αυτή τη στιγμή, όπου δεν παρεμβαίνει χέρι φαρμακοποιού μέσα στα φαρμακεία του νοσοκομείου. Και επειδή αυτό θα γίνει, δεν θα γίνει αύριο στη χώρα μας, αλλά τα νοσοκομεία, το Ωνάσιο, τα νοσοκομεία του Νιάρχου θα πληρούν τέτοιες προϋποθέσεις και το Παπαγεωργίου στη Θεσσαλονίκη. Ίσως φιλοδοξούμε και εμείς ο Άγιος Σάββας να είναι μέσα σε αυτά. Αντιλαμβάνεστε ότι το περιβάλλον αλλάζει τόσο πολύ που θα πρέπει να ξαναχαρτογραφήσουμε το που θέλουμε να φτάσουμε. Χρειαζόμαστε λοιπόν φαντασία. Το κομμάτι τώρα της κατοίκων θεραπείας ήταν όντως ένα πιλωτικό φιλόδοξο κομμάτι, ξεκίνησε το 2020 μέσα στο μυαλό μου, αλλά η αλήθεια είναι ότι το τελικό προϊόν δεν έχει καμία σχέση, γιατί προσθέθηκαν πάρα πολλά μυαλά εκεί πέρα μέσα και βγήκε ένα υπεράριστο τελικό προϊόν. Άνοιξε δε σε 4 πόλεις, 5 νοσοκομεία και είμαστε πάρα πολύ ευτυχείς γιατί συμπεριλαμβάνει και 3 ιατρικές ειδικότητες, την ογκολογία, την αιματολογία και την νευρολογία με τις κλίνες κατά πλάκας. Και αυτό, ενώ μπορεί να φανεί ως κάτι πολύ μικρό και όντως έτσι είναι, ξεπέρασε εμπόδια, δεν υπήρχε νόμος πλαίσιο, άρα φτιάξαμε το νόμο πλαίσιο, αποδείξαμε ότι αυτό μπορεί να γίνει με ασφάλεια και έτσι ξεκλειδώθηκαν και όλες οι άλλες εφαρμογές, το πώς το φάρμακο μπορεί με ασφάλεια να φύγει σπίτι, να γίνει ιχνηλάτηση, να υπάρχει λογοδοσία και έρχεται τώρα και η τεχνολογία και όλο αυτό το background, το ψηφιακό με τον ηλεκτρονικό φάκελο του ασθενούς και προασπίζουν έτσι το φάρμακο, γιατί είναι αλήθεια ότι δεν πρέπει να γίνονται σπατάλες στα φάρμακα. Στο παρελθόν έχουν βρεθεί ελληνικά φάρμακα σε άλλες χώρες έτσι, του κόσμου και αυτό είναι μείον για όλους εμάς, γιατί αυτό είναι μέσα από τη φορολογία μας. Θα πρέπει να υπάρχει αυστηρότητα στο πλαίσιο και λογοδοσία. Νομίζω ότι είμαστε σε αυτό το σημείο, έχει αποδειχθεί ότι μπορούμε να είμαστε σε αυτό το σημείο και σχεδιάζουμε τα επόμενα βήματα.
Ευχαριστώ πάρα πολύ και πάλι συγχαρητήρια. Να θυμίσω σε όλους μας κάτι που πρέπει να το λέμε για να το ακούμε κι εμείς. Κάθε τι που ζητούμε να χρηματοδοτηθεί από το κράτος επιστρέφει σε εμάς, γιατί εμείς είμαστε οι βασικοί χρηματοδότες. Αν ζητούμε αύξηση κάποιας δαπάνης...
We need to remember that every time we ask for more expenses, we'll end up footing the bill. Because when you spend more money than you should in a certain category, you'll need to subtract this money from another one. And we've had personal experience in years that were far more difficult. You know, when something happens in this country, and we need to take it as read because it has been implemented 10 years ago, if somebody said that we would visit seriously ill people at home to give them their drugs, people would say, no, these things don't happen in Greece. But they are happening already. So enough with the self-castigation, because all improvements require an institutional overexertion. People need to forecast every possible thing that can go wrong. I'm not talking about things like, for example, the transportation of drugs, people that need to be certified for this task, and all this needs to be written in a text that is official. There is red tape in our state. It has always been the case. I like shortcuts because sometimes we can achieve very good results. We are talking about care and support. Let's go to Mr. Burlivas. So, care, this supporting care, what's your outlook on that? What can we have? My friend Yorgos Marketidis in the morning roundtable talked about glass, half full, and how we can fill it further. Thank you very much. Mr. Kapitonakis, thank you very much for honoring us by inviting us here. As Armatura, what we do is something that is important. People at the center of care and building bridges of care. This is precisely what we do. We place people at the center first and foremost because technology, innovation and science will need to make a difference in the quality of life of people. Otherwise, there's no point. What needs to be done is to get out in society and help. We have a very special technology and a drug for oncology patients that's related to their nutrition. I don't want to talk about it because I don't want to advertise the product. If you are MDs, you'll understand that there are many clinical medical studies, and one of them is in Annals of Oncology, 65.4 impact factor, and we're talking about a nutritional agent. It's not immunotherapy or a biologic. Having people at the center, we create concentric circles around the person to protect them. One circle may be the surgical procedure, another one chemo, irradiation treatment, immunotherapy. But in a recent visit in Frankfurt, in a big conference, my colleague from Spain, from the factory that produces this particular product, that many big societies approached him because oncology is now turning towards nutraceutical products. The patient is approached holistically. We're not talking about a person that has a disease, will get a drug and get it over with. This is something that needs to be faced holistically. Ongoxin has been incorporated in protocol in ERAS, which is increased care following oncology surgery, which means that we now have something that drastically reduces side effects following chemo and radio treatment, increasing quality of life. What does it mean? We can say that the disease is a difficult path. It's like walking on a mountain or towards a mountaintop barefoot. Every thorn will hurt us. This nutraceutical is a pair of socks. It's not heavy boots, for example, heavy-duty boots that will do away with all thorns. But we are talking about steady socks that make the path easier to tread. Quality of life is important. People can go back to work faster. And macroeconomically speaking, this is very good value for money for both the patient and the system. This is what I wanted to say. Thank you. Mrs. Stefanaki, what's your outlook on all that? Let me remind you that last year we didn't have the distribution of drugs at home, the Katikon program. This was an announcement, a plan, but we are here and it has happened. Okay, first of all, I would like to welcome you on behalf of the Board of Directors of ELLOK to the 10th Annual Conference of the Hellenic Cancer Federation. We are very glad to see you here. So, on behalf of patients, I paid great attention to what Mrs. Kani said. And, of course, I heard Mr. Nicolaou talk about the home care, Katikon, the program that is of home care. Mr. Nicolaou, of course, talked about this program. He didn't create it. And I heard about this nutraceutical product. It's very nice indeed. And you know something? A pair of sturdy socks are always welcome for patients that tread such difficult paths. would like to tell you, no, I'll make a comment, rather. Drugs at home are indeed a very interesting innovation and a necessity in the field of oncology care, a necessity for years. It's true that in the previous years we had a major problem with the procurement of drugs and the ordeal of having to get your own drugs. I'll remind you, although I don't think it's necessary, because here in this venue we all know that oncology patients during treatments are particularly vulnerable and need all sorts of care, and any facilitation that may be provided to them. There are people that are lonely, weak, without a supportive framework. There are people that do have a framework of support, but this too is lost in the farrago of the national health system, or is not sufficient. In central pharmacies of LP, our knowledge is that quite often people wait for long hours, and many of them wait at the same time, and this was remedied by the Drugs at Home initiative. Of course, it's welcome, and when it's fully deployed, we trust that it will truly be a relief, an effective relief. It appears to be a correctly planned program, and we hope not to be proven wrong, because many times at the stage of implementation there are some unexpected factors that crop up. It started a few months ago. The BOD of the AOP Organization for Healthcare Services has estimated that about 120,000 patients can benefit from that. A recent calculation regards about 25,000. I stand corrected if I'm wrong. So there is room for great improvement for this program to be rolled out further. We patient organizations persistently inform our members, patients that is. Unfortunately, we find ourselves at the other end of the spectrum when we talk about pain relief centers and palliative care. In a previous panel, we heard that in this field there is a huge gap observed, because it appears that it's not very high on the agenda of the Ministry of Health, even though there is a law. In fact, it was tabled in 2022, but its effect has not proceeded. Regarding pain relief, not only don't we have progress, but we have a regression. Pain relief centers in many parts of the country do not exist, or sometimes they exist but they are closed, or they do not operate in full capacity, either because there is understaffing or there is no suitable staff. We shan't discuss the obvious reasons that we all know and understand, I suppose, but we'll talk about the downgrading of oncology care that this entails. In the wider region of Western Greece, where I come from, and specifically in the two hospitals of Patras, there is a big problem. The pain relief center at the University Hospital, which is the flagship of the health system in the area because it covers a population of 1 million inhabitants, has closed already. It is not functional. The smaller office of the smaller hospital, St. Andrew, is not operating properly. If you want to make an appointment, it takes a long time, and there is insufficient provision of services. Pain, cancer pain first and foremost, cannot wait. We all know that. I don't believe that in this room there's even one person that fails to understand that. Especially in advanced stages of the disease, we have very, very few patients that don't need pain management and palliative care. And you know, no matter what you say, I'll say that we, as patient associations, will say that as a society, we owe it to them. We owe it to the thousands of patients to have a rudimentary quality of life at the end of their lives. The society owes this to them. and it needs to overlook financial criteria. Financial technical criteria have no room if we want to call ourselves human beings. Thank you very much.
Ευχαριστούμε πάρα πολύ. Ήθελα να το πάω αντίστροφα για να...
Thank you ever so much. I was hoping to move in the other direction so that we could close with Ms. Kani here under two hats. If you had the minister here before you, what would you ask? Let's ask with you. Let's start with you. I understand that pain management is a very important topic. There are many patients that stigmatize themselves because there is such a lack in pain management. And one of the findings of the study conducted that impressed me was that support is very, very important. Support, psychological support, nutritional support, pain management support. They all rank high in the priorities of patients. And I will go on and ask, do you believe that we can do things to alleviate all those problems, to especially to mitigate all these problems, especially with restricted funds? Yes, and if the minister was here, I would have said the same things exactly. We owe it as a society to end-stage patients and to patients truly suffering enormously from cancer pain to implement all that. Let me just say, because of what you said, that this is not financial or technical, it could be a wonderful object for a financial technical study that would help us truly meet our needs down the line. I believe that if we have a cost-effectiveness study, we would be able to move forward much more easily. So, Mr. Jens, we've got demands here for supportive care that you provide, but I'm guessing this is not reimbursed. We've got Ms. Kani here. What would you tell LP, the National Organization for Healthcare Services? Do we want something of the sort to be reimbursed? Can we afford it? What do other countries do? What could we do? Because it's not just about direct medical costs, it's also about quality of life of the patient. That is something that we measure and we are interested in. So if we could have an intervention that truly improves quality of life, is that cost effective? Of course. Definitely. For 10-15 years now, I've been seeing studies, especially in Northern Europe, that measure the indicator, a quality of life indicator regarding the overall population, not just patients. A population which has good quality of life can be more productive. And this is even more important for a patient because he may visit the hospital, come back with a hospital infection, and this could lead to adverse events. So I believe that it is highly cost-effective, no matter which way we look at it, both in terms of health economics, cost-effectiveness, because it's the person above all else. Person centricity, with consistency, so that with cohesion, so that we can ensure that this is something that applies to the next generations as well, to the generations to come. And this is why we have undertaken numerous clinical studies in order to highlight, demonstrate the quality of life of a patient that does not complete, for example, chemotherapy cycles because of the side effects of the adverse events. Hematologically speaking, that that prohibit this patient from concluding the cycle. We have scientifically demonstrated that if we improve this indicator, the person can go back to their family, to their job, continue being productive to the benefit of the state, and also have an improved quality of life. It is true that any disturbance and disruption of the treatment protocol is costly. Mr. Papanikolaou, what do you think? It is true that treatments at home are highly interesting in terms of cost, But let's not talk at the finances alone. Let's look at the benefits of being treated at home, surrounded by people that care for us, that don't need to take the day off from work to stand by us. Once again, my reply will be indirect, in the sense that lots has been achieved. It could be because of the recovery fund that allowed facilities to be improved, hospitals to be improved, equipment like radiation equipment. With the help of Stavros Niagharos Foundation, it has been upgraded. There have been applications like Ecothen or drugs at home. Even the National Registry, therapeutic protocols, digitization of health, the e-file. So, a lot has been achieved, and we are faced with the end-of-life care, which has not been touched upon. We've mentioned it multiple times. And, of course, the pain centers and the supportive network. We cannot have families always playing the role of carers. These are all very, very important topics. And as you said yourself, if we remove quality from the equation and we only focus on cost effectiveness, then the most effective solution would be to drop people off a cliff like was done in ancient Sparta. But that is not what we are looking for. We want people who enter a healthcare system, are able to navigate it and come out feeling better, with their lives improved, both ourselves as physicians and patients that play increasingly a part in decision making. We are co-forging an ecosystem highlighting these values, these principles. Recently, we created a digital tool with the help of Kostas Athanasakis, where various scientists from various posts and different posts studied variables and constants regarding subcutaneous infusion of drugs. And we talked about it to Mr. Agelis, but it was very difficult for him to integrate it into what is being written as regards reimbursement of drugs, because it has not been standardized. But this is a dialogue that has opened up, and I believe that slowly but surely we are coming closer to this pivotal point where demographics are changing, and very soon we will have people aged 65 and above being the majority of our country. This creates new needs, and there we need to expand the territory of our hospitals with applications like Ecothen, with applications like drugs at home, and not obsessively cling to the silos of the sanctity of a hospital. As I mentioned this morning, 50% of our citizens need to change their geographical department in order to find treatment, and transverse 150 kilometers to get to a hospital. Very often we consider assessment as what the patient will have to say about what has happened to them after they crossed the doorways of a hospital. But what happened before that? We've mentioned that there is an entire pathway, and the patient needs to navigate the entire health system. Lots has been achieved, thanks also to the Recovery and Resilience Fund. But it makes sense if we capitalize on a financing tool. Makes sense. Imagine if there was money available and we were unable to absorb it, or if it was other countries that got those funds. We've been through such times where Europe was channeling funds and we couldn't claim anything, or we claimed those funds and unfortunately they were misdirected, as has been revealed in the recent scandal that I don't want to go into details about. Now, there are people objecting and speaking of breaking down the walls of hospitals, meaning breaking down hospitals, but we need to go beyond that. We need to move beyond that, and it's good to take that into consideration. Let's conclude this panel with Ms. Kani with a final comment. After I congratulate you once again, I truly believed in this project from the very beginning. I discussed it with colleagues from abroad, and to them it seemed extremely costly, and they said you would never be able to send drugs at home. But there we go. Yes, it is a very demanding, a very challenging project, but slowly we believe that these services will start existing and being offered throughout the world, because digitization allows us to come up with solutions for patients that are remotely situated. Always when we are shaping strategies, especially on a European scale, there need to be three pillars: availability of the drug, which means incentives for the government, for the state, so that there is no shortage of medication. So a drug needs to be accessible. A drug that is amazing but not accessible to the patients, this has no interest whatsoever, no benefit whatsoever, and this could be due to the fact that those patients are far away from urban metropolis or a city, or it could be for other reasons, financial and what have you. And then we have HTA and negotiations, and now I would like to mention something. Next week there will be an announcement regarding the technical assistance that we received on for this reason. For the first time in the framework of this pilot, we took into consideration patients, and they had an institutionalized part to play as regards assessments, assessors, and of course what they felt should be included in a clinical evaluation. And to us this was very important, because in very simple terms, as somebody said before, I am a patient, I might not know technically what is the efficacy of a drug, but what I do care is to have good quality of life and, of course, to be part of my social network without pain. And this was crystal clear throughout all replies that we got from the patients. And it's extremely important because this can push clinical data towards providing us with these kinds of answers. Thank you for this comment. It is true that whenever we conduct a patient's preference study, we tend to see what patients will choose to do when you inform them of what each entails. As Hippocrates said, we do not cure diseases, we cure people. And we have been living the era of individualized medicine for years now, more than a decade. So introducing this to the discussion is important, and given that the recipient, the state, has matured and it is willing to open up dialogue and include more participants, we see how patients can be trained to become patient experts and invaluable allies to the entire endeavor. So, we are closing this roundtable on time. Thank you all very, very much for your excellent remarks and comments, and thanks to all of the audience for your attention.
Ευχαριστούμε πάρα πολύ τους ομιλητές του τραπεζιού που μόλις...
Thank you very much to the participants of this roundtable that has come to its conclusion, and we're moving on to something very interesting. I would like to call upon Ms. Stavroula Droufakou, a medical oncologist in the General Clinic of ESO and member of the BOD of Exercising Medicine Greece, to come to the stage so that she can moderate and invite all participants to this round table.
Καλησπέρα σας και από μένα. Θερμές ευχαριστίες στο Διοικητικό Συμβουλίο της ΕΛΛΟΚ για την τιμητική...
So good afternoon. Thank you to ELLOC for inviting me to moderate this roundtable. I believe it's going to be a very interesting discussion. I would like to invite the members of this panel, Ms. Eleni Deliopoulou, Art and Culture, Head of Art and Culture with ELLOC, Mr. Konstantinos Kaposioras, Consultant in Medical Oncology, the Christie NHS Foundation Trust, and Mr. Konstantinos Tsilidis, Epidemiology Professor in the Health and Epidemiology Lab of the University of Ioannina. So today we are discussing innovation, care, efficiency, and all these aspects are linked to a drug about which we will be talking today, a drug that is free, has no side effects. We've been discussing it for at least a decade, Mr. Leopoulou and Mr. Kapatanakis. But the last couple of years, we've had scientific data that is quite impressive and has established the role of this drug in oncology. As you have probably understood, we're talking about physical exercise and the impact that it has on cancer patients and on survivorship. I have just one slide that I want to share with you and say that randomized clinical trials regarding physical exercise in cancer began back in the middle of the 90s. If you look at the first interdisciplinary consensus statement was publicized, you will note from the American College of Sports Medicine, you will see how randomized trials multiplied by 300%.
Και θα σας παρουσιάσουμε πάρα πολύ ισχυρά δεδομένα.
So we have very strong, very powerful data to present to you. And we decided to have small presentations from each and every panelist and then hold a discussion. So we will start with Mr. Kaposioras, who will be addressing the benefits of exercise in cancer patients being treated under treatment. Good afternoon. Thank you for the honorary invitation. Thank you to ELLOC. Thank you to Mr. Kapatanakis. I only have 6 slides to present to you, trying to summarize the importance of physical exercise, not just for the oncology patient, but for society as a whole. The World Health Organization presented data 2 years ago saying that 500 million people will suffer chronic diseases if health policies do not seriously take into consideration physical exercise and the reduction of physical inertia. This has a huge cost on national health systems, $300 trillion by 2050. 30, excuse me. You heard how these parameters can be improved by former panelists with a very simple intervention called physical exercise. Unfortunately, however, when we look at data, we see that only 50% of the countries has a national policy for physical exercise. Only 30% of countries has guidelines on physical exercise for all age groups, and including ages below, people below the age of 5. This is something missing in the policies of health and physical exercise. Another thing that is missing is the individualization when it comes to exercise for the various age groups, toddlers versus adolescents versus adults. And then we know with cancer patients, for example, that they are more susceptible to developing diabetes mellitus, or other cardiovascular diseases and other comorbidities. And let us not forget that the older we get, the more susceptible we get, the more prone we get to both accidents and reduced quality of life. And this is something that physical exercise can improve. Now, as regards physical exercise, we see that there is an improvement of the state of health for the person that performs exercise, both preoperatively and postoperatively for people that undergo surgery. And this has a direct impact on lowering the cost of hospitalization. And when we look at chemotherapy, immunotherapy, or any other systematic treatment, we see that physical exercise reduces stress and depression. It increases the quality of life, especially when it comes to women having faced breast cancer. Here we have an overview of guidelines regarding the type of physical exercise. We have aerobic exercise versus anaerobic. You see the hours, the minutes per week, and there was the challenge study, which was very important for colorectal cancer, and this has also looked into physical exercise. And then we have the American Cancer Society that also claims how important it is to continue physical exercise prior to and post-treatment. And recently we had a publication of this algorithm when it comes to CRC. Physical exercise is part of the treatment pathway and management pathway. But how can it be done? The patient needs to be informed from a specializing healthcare professional. There needs to be a co-decision made in between the HCP and the patient in order to draft an exercise routine. What is most interesting for our discussion is that when it comes to health policies, there needs to be a willingness to invest on this aspect, because physical exercise is both prevention and treatment. It is the best drug we have. And now the floor goes to the next panelist, Mr. Tsilidis, and then we can continue with our discussion. Thank you.
Mr. Tsilidis will talk about the benefits of exercise on the reduction of risk for recurrence vis-à-vis cancer. Good afternoon from me too. I would like to profusely thank you for the invitation. I've been a researcher in the realm of cancer epidemiology for about 20 years, but only in the past few years have I started working more closely with patients. And this has both improved the quality of research I do and the sense of contribution, job satisfaction, the sense of making significant effort that will lead to improvement. So I hope to enhance this further with this presentation and with the collaboration with the Hellenic Cancer Federation. I'll talk to you about physical activity and how it is related to outcomes following cancer diagnosis. I'll start with brief statistics, mainly to show you the importance of research in cancer patients, especially lifestyle, and how it can have an effect on cancer outcome. We know that there's been an increase in cancer incidence in most countries worldwide. You can see a number of countries since the 1970s and up to 2022. You can see the different percentages per country in both men and women. And we have an increase in cancer rates. We have data from the UK. All cancers in the same period of time, 1970 to 2022, all cancers, with few exceptions, have had gradual annual increases in their incidence, with two main exceptions: lung cancer and bladder cancer, where we see reductions because of the reduction of smoking prevalence in the UK and other Western societies. If we were to look at similar data from less developed countries, the increase in the incidence of cancer is far more dramatic. And fortunately, this increase in cancer rate will continue in the future in both men and women, men on the left, women on the right, in all continents, as you can see on the x-axis. In the graph, the most impressive increase, more than 100% from 2022 to 2025, will happen in countries that now have relatively low levels of cancer. For example, areas of Africa and Asia, but will also see an increase in both North America and Europe. So, all in all, we'll have more patients diagnosed with cancer in the years to come. This, in conjunction with the fact that we have improved survival rates for cancer patients, means that survival rates have doubled in the last 30 to 40 years in all Western societies. For most cancers, lung cancer, esophageal cancer, and pancreatic cancer have not had very good results. But in the years to come, we'll have more patients surviving their cancer. And it's important for us to have research data supporting patients and cancer survivors, support related to heart outcomes or diagnosis of primary cancers that may appear in the future. So in the next few minutes, I'll present to you some basic results regarding physical activity and how it relates to outcome following cancer diagnosis. I direct a big program at the Imperial College of London in collaboration with the University of Ioannina. So without further ado, you can see data from a meta-analysis, which is in fact a summary of many different research studies trying to correlate physical activity following breast cancer diagnosis in women to all-cause mortality or mortality specifically from breast cancer. On the left, all-cause; on the right, breast cancer mortality alone. On the x-axis, you can see the amount of physical activity from 0 to 50. I'll explain how we measure. And on the y-axis, we can see the risk of death. Here, the risk is less than 1, which means that we have protection. Physical activity protects against future all-cause death or death specifically from breast cancer. And this risk is linear and continues from physical activity 0 to physical activity 20. 20 denotes 20 METs, metabolic equivalence, which is translated into 20 minutes of intense physical activity every day or 40 minutes of moderate physical activity every day. The reduction of risk in these 20 METs reaches almost 45%, and these are levels of death risk reduction that even the best drugs we have cannot achieve. Going on, apart from reduction of survival, excuse me, says the speaker, the opposite. We have more data, as Mrs. Drufako said, from studies showing improvement of quality of life. Physical activity improves cancer patient quality of life. Here we are talking about breast cancer patients, shown in the graph, and we have improvement both of total quality of life and QOL related to emotional functionality and mental health. Going on to large intestinal cancer, we have strong data, similar to those of breast cancer, showing what you saw before in the dedicated breast cancer graph. Even little physical activity improves the likelihood of survival. And if you can actually reach 20 metabolic equivalents, we have again improvements in survival that reach 45 to 50%. We have data for other cancers as well, fewer than those for breast and large intestinal cancer. But these data prove the same point as well. Before I finish, I'll show you at a glance the latest big study published a few months ago. This is a clinical trial, an experiment on people. In effect, researchers used patients with large intestinal cancer stage 2 or stage 3, and after agreeing to participate in the study, the patients were randomized in 2 groups. The group that received physical activity interventions for 3 years, plus behavior modification support, and the second group of patients that just got some recommendations for good health, but did not receive the intervention of the first team. This is not an easy trial. It's a trial that started in the year 2009 and was completed in 2025 with the publication. It lasted for more than 15 years. There were 900 large intestinal cancer patients included in the study in a physical activity program that lasted for 3 years. 900 patients from 55 centers globally, mainly located in Canada and Australia, but many other countries participated. And it was shown that this physical activity intervention plus the behavioral change program led to an all-cause death risk reduction by 37% and a reduction by 28% in the risk of dying from large intestinal cancer. So in conclusion, physical activity has an anti-cancer effect. It seems comparable to many of the established cancer treatments we use. There are many oncotherapies that we use that have a far less pronounced effect. Physical activity does not only constitute a way to improve the quality of life and the mental health of cancer patients. It was something that we used to believe up until recently. It is a treatment and a cure for cancer, and it needs to be prescribed for cancer patients. However, this knowledge in itself will not change people's behavior. And health systems and governments need to invest in holistic programs in order to support behavioral modification that leads to increase of physical activity. And before I conclude, in collaboration with ELLOK and with fellow researchers and MDs on the panel, today Mrs. Droufaki and Mr. Kambosioras, in unison, a few months ago, we set up a study that shows physical activity recommendations made to patients and implementation of these recommendations. If you'd be so kind, please fill in the questionnaire. You can take a photograph now, please do, and 10 minutes suffice. You can fill it in, or you can forward it to your friends and acquaintances, or if you're MDs, to your patients, so that they can fill it in. Thank you very much.
Πληροφορίες για αυτή τη μελέτη θα βρείτε και στο...
There is the QR code and info for this study on the ELLOK site. Please fill it in only once. If you haven't filled it in already, please do. Thank you very much, Mr. Tselidis. The challenge study that Mr. Tselidis presented was the beginning for new guidelines by ESMO, whereby finally oncologists are asked to prescribe exercise as a drug. If they don't use it, it's wrong, it's malpractice. And To make a summary for the most frequent forms of cancer, I don't know if you agree with me on that, Kostas. Cancers like those of the breast, the large intestine, and the prostate, data that are not prospective, randomized, but they are prospective observational from very big studies that the group of Mr. Tsilidis has carried out, and meta-analysis show reduction of death risk of 38% and 20 to 30% reduction of the risk of recurrence with only 30 minutes a day of moderate physical activity. It is a very strong drug, as I said before. It is for free. You could start it at any given moment in time, and it's side effect free. Mrs. Deliopoulou, we'd like you to share with us your experience through ELLOK, your personal experience. Thank you very much.
Καλησπέρα σας.
Good afternoon. I would like to thank the excellent panelists for the very recently acquired knowledge they shared with us, and of course the moderator of this roundtable discussion, Mrs. Droufakou, whom I hold in great esteem. Not only for the 10 years we've been together in ELLOK, Mrs. Droufakou, I remember you 18 years ago when I heard you speak during an oncology conference, corrects the speaker. And back then you talked about the results of certain studies carried out by Harvard. And indeed, I was speechless back then. I couldn't possibly have imagined that so many patients like myself back then would be initiated in the world of exercise. It was 18 years ago, and I remember your precise words whereby if exercise were to be prescribed, there'll be people queuing up to reap the benefits, and it was 18 years ago. This would be the most frequently prescribed drug in the world, and at the same time, a yoga trainer, meditation trainer from Australia had come, and in a contact that we had come from for some programs from Alma Zois, the Thessaloniki branch where I come from, said the same things. And this was an opportunity for me to hesitantly start exercising because I had never done it in the past. I started doing a little bit of walking, thinking that interval exercise would be beneficial. Let's see now what we do in Hellenic Cancer Federation in practice. It's not a study, it's what we do in practice. We heard the speakers say that physical exercise has a very important effect on both prevention and prevention of recurrence. So, we thought about starting and launching a program, Movement for Life, or Physical Activity for Life. This is now in collaboration with Medical Oncologists Organization, and indeed, it needs to be supported because we patients actually marry medical oncologists, and you know that, I suppose. They need to promote exercise because the benefits are so important. So, physical activity and a right diet play a critical role in the management of side effects and treatment and the reduction of the risk of recurrence. Physical exercise works miracles for the mood. It reduces stress and improves quality of life. There is no specialized program here in Greece dedicated to cancer or cancer patients. And in this program that we launched and systematically run from 2023 to 2026, more than 450 patients participated. I'd like to say that this program is online. And this is the case because many cancer patients are not members of an association. They may live in a remote island or a remote area, and in their pajamas they can actually work out, exercise and reap the benefits that we mentioned. Some of the types of exercise can be seen in the last program that we adopted in 2026. Yoga, meditation are recommended to cancer patients. I would like to say that most instructors are experienced and skilled, and they know about medical exercise. We started working with a yoga instructor 18 years ago, and we still work with her. You can see the different kinds of exercise. Here I would like to kindly ask medical oncologists to ask ELLOK to send them this poster so that they can have it on the walls of the hospitals, because even if you attract one patient, this will make a significant change in their lives, and according to the testimonies that we have, patients are very satisfied. Here I'd like to say that last summer, before we closed for vacation, the online patients asked us to have a live session, to record it so that they could take it along and use it during their holiday. Here you can see our instructors who invite us to take part in different fitness festivals. You can see a small group that took part in such a festival in a summer camp. Our voices must be heard everywhere, because we represent a great number of people. And here I'd like to tell you that we created the ELLOK team that participates in the marathon race. There is no age limit. It all boils down to willingness and mood to participate. I'd like to encourage you to participate. All of you, you should know. So, next year, participate in the race. It's very important. The enthusiasm and the joy that I cannot convey to you, but I feel it because I participated for the 6th consecutive time, and I really enjoyed it. And let me tell you that I'm 72 years old, and I dared do this, and I will dare to do this again. And I'm saying this to encourage younger people. So following what our great speakers said about the benefits, I'd like to condense them in one line. We have strengthening of muscle mass and reduction of fatigue, important reduction of pain, improvement of the cardiorespiratory capacity, reduction of side effects of chemotherapy, hormonal therapy, positive effect on lymphedema, improvement of sexual dysfunction, reduction of risk of disease recurrence, mental health, reduction of stress, depression, improvement of quality of life. And through the holistic approach to health, we timely shape a new culture of prevention starting at a young age. And this is what our country lacks, the culture. Thank you very much.
Ευχαριστούμε πολύ, κυρία Τελειοπούλου. Η άσκηση προκαλεί εξάρτηση.
Thank you very much. I believe that exercise is addictive, but this is an addiction that we would be more than keen on developing. Congratulations on the beauty of ELLOK. As a member of the board of Alma Zois, I would like to strengthen you to the best of our abilities, increase such actions so that they are open and accessible to as many people as we can. Unfortunately, we don't have any more time for this to continue this discussion. We could continue it on a personal basis. Let me conclude this roundtable by saying that we need the state to stand by us so that we can truly implement all that we are talking about. So we need health policies. We need cities that are friendly to people that wish to work out, to exercise, that have pedestrian routes that are safe, that have parks, the opportunity to prescribe physical exercise to people who truly need it for free. Let's not forget that therapeutic exercise protocols have already been translated from the American College of Sports Medicine. They have been submitted to the Central Board of Health. They have been approved by it, and we are now awaiting their implementation. And let's not forget that knowledge is not enough to change our behavior. Sometimes it also requires counseling, and I dare say that we need to demand access to such counseling via the national health system. We want that to be prescribed as well, because benefits can be multiple. To prevent a metastatic disease means enormous reduction of costs and expenditure on behalf of the state in treatments, drugs, and anything that comes along with non-prevention. Thank you very much for your attention.
Δεν έχουμε πριν το κλείσιμο ή μετά το κλείσιμο, έχω και φωνή δυνατή. Να πούμε ότι μέσα σε αυτό το πρόγραμμα θα έχουμε και κάποια...
Let me just say that there will be some webinars down the line in the near future that are now being prepared, and we want people like you who are keen on staying informed to participate so that we can inform patients as much as possible. Thank you. Thank you very much for all the interesting concepts you put forth. Let us move to the next roundtable on palliative care. I would like to invite our own Ioanna Karavana to come on the stage and moderate this roundtable.
Καλησπέρα. Νηστάξαμε.
Good afternoon. I hope that people are not feeling tired or sleepy. Well, we heard about the benefits, the advantages of physical exercise. How much physical exercise have you had today? You worked out this morning, Eleni. Good for you. But all of us right now, we're kind of spend our day sitting down. So let's get a couple of minutes to stand up, move around. This is the last round table, and I'm very, very happy for this round table. And also for the object that it addresses, the subject that it addresses. We are the final ones, and we can use this to our advantage. I can invite Ms. Kyriaki Mustakidou, professor of the Faculty of Medicine of the National Kapodistrian University of Athens and head of the Palliative Care Genicaresi unit. Mr. Andreas Charalambous, former president, former chair of European Cancer Organization, professor on oncology and palliative care. Mr. Christos Leonis, general medicine and primary health care professor at the University of Crete. Mr. Ioannis Boukovinas, medical oncologist and head of the oncology unit of Bio Clinic in Thessaloniki. Ms. Aliki Tserkezoglu, a gynecologist, oncologist, and licensed in palliative medicine, head of the palliative care unit Galilea, I envy you. I only wish that every city, every coin and corner of the woods called Greece had a Galilea unit. And I would like to also invite Mr. Nicholas Philippou, Executive Director of the PASICAF, Cyprus Association of Cancer Patients and Friends. I would like to begin with Ms. Kyriaki Mistakidou. Could we look at the state of play, the current state of play, as patients? As a patient and as an active member of this movement, I need to say that we are all hugely and vastly confused with the terms. Although I'm a great fan of the Greek language, I'm very confused because you doctors like to play with words. So we've got palliative, two different words for palliative, and then we've got supportive, we've got end stage, end of life. What do the terms mean? First of all, allow me to thank ELLOK for the honorary invitation, and I would like to thank the members of the board, the other members of the board. This is a topic pertaining to the terminology of palliative care, and trust me, within the National Committee of the Ministry of Health, it was so difficult for us to decide as to the terminology that should prevail. We chose the terms ανακουφιστική φροντίδα for palliative care because we felt that it best describes what is offered, a comprehensive care to chronic patients. The previous term, as Mr. Babiniotis has said, who was the dean of our university, was more about compassionate, and it was showing compassion without really meaning it, and this is why we decided to stick with palliative care as ανακουφιστική, which includes the notion of relief. So palliative care is about how we can provide comprehensive care to a patient suffering chronically with a life-threatening disease. And this is due to the fact that there's lots of patients that are not on their way to dying. We also have survivors. We have patients that can live for long years without, but also require palliative care. Comment off microphone. Yes, first of all, let me go back to the history. Palliative care, officially speaking, began back in 1992 in the University Hospital of Aretaion with a department dedicated to palliative care. And then a few years later, we formed Galilea it was mostly for cancer patients and ALS patients. And we also created a body that included patients both at home and in hospital settings or clinic settings. And we created Merimna, which was for the pediatric population. And there were huge efforts underway before we managed to institutionalize palliative care. We struggled a lot until we reached in 2022 the point where the law on comprehensive palliative care in our country was actually passed. And unfortunately, all aspects of this law have not been implemented yet because there are structures that are required. We need to educate healthcare professionals so that they can staff such structures. But with lots of hard work, we managed to have this law come around, and there is also a presidential decree and a national action plan that also provides for the needs and types of units required in our country, and I'm hopeful that very soon we will see them materializing. Okay, I will be the Debbie Downer of this panel. Let me just remind everyone that may have forgotten that there was a bill of law. Do you remember the date? December 23. Almost Christmas Eve. It was at the time of the pandemic, and we really toiled in order to have that bill of law pass. And we worked extremely hard for palliative care to be recognized and institutionalized. And I'm hopeful, yes, I am hopeful that we will see it materializing pretty soon. And it's not just about the legislative framework. All associations dealing with patients, all organizations out there need to work in the direction and push for the creation of these structures, of these units. This is exactly what we're all doing, and towards the end I will share some news on behalf of the health region. Now let me ask Mr. Haralabos, what happens in Europe? Are there any best practices that we could implement in our country? Thank you very much for this opportunity for me to convey the conclusions that the European arena has reached as regards palliative care. What I should mention is that the European effort for palliative care began back in 2003, where the ministries decided, the Council of Ministers decided that palliative care should be equitably accessible in health or national health systems. It needs to be integrated also legislatively, and it needs to be reimbursed, as is the case with any other care provided. It is one of the most sensitive problems that health plans are faced with to this day, because palliative care is not considered part of the health system, but rather an additional service. And this creates a chain of problems to the patients requiring this kind of care. Some best practices as regards integrating palliative care have to do with healthcare professionals involved in palliative care. We need an interdisciplinary team here and not a multidisciplinary team. Those who are in the audience probably know of how these two teams are different and provide different services to patients. Could you please elaborate on that? It's very interesting. Interdisciplinary approach is not a steady team, a constant team, a permanent team for patient treatment, or it's a tailor-made for a patient. It's a dynamic team that is established based on the needs, and there is no hierarchy within this team. At the heart of this team, we find the patient, the patient's needs, and the patient's family. There are various models of palliative care. These models also need to be adapted to the needs of the patients. There are some models that are based on hospices. There are some models based on community centers, some others on day hospitalization centers. Or not all models are suited for all patients. There needs to be an adaptation, and there needs to be a grading system. In a certain period of time, we will need model A, then following period of time, we will need B, model B, but there is no strict sequencing to that. For all of the people involved in palliative care, we share the feeling that home is the best site to provide palliative care. And as Mr. Kidou said, palliative care needs to also be supportive care. And as such, it needs to begin as of the day of diagnosis and evolve along with the evolution, the progression of the disease. It can evolve in terms of increased needs on behalf of the patient, or these needs may decrease. And this is precisely what the supportive care and palliative care should follow, the example set by the patient. Could you tell us, very briefly, I mean, you've heard all that has been said so far, you know the state of play in Greece. Could you share something that could be implemented in Greece but doesn't require unlimited funding? Any practice from abroad? Listen, palliative care is a way to improve quality of life of the patient and their family. Supportive care is not just about drugs. A person is not just about the body. It's also psychosocial. So with limited resources, with limited services, we can support this patient, this individual, so that throughout their journey of their disease, they can feel supported and sufficiently, adequately supported. That is very hopeful because we do not have unlimited funds, but there are lots of things that we can do, and this is something that needs to be visible, that needs to be heard, that the state needs to delve into. Dear Mr. Leonis, there's a study that I believe you contributed to that looks into the dignity of an individual towards the end of their life. I love the term dignity. As a patient, let me say that we fight for our dignity throughout our life, from the beginning, the onset of our disease, and all the way until the end for the people who do not share our lack, the lack of all of us being present here today. Thank you very much. Thank you for the invitation. It is truly a pleasure for me to be a part of such a panel with such esteemed panelists. I was asking myself, why did they invite me? Many years ago, in a team of British, Greek, Cypriot colleagues, physicians, practitioners, we worked on supportive, compassionate care, lots of different versions, and we tried to include that in what was taught to in pre-graduate curricula, not just for the sake of the patient, but also in order to make the healthcare professional happier. So we're working towards documenting that such an intervention on behalf of the healthcare professional does not just provide relief of the pain, it makes the healthcare professional happier as well, which means that he is at lower risk of becoming a patient himself or herself. Now, this is a concept that is impossible to demonstrate scientifically, as is the concept of suffering. Suffering is about more than physical pain. It's also mental pain, emotional pain. intellectual pain, and we're working on the concept of suffering as the starting line, because very often medicine emphasizes the onset of the symptom. However, it would appear, and this is the most contemporary, the most modern approach, that a problem with a patient sets on when suffering increases, and all of a sudden we've got chronic stress and inflammatory disorders. So this suffering is not just about underlying conditions, it's also about feeling frustrated, feeling like our dreams are slipping through our fingers, and this suffering is part of our approach. So within this framework, and based on a long experience as people working in primary healthcare, we realize that primary healthcare is not at all involved in pain relief. And when we speak of pain, and this is precisely the amazing approach by Viktor Frankl, and I would urge all of you to look him up if you're not sure. He is a psychiatric and neurology professor, unfortunately deceased, in the Vienna University, an Auschwitz camp survivor, and he said that the person is a mixture of the body, the mind, the central nerve system, and the spirit. And he argumented that suffering, wherever that may be, before the end of life or in the anticipation of the end of life, should not be part of the thought of the treating physician. The treating physician should consider how to direct the patient, the suffering person, in finding the meaning of life. And if the treating physician, the healer, one would say instead of the doctor, could truly find a way, it would be wise if they could talk to the patient and say, yes, your life, it's not about finding the meaning of life in general. Your life has purpose. And this purpose very often is cut short because of cancer. And we've been discussing with ELLOK, do we have a purpose? When we see a patient whose life expectancy and survival expectancy might be measured in months, does it make sense for the healer, for the therapist, to talk about the meaning of life? And it would appear that the answer is yes. And it is truly an art when the healer is able to bring this forth with the patient. And so 4 of us from Cyprus, we sat down and we thought about the need to talk about the direction that physicians should follow in primary healthcare, because they do not come across the people who are to die, so that in those moments they can attribute meaning to their lives. And of course we borrowed lots from our colleagues when we thought of palliative care, so we ended up writing an article that we published in the Academy of Health and Well-being, and we highlighted the interventions that can be achieved in order to change the behavior mentality of healthcare professionals in primary healthcare. It is true that we have very few randomized controlled trials, and where do we see those taking place? Always within the primary healthcare system. We see that not much is achieved, so we need new thoughts, novel approaches, new interventions, so that primary healthcare professionals can truly contribute in providing relief to the patient, relief from the pain, from all the existential, psychological, emotional, mental issues and concerns and troubles that can arise. And I would like to speak of Professor Ziraki, who coordinated an important team of colleagues during the pandemic, and they wrote an article saying that, yes, palliative care is part of the health system, and I believe that this is an immense challenge. And I'm open to speaking again with a second comment, should time allow us to do so. He's always fascinating, and he's truly amazing. I've always felt like a student when he speaks. So now, moving on to Mr. Bukovinas. People who know me know that I've got a DNA which is anti-private sector. Not when I was a patient, when my father was a patient, people who know me know of the story, and he was at the end stage, the only space where, as a family, we could do something for my father in Larissa, it was not in Athens, was in a private psychiatric clinic. It was the only space that let my dad, Miltiadis, in. My dad was fully alert. He died fully alert of everything that was happening, and it was his decision to discontinue the treatment that he had been on for years that was no longer beneficial, but it was depriving him of his dignity, and he had ended up weighing 45 kilos. Still, the wrong private sector space, since it was a psychiatric clinic, helped us out. So, Mr. Bukovinas, what can the private sector do?
Although our identity is not defined by where we work, this is what I believe, I'd like to ask the audience a question, because we've been discussing palliative care, we experts, quote unquote, but how many of us, had we been patients, would accept having to be subjected to palliative care? It's not easy to tell Greek society that this is the point where treatment stops and palliative care starts, because one needs to combine in their minds two things. The prudent therapist or healer or doctor on one hand has a biology of a disease, and on the other hand has the narrative or the biography of a patient, and we need to combine them. What we call palliative care in English has been defined at the beginning because it enhances diagnosis. In large intestinal cancer, for example, it has been shown that when we have supportive methods, palliative care, we have improvement of survival, especially in survival curves that talk about survival but not mortality, unfortunately. Yes, to palliative care to begin with that plays a supportive role, but when we reach the end whereby treatments decrease and the status of patients gets worse, there we don't treat patients well. We stab them in the back many times using words and expressions that are not right and not undertaking the responsibility of therapeutic care. It is precisely that gap that the bill is trying to bridge. I don't know when it will appear in practice, but I'll tell you how palliative care is linked to daily medical care of people. There needs to be a treatment team, the one that is responsible for the treatment of the patient, and at the same time, at a second time, towards the end stage, another team consisting of other colleagues, other specialties, interdisciplinary team. Mr. Haralabou said it exceptionally. Mr. Leonis talked about the spirit, hope, and dignity, setting a different tone. So these people will lead a patient to the end of their journey. Kafka used to say that it's far easier to prescribe drugs than be by the side of patients, and this is what happens in practice. They'll be given relaxants, painkillers, but the important approach will be lacking. There need to be regular sessions every week. The resist the prey instructions in the latest film of Gavras, the director, unprecedented film. Palliative care is precisely as it is described in this film, and this is what we want. And of course, this calls for funding, considerable financing. This necessitates awareness raising, sensitization of people, information of all healthcare professionals, oncologists, surgeons, gynecologists, primary healthcare physicians. How many of them really know palliative care? For this purpose, we need intercomplementarity between public and private sector. When Mr. Leonis was talking about public health, he was not talking about the public health system. It's much more than that. Let's not forget that apart from the psychiatric clinic, all initiatives for palliative care have come from the private sphere or non-state system and not the public system. If we exclude the home care that has been evolving lately. In an effort we made in Salonika, northern Greece, to do something more, we have trained some people in that domain, sending them abroad, both doctors and nurses, and hesitantly we've started an effort that includes home care, not only tantamount to distributing drugs, but doing whatever it takes for the dignity of death. There is an awesome paper dating back to 2005 in JCO. Mr. Leonis, you know it, I trust. And there we have the patient narrative laid out. What are you proud of in your life? What is the purpose of your life? What would you like to leave behind as a heritage? All these things are important. We have a small experience of about 50 patients. Fewer than 10% of them died in hospital. This is very important. They departed at home because this is the purpose, not to have them die in hospital, which is something that necessitates financial analysis in the field of public health. So this complementarity can play a role in innovative actions, awareness raising, even information and briefing of healthcare professionals. If you look at the proposal of the Stavros Niarchos Foundation, there are very few departments of undergraduate education in Greece dedicated to that sector, and they have to do with very few specialties. So there is room for great improvement. Thank you very much. Sometimes I sound a little bit more abrupt when I speak, but we've celebrated 10 years of ELLOK's existence, and I believe that you stand out, and I believe that the way you speak is outstanding. You pointed out something important to my mind. Many doctors may know, but there are no referrals. There are pain relief centers at the University Hospital of Larissa. The vice president of our association just so happens to be an anesthesiologist. She's running the department as a volunteer. This is a big originality. We have volunteer centers and offices in university hospitals. What can I say? This is a Greek originality. referrals are not made. We know this firsthand. It's difficult. Please, I'd like to repeat what Mr. Haralambou said. It's very important. Society needs to identify and reimburse these activities. So we need a DRG for palliative care, be it related to home care or the overall intervention. Without a DRG, an official one, everything is in the air. So it has to do with the income bracket of the patient and, of course, the voluntarism of people. You are right, we can agree more. I'm not glad, but I'm smiling because we need to keep on smiling, I suppose. I can't see far, but I can detect your shape, George. We are the last one, so we can afford to be late, I suppose. We envy Galilea. I mention you very often, and as we say in Greek, you must have the hiccups, because in Greece we say that when somebody is talking about you, you have the hiccups. So you must have the hiccups, I suppose, because I keep saying, if only we could have the Galilea. But please tell us, what are the challenges you're faced with? There are challenges, I suppose, and problems. It would be interesting to hear about them. I would like to thank the BOD very much. I'm glad to be with you. And I believe that I'm given the opportunity to share a personal story. For the past 16 years that Galilea has been in existence, and 3 years prior to that, when we were trying to organize the services, I believe that when we first set foot in the Ministry of Health in 2013, we got an NSRF fund back then, in the years 2013 to 15. You know, of course, that these services are not reimbursed. So they were trying to pin us down. Ours is not primary healthcare or secondary healthcare or public health. And they were saying, you know, there was a law in 2003. Now this is under the umbrella of the Ministry of Labour or Welfare. When we knocked on their door, they hadn't heard of anything. They said, you give people opioids and drugs, so you can't be under our responsibility. We've come a long way. We worked under the radar regarding the institutional framework that we lack in Greece, but I believe that this experience has been important for me, and I find excuses for the state and certain gaps. At first, we didn't know where we belong. In 2016 to 17, when the Stavros Niarchos Foundation started this initiative, the Ministry of Health said that they should look into the matter so that we could start working, thinking that this had to do with health. But the Ministry of Social Cohesion and Family that we now have has everything related to welfare. Welfare regards caregivers, many teams of chronically ill persons. They fall within the framework of another ministry. Now, long-term care is what should be done according to a directive. And indeed, the Ministry of Social Cohesion and Family has issued a very good strategic framework that will be financed, I think. Palliative care is part of that. Everyone in our country do their own thing. Palliative care, mental health, hospitalization at home, or rather care at home. Look how many things exist in common. It's so difficult for our country to organize. These ministries are all line ministries. They need to come to a mutual understanding and coordinate. They don't only have medical services reimbursed with DRGs, they have the holistic care. So there needs to be a team reimbursement. And we are not familiar with the notion in our country. There needs to be a reimbursement both in hospital and the community. We don't have a developed primary health care that should undertake the task of general palliative. We've been doing both general and specialized palliative care in the area of Mesoia and Lavriotiki here in Attica. Everything should be examined under the umbrella of long-term care. For us to have legislation, reimbursement, organization, to see to it that we don't waste money. Long-term care, approached in a uniform way, But let us say something else. We had a license for help at home from the Ministry of Health. It went to the Ministry of Labour and now the Ministry of the Interior, because now home care is under the responsibility of municipalities. So it's fragmented. It's difficult to tackle. We opened the hospice, working illicitly, as we said at first. But the state has now come to embrace this effort, making an effort. The bill is tabled. The presidential decree and the regulatory provisions will need at least 3 to 5 years. I don't want to disillusion you for us to say that someone can go to the region and say, I want to develop such services. Larissa, central Greece, really wants that. They'll work under the radar, like us, I suppose. Crete is very willing. We lack the institutional framework. These people cannot be fully lawful. But I need to say, talk about good things. Last week, with an amendment in the law of 2022, Galilea is the first unit that received officially the identity of palliative care in the country. We can go to the fire brigade and say that our building is a special building, but then we need the Ministry of the Environment to work out specifications. So it's a long way. Both reimbursement, buildings, municipal waste, infections, you name it. It's multifaceted and complex, but we need to have a single approach. Mental health, long-term care, hospital at home, NOSPI, as we call it in Greek as a program, palliative care. It's one and the same thing for patients. We are talking about the same patients, the same caregivers. So, as a state, we need to examine all those things at the same time in unison to have a solution at a moment in time.
Sometimes I think that reality comes before legislation, and sometimes it's the other way around. It is true that in order to meet a need, we have to identify the need, detect it, and understand, all of us, to what extent each and every one of us is responsible for bridging this gap, for meeting, filling this unmet need. I have the impression that up to quite recently, our country, and guess that this is not the case among all Balkan countries who suffered more financially speaking, and they did have such structures. In Greece, there was always the mentality that this is something that we need to address, an invisible force of people. But it's true that not everyone has a family, not everyone has a support network, not everyone has bills that are paid, a house, a roof above their head, and a heating system that works. So there is a change in the recent years, and that's what keeps me smiling. I would like to add something that's quite optimistic, quite hopeful. Galilea, I believe, has proven that such services can be established in Greece, because this is all things that need to be adapted to the culture of each particular state. We cannot simply transplant the model of another country. In France, with more than 1,700 deaths, 50% were not hospitalized, and 40% death happened at home, because that was according to the decision and the wish of the patient. Thank you very much. Mr. Philippou, can you share with us what happens in Cyprus? Of course. I would also like to thank ENG, ELLOK, my friend Yorgos, Marina, and all of you, of course, for staying with us until this moment. And I can see that you're actually paying attention. So it's a huge burden, because I want to add, I didn't want to just share numbers about what happens in Cyprus. I want to add to the discussion. And I will draw my inspiration from Galilea, Pasikav was a similar example 25 years ago. We were able to prove that where there is a need can be met. We know that it requires a multidisciplinary approach, a holistic vision, and palliative supportive care. I believe we all agree on this, needs to be fully integrated into the therapeutic aspect. We need referrals from our doctor from day one of the diagnosis. And this team needs to map the needs of the patient, the needs of the family, so that they can manage the crisis that comes with this diagnosis. Welfare state aspects. I've got with me my colleague Ioanna, Artemis, a clinical psychologist, a physician, Mr. Stylianidis. All of us will look at all needs holistically, comprehensively, and we draft what we call an integrated treatment plan. We manage side effects of the treatment, we manage anything that we can, we support both the patient and the family of the patient with tangible projects. And we don't stop that at the end stage, because there is also a part that is called managing loss, managing mourning. There is managing the differences that cancer brings into everyday life during treatment, pre-treatment, post-treatment. And we work in this integrated framework. This was the vision of our director, Miss Anna, 40 years ago, and she said, that's what we'll do. We'll hire the first physician, the first oncologist, the first psychologist, and we will use whatever financing we can get our hands on. And it's only in the most recent years that we are discussing palliative care in legislative terms when it comes to the Cypriot Parliament. But palliative care is already reimbursed for cancer patients, and this is a success story for us. We fought for the rights of these patients, and we have managed to accomplish some innovative steps. The organization itself recognizes the integration, the concept of integration, and raises quality criteria. And among one of those quality criteria is accreditation and certification, and the organizations that will get accredited will also have increased reimbursement based on that criteria. And we all know, as regards comprehensive cancer centers and organizations under the International Society for Quality of Health, or the Accreditation Canada, when it comes to cancer centers, they require that palliative care is an integral part of the services provided before they provide certification. So in Cyprus, we have two NGOs, the Cancer Association of Cyprus and the Association of Friends of Cancer Patients, with two centers, one in Nicosia and the center under Pasikav in Larnaca with 15 beds, and in Paphos, Archangels Michael, with another 15 beds. We lay emphasis a lot on home care at home. And if we were to state figures, we take care of more than 3,000 patients at home as Pasikav. Our doctors, our nurses visit our patients at home. We've got psychologists providing socio-psychological support, even in the case of loss, at more than 2,500 people per annum. We have clinical dietitians and nutritionists that provide nutritional support to more than 200 patients. We've got drivers that are part of our team because they transfer, support patients on their way to and from cancer centers with specially designed vans. And within our centers, we have 150 healthcare professionals working for PASICAF right now. And setting numbers aside, I believe that the true success story of PASICAF and the indicator demonstrating the quality of what PASICAF does is the fact that we manage to control the pain, the suffering of our patients. We have made it so that a daughter, a son feel peace because they know that they will not stand alone in taking care of their parents. We have patients that receive care within the warmth of their home. We have a mother that managed to attend her daughter's wedding. These are all examples that showcase the added value of what we do. Now, as regards innovation, there's definitely a need for more tools like IPOS, capitalization on the data that is all available that will allow us to schedule things much more in a much more organized and improved way. And another thing that is very important to me is the participation of healthcare professionals in palliative care within multidisciplinary teams that are formed in cancer hospitals and that have a decision-making role. And I would like to come back to primary healthcare, which is a sector that plays a very important part because we see patients with lots of comorbidities. And it's very important at this stage to well coordinate between the various teams of specialists. And this is something that the primary healthcare can provide along with others. We have a red signal with numbers, but honestly, this has been read almost from the first 5 minutes that we've been on stage. No, I refuse to listen to it. It goes red, it goes off. Mr. Bukovinos, honestly, I haven't seen it green for 1 single second. I protest. But it is red. So I will hand the microphone to all of you so that you can say whatever you feel like saying as a closing remark. Thank you. I would also like to add a few things as regards palliative care needs. I heard closely to all the other panelists, and according to our experience, what we've seen throughout the years, because we have provided care to more than 6,500 patients, we have assisted close to 80,000 family caregivers. They had psychological support from our team, but via our multidisciplinary team, of course, because it's not just about drugs, it's not just about psychological support, it's also about all those adjuvant treatments that allow a patient to feel that they are retaining their dignity, that they still have a voice, that they are still alive, participating in life. That's the most important thing. But what we have identified throughout those years is that the earlier on we introduce palliative care, because very often I hear palliative care associated to end-of-life stage. As soon as a patient comes to us, alongside the treatment, in tandem with the treatment, there's palliative care support offered. And this has also to do with the psychological and physical side effects. And this is very important for the patient. And this allows us to prevent lots of things that under different circumstances would accumulate in advanced stages. It's a lot easier to support the patient if you meet him or her at an early stage, and if you help the family understand what is coming. This is the most important aspect, because in advanced stages of the disease, because up until then there was treatment, you're going to be fine, you can understand how bad, how horrible it is for a patient. If you come to them and say, okay, listen, we're done with the treatments, go that way, because now there's something else around the corner. So we should not associate palliative care with end of life. There should be a palliative care representative participating in the team from day one of the diagnosis, of the treatment, be it for the physical side effects or the psychological side effects of the treatment and the disease as a whole. I believe that all panelists focused on the goods of palliative care, but there is the other side of the coin, the dark side of the moon as well. If we do not offer palliative care services, then people start contemplating euthanasia. And palliative care, or rather the lack thereof, can lead a person to thinking of dying as early on as possible. They despair, they feel that they are a burden to their family and loved ones, and the only way out that does not require treatment, that does not require support, is what? Death. Thank you. I apologize, but I need to say something. There's lots of ethical dilemmas when we get to that point. It's a completely different roundtable. And look, we would love to talk about that as well. It's a more advanced and more sensitive topic. So yes, I think that lots has been said that's very important. I would also like to underline and stress the need for this coupled care. And I would also touch upon something very important that we talked about in our publication. There's little interest on behalf of healthcare professionals, especially physicians, and I'm not talking about those that will specialize in palliative care, when it comes to palliative care and all that it entails. On the other hand, second thing that I would like to mention, there's also great criticism that health systems are becoming less humane and that physicians are becoming less human. And it is very often underlined, especially in our country, that compassion fatigue and burnout are huge topics in Greece. So at some point, we need to make medical faculties responsible and accountable. Because if they manage to convince everyone that palliative care provides support to the healthcare professional as well, we will have won a huge challenge. We need to look at the humanistic aspect, because palliative care brings relief to the healthcare professionals, but also to the health system. Because, Mr. Bukovinas, you wanted to say something nice? Well, to me, I'm not sure if it's nice, but it's definitely important. We need to raise awareness throughout the society. People do not know what palliative care is all about. Here we are among people that know what the disease is all about, but when it comes to a person becoming a patient, palliative care is filled with gaps. And it's about culture. A culture, a mentality that we no longer have to the extent that we had in the past. In the Black Sea region, Pontiacs, instead of saying, I'm dying, would say, I am complete. That is how it translates. And this is what we need to focus on. We need to have a complete health plan that from the very beginning and all the way up to the completion of the human being, it will include all the humanistic aspects that Mr. Leonis mentioned. And it's not just about ideals, cultures, mentalities. It is about how while we live, we learn about death. I had no idea that at the left is I'm complete was from Pontiac Greeks. I thought it was an ancient Greek saying. Maybe we should upload this article. It's truly impressive because I feel that in this type of medicine, of care, we are reminded of humanistic values that we tend to disregard. Mr. Filippo, the floor is yours for the time being. Okay, I would just like to say that we are the Cypriot Association of Cancer Patients and Friends. We started 35 years ago with a small experience on cancer, and now we also provide services of palliative care, along with everything else that we do and provide. So it is something that can be done. We may have provided services to more than 8,000 people per year in Cyprus, but what we have seen is that we needed to walk into the home of these people, feel, experience their needs, their wants, that in order for us to realize what palliative care means. So start as of yesterday with a nurse at the home of a patient. In Cyprus, we're fighting hard for the Bill of Law to pass because we're fighting on a front which is extremely sensitive, the pediatric palliative care, a huge discussion that could perhaps be the subject of a round table. Okay, all associations, have you heard? We're all here. Start with a single nurse and a psychologist. Start. Mr. Kezoglu, I apologize, but I left you as last speaker because I truly feel strongly about Galilea. What I would like to say is that we need to fight together. Palliative care is a journey for the beneficiaries, a journey for those who are willing to stick around and provide it. It is an experience, and that's hard to explain. And Mr. Leonis spoke of not individuals, but persons, people and relationships. Galilea right now is a member to 4 European projects. We're preparing a petition to enter a 5th, and it has to do with care for the carers, for the caregivers, for their burnout, for their needs. So join us in these efforts.
Και φτάσαμε αισίως στο τέλος.
And we have auspiciously reached the last part for today's discussions, and I'd like to invite to the floor Mr. Nikos Mariatinis, who was with us throughout the day, and I could see him attend all the roundtable discussions with great attention. So I would like you to please conclude the day and share with us your conclusions. My God. Rescued by a hair's breadth. When we are in Brussels and Luxembourg and we finance actions and projects, we know that something is happening. We are making a contribution, but only when we come and actually attend such congresses, we can realize what we can achieve. And I have certain thoughts that I would like to share with you. First of all, the level of discussions, very high indeed, both in terms of technical contents and in tension sometimes. The British have a nice word, engagement. There is engagement and there is passion galore, and this is very important. The same discussions have been taking place throughout Europe. Nikolai Bocharenko and Mr. Van der Bulken mentioned it. Perhaps not in the same spirit, but the same discussions. The challenges and the problems are known, and the point of reference, of course, was cost, as it's everywhere the case. It's all about the money, but I believe there were important arguments about the fact that health expenditure is an investment. Health is wealth. And numbers were mentioned, and I believe this is what rendered the argument quite convincing. Now, we have a time junction that has positive and negative attributes. There are pressures from the other side of the Atlantic, pressures for the pharma industry that will undergo major change because there are pressures in the US that have an effect on the drugs that Greek citizens will receive, but health and life sciences constitute a sector where Europe has a comparative advantage, a competitive edge, cohesive health systems. We don't like them, we complain, we lack this or that or the other. But in Europe, we do have national health systems. You should know that they don't exist in many other countries. They exist in certain countries like Canada, perhaps, or Australia. But they are not omnipresent. So we do have an infrastructure to build on. You talked about time. Time in the sense of every day that counts for the patient, and time in the sense of timeliness. Now the time is ripe. So we want speed and we want to seize the opportunity. Greece is definitely at a turning point. I was the young manager of a cancer comprehensive center 25 years ago. There are certain things that we still discuss because important decisions have not been made, mainly regarding the finances of health, not only cancer, but many things have happened. Mr. Nicolaou condensed them quite significantly in this session. A lot has been done. You can build on that. Whatever Europe can give you through joint actions, as I said this morning, is topical. We are ever willing to give you the deliverables that we already have. This is an opportunity for the economic and social dividend of a national field for cancer. We'll need trade-offs, of course. Who will pay the cost? But compromise is part and parcel of political decision. Politics is the art of the feasible. It's up to you to identify the trade-offs that will move the system forward, but definitely something can be done. And to use a sports shoes slogan, just do it. Voila. Said Mr. Mariatidis, Head of Sector, EU for Health Grants on Cancer, NCDs, Mental Health, Rare Diseases and Health Workforce. We'd like to thank you very much for summarizing the day in this excellent way. I'd like now to call to the floor the representatives of ODP, Mr. Kapetanakis as well, because we'll have the signature of a memorandum. ODP, which is the Agency for Quality Assurance and Health. Please, today we'll sign 2 MOUs. Today is the day when we'll talk about the 10 years celebration since the establishment of the Hellenic Cancer Federation as an official body. So 1 MOU will sign with the Organization for Quality Assurance, and the second one with our brothers and sisters from Cyprus and PASIKA, that is a Cancer Patient Association of Cyprus. We want these moments to also signal a moment that is important for us. I'd like to say that we've been working with Mr. Fireos and Mr. Nestoras, who are here with us from the Agency for Quality Assurance in Health, ODP. In the past years, the organization has changed the way in which we see many things. We talk about procedure, standardization, safety and quality standardization. We are talking about concepts that have become everyday lingo, and this we owe to you, to ODP. We all want to endorse these initiatives. We want to work together. We want to work in the framework of some programs that will offer what the health system, patients, and every stakeholder needs. And the same applies to systems of support, of course. And it is with this thought and the collaboration of these many years that we'd like to talk about and make everything official by signing this MOU. Would you like to say a few words? This MOU that we'll sign is not just a mere formality. Our strategy is about building strategies with patient associations, and we want all this to lead to the creation of procedures and standards. So with the Hellenic Cancer Federation, ELLOK, what we want is to gain something from your experience. In the strategy of ODP, we have this NOSPI, that is the hospitalization at home, which is funded by the Recovery Fund. We would welcome your proposals, and the leadership of the Ministry of Health and myself are, of course, willing to enter into research programs. My uppermost concern as an advisor of the Quality Assurance Agency, ODP, is to establish a process for people with cancer. We want your experience because the system we've been trying to promote is patient-centered. So I'm very glad that we are now officially launching this collaboration, and we'll be by your side should you need anything at all. Thank you very much. But I omitted to ask our board of directors to please come. If you'd be so kind, Paraskevi, Maria, Angeliki, Dimitris, please join us because we'll be signing an MOU. We are the hosts. I forgot to do this at the beginning. I apologize. So let us all be here for the occasion. Lefteris, you'll say a few words as well. Thank you. We thank you very much for the honorary invitation and for the beginning of this collaboration. I believe with the introductions of both Mr. Kapetanagis and Mr. Nestoras, a multi-annual collaboration with ELLOK will now be sealed with an agreement in order to do two things that lie in the heart of the conference and what it is all about: building bridges, having patients at the center. We have started actions with your participation, like hospital care at home that Mrs. Tserkezoglu is involved in and honors us with her collaboration. Care, the patient path, starting from prevention, early diagnosis and long-term care that we lack. And what was emphasized in the previous roundtable discussion, connection with primary health care, which is not just care, formal care, but gistful care, and what was accentuated, community-based actions provided in a fragmented way under the responsibility of different bodies and ministries. And I believe that after the excellent previous discussion that focused on what was said by our panelists, talking about the person, and I believe that starting from the Philoctetes of Sophocles to the death of Ivan Ilyich of Tolstoy, we need to focus on the person that suffers. So the path of the oncological patient is important. Irrespective of the way in which we approach quality, practically we are talking about a culture of measurement. We measure our performance to grow better, and we compare ourselves to others and mimic best practices and good examples like those from Cyprus. Thank you very much for the opportunity.
προσκαλέσουμε τώρα και την κυρία Χιλεούδη.
Let's also invite Ms. Hileoudi and Mr. Filippo to join us for the signature of the second MOU. What can one say about Passikaf? We've been collaborating, we've known each other for years, that we usually meet abroad in conferences, and this has been the case with Nicholas for decades now. Maybe we should rather say that what's happening today should have happened years ago, but it's never too late. And thank you for sharing your experience with us of the work that you carry out in Cyprus, which is very important, and of all the efforts in order to highlight and serve as a role model, an example to others, such as ourselves, other countries, such as Greece. Congrats for being pioneers. Thank you very much. It's a great honor to be with you here today and to be starting this official collaboration with Greece, and in particular with Dr. Gerasimus Rigatos. We've got a long-standing story. He was the first to come to Cyprus and help us with the psychosocial service establishment. Then each year he would set up a psychosocial oncology conference, and we had all organizations from Greece, from Thessaloniki, and there was a wonderful collaboration. We had the opportunity to get to know one another, exchange experiences and ideas, and of course, had speared the establishment of this association because circumstances in Cyprus were dire in terms of the stigma, the bias, the medical community, the physicians. So a small team of us, we decided to set up this association. Initially focusing on changing the mentality of people, the culture, fighting stigma, and creating, of course, establishing better conditions. So we needed a linear accelerator that needed to be imported. I was fortunate enough to get my treatment abroad. I'm an anesthesiologist, and I knew what happens abroad. I saw babies being treated with a ruler instead of proper medical equipment, and all these experiences helped me look out for colleagues that stood by me. Of course, there was resistance. Let sleeping dogs lie. That was the mentality at the time, especially as far as cancer was concerned, but we persisted and we created the Oncology Center of the Bank of Cyprus, a wonderful center with specialized medical oncologists, fully equipped. And of course, nowadays there are other centers and Lemons and centers are popping up all over the place. And of course, our goal is to establish a cancer institute in Cyprus that will oversee all individual efforts and will also control who does what and how. That is also important. And I didn't want to speak long, but we also established psychosocial support teams, and we came across patients that were not doing very well, and we needed to support them as well. Everything was out of our own pocket. It was not on a voluntary basis. Voluntarism is great, but it cannot have the impact that we were looking for that easily. So I did some upskilling and retraining abroad as regards pain management, palliative care, so that we would know what we wanted to head towards. In the beginning, the director told me, "We've got no money." And I answered, "It's your job to come up with money. If you do not grasp the bull by the horns, if you don't take life by the horns, then you will not move forward." And of course, each district has a different system, but I believe that teams at their core can work together, gaining funding, financing, but also helping each other for the benefit of the entire system and landscape. Now we have reached the point where we are running 2 hospices. There are 2 hospices in Cyprus. 150 villages are serviced. Of course, Cyprus is a smaller country, perhaps easier to implement things in it compared to other countries. So thank you very much. I don't want to tie you any further. George, I think that for the past decade we've come across one another all over the globe, not just with George, but with other fellow travelers. You were also pioneers when you established ELLOK in Cyprus. We don't have a similar association or federation. I apologize for interrupting, but I wanted to say congratulations for establishing the federation. Now we are setting up a federation ourselves in Cyprus, and I'm so pleased with the wonderful work that you have achieved so far, so God bless. It is true, you have done excellent work. As I've mentioned before, we came across one another all over the globe, all over the place. We helped each other out. We shared knowledge regarding national policies, palliative care, cancer strategies. So we're very happy to be here with you today and very, very happy to be signing this MOU that will help us launch joint actions. I am convinced of that very, very soon. I would like to say that Cyprus and Greece are siblings, and very often you are our source of inspiration, and we can only hope that sometimes we can be your source of inspiration. But it is true that between us there is a form of communication that goes really deep. Europa Donna of Cyprus is amazing. Alma Zois has begun a collaboration back at the day when we had Ms. Kyriakido at the helm. And now, as ELLOK, we are signing an MOU with Pasikafe. I think it's very important, and it demonstrates all that binds us together.
Λοιπόν, Μαρία.
Και μετά τις...
And following the signing of these two very important MOUs, we can begin the final part of today's session, the anniversary celebration. I would ask the members of the board to sit down. We have some videos that we will be showing on the screen. You can sit down here, or I think we should invite Zoe, Eleni, Ioanna, and Apostolos. Please join us here. We also invited Katie, but unfortunately Katie would be unable to join us. Here we have all the members that have been members of the board ever since ELLOK was established, was founded. And I want us all on stage because we've all been part of the decisions made. Let's hope that we have sufficient chairs. Please be seated. Go on.
Λοιπόν.
Μία θέση θα αφήσουμε, πηγαίνετε όλοι πιο εκεί για να έχουμε και τη Μαρία. Όχι, δεν θα διαβάσουμε τίποτα. Πάμε μια θέση πιο εκεί όλοι. Ωραία. Μαρία.
10 χρόνια πριν.
10 years ago, a team of people from 17 cancer patient associations felt that cancer patients in Greece need to have a voice, not a fragmented one, not a whispered one, but a united, strong, demanding voice. ELLOK was born out of a vision, out of dedication, but primarily out of solidarity. Today we're not just celebrating an anniversary, we're celebrating a journey. They changed the way we speak, the way we demand, the way we exist. So now let us have a swift glance backwards to all the milestones, the moments that turned into milestones of our joint history. So let's have a look at a short video. Unfortunately, videos are not translated.
Κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην ελληνική όμως...
You can't refuse anyone the right to hope. That's why the Hellenic Cancer Federation, we are fellow travelers with people suffering from cancer because we empathize, we co-create the framework and work together with all competent bodies so that they have direct access to early diagnosis, psychological support and a smooth comeback to society and the workplace. Supporting people. Find out more in ellok.org. We remembered, we traced back the steps, the path, successes that we take pride in, everything we've managed together, and ELLOK is tantamount to its people. The people who have been contributing throughout the years, time, energy, and frequently personal cost. Since we have the BOD of ELLOK here, I would like to address certain questions to all the members so that each and every one of them can make a statement, and I'll start with Zoe. Could I? Why? Could I interrupt you? Thank you very much, says Mr. Kapetanakis. Excuse me for this. It was something spontaneous. I'd like to say a few things. This very nice flashback video, I hadn't seen myself, indeed. Very nice. Fellows, indeed. And our team in our office curated this video. Maria, the art director, and all the other guys that will come here for you to see. Excellent colleagues who help bring this to fruition. And of course, all of you who've been supporting this effort with your presence, your contribution throughout the years, helping us in whatever we try to do, joining your voices with us, expressing your opinions. So thank you, a big thank you from us to you for everything we've done together. But I'd like to say 2 or 3 things. As Katie would say, had she been here, everything started in 2011 with the Vivica. And she would like to say it, and I am saying it for this purpose. Indeed, we needed a dedicated association that needed to assume a specific shape and form. There were some efforts in the north of Greece, but they lost their orientation. OK, that had been established, could not indeed follow the pace on the needs of time. What they tried to do was stillborn. There was no light of hope. Back then, important decisions were made. Some people helped a lot. And things started in 2016, because in 2016, we had the approval of the Articles of Association, but everything started with the enose in 2015. And the first headquarters of ELLOK were accommodated at the offices of Géphy. We lacked resources, we lacked every basic thing, but we had a vision, and we had all these people who are not here with us today, and we saw them in some photographs. This is what I wanted to say. Many happy returns of the day to ELLOK, celebrating its 10-year anniversary. I don't know if you'd like to ask a question, Maria. Maria, ask the question. I was hesitant to give him the floor because we have a flow, and I want us to be spontaneous, of course, but I want us to keep a certain order. Of course, we were moved. We'll be spontaneous, take the floor, and share. So, what Yorgos said, indeed, was very apt for what will follow. At the beginning, everything was an idea, and then reality came. And Zoe, you were there when ELLOK had to prove that it could stand on its own feet. How difficult was it to establish the federation, and what were the challenges that needed to be overcome? It was very difficult. I was lucky to have met George in OK. It was the first contact that we had back then. We were making an effort to establish an office here in Athens, but the effort did not bear fruit. The great need, in my opinion, came after 2009, when we had the first signs of recession. I believe that this was the first alarm, and patient associations that saw people that were uninsured. We need to say that. There were many people that were uninsured knocking on the door of the association. We were trying to collect medicines. Thinking back to the volume of drugs that Géphy was distributing, I can't help thinking, my God, it's a miracle we did not end up in prison back then. We started knocking on the door of the ministry, sending paperwork, and everything found its way to the waste bin. And so we thought that we needed to do something and organize ourselves. Back then, we had Cleopatra, Katie, Panagiotis, Michail, and we are the associations, and Agalliazo. And we had the Vivica. That was the result of this meeting. Mrs. Galazidou, you were there too. I don't remember that. I notably remember Cleopatra, for all intents and purposes. So this functioned for quite a while, but in limbo. In 2015, we started speaking, and this was important, because united we stand. In 2015, GEFI, the Association of GEFI, was truly willing to establish the federation. So we received funds for pancreatic cancer, and we sent a message to all associations, and we said, we'll cover your expenses. Come to our one-day conference. I think that for that time, this was a big endeavor. Thinking about an association like us, with the finances that we had, to make this proposal, which led to a considerable turnout. And I believe this was the first gathering. Then we organized ourselves better, as Yorgos said. And again, the advice of Kefi, I'll repeat, together with Elisabeth Psilopoulou, whose contribution to finance, because the first ELLOK conference got money from Kefi, from the companies, handled the money as if it were its own money, and it gave the rest to the federation, the money that could be spared. I couldn't possibly have done this myself without Elisabeth, because I lacked knowledge, financial knowledge, to know how the association could cover this. Then I believe that the federation, thanks to Katie, who knew the European market of patient associations and initiated us to that, and we need to acknowledge and give a credit for that. We had the zeal and energy of George, who was omnipresent, with the board of directors that was very supportive of him. But I believe that indeed we need to give credit to Yorgos, George, for the fact that he fought the hardest. And 10 years down the road, seeing him act, going everywhere in Europe, having ELLOK as a member organization for many European programs, many organizations, I believe that without Yorgos and without the contribution of Katie that I mentioned, of course, who was very familiar with things in Europe, ELLOK wouldn't have succeeded as much. I wish Yorgos to be strong and healthy and to be on the go constantly. I wish that the BOD can always help him in his efforts, and all of us, all satellite associations, whenever need be, can assist. Many happy returns to ELLOK, and may your work always be important.
Next question is addressed to Paraskevi. I would like to ask you, behind all the interventions, actions, efforts, persistence, there are some moments that make you stop and think to yourself, okay, it's worth it. Can you share such a moment with us? Not a single moment, no. But I can share some thoughts, some very personal thoughts that lead me to thinking that it's worth it. First, I would like to share a moment I remember in an effort to speak with OK. We split the distance, and along with Nikki, we went to Karavomoulos, precisely in the middle. Katie, myself, Yorgos, I don't remember who else it was. Zoe was the one to drive us there. I just remember the hotel, to be honest. So it was on neutral grounds, so that we could try to work things out. And Fanny, who was Fanny? Comment off microphone. Fanny, yes, right. Okay, so pieces of the puzzle falling into place. So this showed how willing we were to make things happen. We saw that this could not move forward, but we also realized our own willingness to move forward. And I will say something that may sound strange, and it's not just about ELLOK. To me, a very important point in time that brought the discussion to the public sphere as a very important topic was 2021 and the European Beat Cancer Plan. This changed everything for all of us who were advocating for cancer patients. We finally came across a plan where all that we had envisioned was written down, was stipulated clearly, and now the state had a guide, and this is what allowed all the things that we have been discussing to take place. And that was a decisive moment in time for me. And all the work that had preceded that was exactly what indicated that the ELLOK was in a position to advocate for cancer patients in Greece. And I believe that this was the moment where I thought to myself that everything was worth it. And it's still worth it. We're all harassed, all very tired. At the end of this conference, we come here early in the morning, we leave late at night, and yet I feel so good because I feel that everyone who comes here from other cities around Greece come truly happy because they feel that this is a conference for them, and they may nag on their way out that, okay, guys, I'm really tired, this was exhaustive, but I feel that every year more so they leave this conference feeling richer and feeling that, yes, it is worth it, and it is worth all the trouble that all our colleagues in the office take on in order to have this conference happen. Thank you. Let's move on to Angeliki. Participating in ELLOK is not just a role, it is a responsibility to others and towards ourselves as well. What was the greatest challenge that you had to overcome, either on a personal or a collective level, whilst you've been in ELLOK? Thank you for this, Maria. So, participating in ELLOK was never a role for me. It was a decision. It was a challenge, a bet. It was about responsibility and collective effort. I believe that a major challenge for me has always been the human being, the cancer patient, and the care that they deserve to have at this most difficult time in their lives, as well as the rights of this patient. The reason why I am here was the fact, as Zoe very well said it, this person became cost. And along the line, it was more than cost. It was also an opportunity to gain, to grow rich, to build a career, to build a reputation for some. And this was enough for me to participate in this effort. Having been a cancer patient with a metastatic disease, I knew very well what your average patient is faced with. And I wanted to be here because